Good morning. Good morning, distinguished colleagues. Good morning, dear guests. Today is June 6, 2023, and we're starting our 36th International Congress, New Technologies for Diagnosis and Treatment of Gynecological Diseases. The Congress itself starts at 10 o'clock with the opening ceremony, and now we're starting our 36th International course on endoscopic surgery. This course has been on for more than 30 years with my great friends, the best surgeons on this planet, Arno Matias, Philip Connings, Mario Malzoni, Anastasia Rusia, and of course, our great chairman who works with sutures, Armando Romeo, who will deliver a suturing course. There will be live surgeries during this course. Live surgeries from Dubai, performed by Arno Matias, a live surgery from Italy, from China, and this course will be full of wonderful surgeries and wonderful presentations. So I do not want to waste any more time. I'd like to say that my family also helps me, as well as my surgeons, my staff, and my students. I'd like to introduce some people who are here in the hall. Edik, please come here. Please come here. Girls, where are you? All right. So, this is my family team working with me. Also, my staff at the Kulakov Center, and of course, a wonderful team from RIA Novosti agency. It's like Channel 1 of the Russian television. We work for Russia, we work for other countries, and there is translation into English. Thank you so much for being with us. And today, we have Arno Matias, who is on the air, Philip Connings, and the entire team will be here soon. So I'd like Arno Matias to start, because today he will have a live broadcast. He prepared the case, and we're going to see a live broadcast. And then Philip Konix. Arno Matias, please say a few welcoming words, and what are you going to show us today? Arno, the floor is yours. Good morning, Arno, can you hear us?
Yeah, good morning, Leila. Good morning, everybody. Good morning, Philip, as I just see you. Yes, Leila, this is the fourth meeting in June that we do online. And I think there are the positive way that we do it, the negative way that we are not together to share more closely our friendship and our experiences. So I hope, I know I tell that every time, but I hope that next time we can be together, and at least if Moscow stay, let's say, closed for us, at least you can come in Dubai, visit me, as we do many times, and we have good time. So thank you for your invitation. As you said today, you asked me to do an hysterectomy, just to start with, to establish for the course, let's say, to talk about basics, because we are going to talk about energy, we are going to talk about suturing, anatomy. So I mean, what best that to do, I hope, a simple case to be able to show some anatomical landmarks, as we call here, that guide you, your GPS inside the pelvis, to optimize your surgery, to reduce the risk of complication, to increase the speed of surgery and to make you, as I said always, a predictable surgeon. So this is the goal of today for me. I have planned the case starting, as you asked me, at 9 p.m. Moscow time, which will be for me in 50 minutes. So the patient is ready almost. The anesthetist will put her on sleep in, let's say, 15 minutes. So the time we set up everything, and as I know that we should be finished on time by 10 a.m. your time, we should be finished this hysterectomy within 1 hour or less. So this is the goal of today, and I hope that people will enjoy. Thank you for the invitation.
Thank you very much, my dear friend Arnaud Vattiers. I always tell everyone that this course is super elite, superstars, great people. All of my colleagues are great surgeons on this planet, and not just surgeons, they're also philosophers, creators of different devices, creators of different schools, creators of different directions in medicine. They work for one purpose: surgery for health, surgery for quality, surgery for the sake of life on this earth, and surgery for the sake of children, for the sake of happiness. Thank you, Arnaud. I would like to ask Philip Konings to say a few words. Dear Philips, goedemorgen, good morning. Please say a few introductory words for our colleagues who are here this early morning. Philip, please. Philip is a philosopher, by the way, a doctor, a surgeon, an OBGYN, the creator of a new direction in medicine, treatment of adhesions, lasers, reproductive medicine, minimally invasive gynecology. Philip, the floor is yours.
Thank you, Leila. Thank you for the invitation. Thank you for, do you hear? Thank you for being here. It's we do regret not being in Moscow. We are coming since 20 years. It has become part of my life, and we have done a few things together. And in the past, this was about adhesions. This was about people from Moscow who are coming to Belgium and to do research. And the very latest thing we did together, I'm going to explain this afternoon, this is the importance of experience, experience-based medicine, which is the complement of evidence-based medicine. And when I heard Arnaud saying a few minutes ago, I'm going to explain how to do in order to speed up, in order to have less complication and so on. I think this is exactly experience-based medicine. And this kind of sharing experience is what I always liked so much in the congresses you organize. Thank you for that, Leila.
I would like to say that at this Congress that we organized this time, there will be 60 surgeons, the stars of world medicine, 8 plenary sessions, and each name mentioned here, each presenter is a great surgeon from the United States, Canada, Belgium, England, Italy, France, the United Arab Emirates, China, Japan. Well, most of the countries will be presented here. Dear Philip, we're starting our course. Armando is not here yet. Armando? Not here yet, okay. So before Arnaud starts his surgery, please, who would like to say some other welcoming words? Anything about our course? Any other considerations? Arnaud? Philosophy or Philip? What's the philosophy behind all this? Anyone, please. Before we start the surgery, Please, if Armando here, Armando can start the suturing course. Armando is not here yet. He hasn't connected yet, right? If Armando is not with us, I would like to give the floor to Arnaud Vatiers or Philip Konings. Could you just say a few words about the basics of the endoscopic surgery or surgical energies or the philosophy behind surgery? Anastasia, I can see you. Hello, Anastasia. Anastasia, would you like to say a few words? All right. Please unmute yourself, Anastasia. Say hello.
Hello, everybody. Good morning.
Anastasia, say a few welcoming words to our participants.
Yes, yeah, dear Leila, I am very happy to be with you in this meeting, as usual. We are, and I'm only in April, not in Moscow with you, but my heart is there, and I wish for you, for all the participants, this meeting, to enjoy the meeting, and it will be a success as usual. Good morning, Philippe. Good morning, everybody.
Good morning, Anastasia.
Good morning, Arnaud.
Arnaud, would you like to say a few words, or maybe we'll give the floor to Philip? Yes.
Armando, I tried to call Armando, but he do not answer to me, so I don't know where he is. I think that
It doesn't matter. Если Филипп хочет сказать несколько слов, я дам ему возможность после того, как скажу.
I have to prepare to go to the OT. Just before this, I would like to share with you one slide. So I will share my screen. Okay, I will share my screen. And the slide I want to share is this one. This one that represents 50 years of laparoscopy. And for the people in the room, I think if you look, the dynamics of this line is very interesting, because you see, let's not go too far away, but let's go to the 70s. You see that the first ectopic pregnancy has been done in 1973 by a guy called Hubert Manès in France, and I must say that every reason that were there to start ectopic pregnancy by laparoscopy were wrong. And so it means that this is very important to understand that when we started in the late 70s, early 80s, laparoscopy was not considered to be a surgery. And why? It's because we were not reproducible. We had no techniques, neither strategy, neither tactics. And we had to wait the first hysterectomy done by Harry Rich, that has been one of the leader of this course. We have to wait this 1988 that Harry Rich did the first hysterectomy to demonstrate that we could, by laparoscopy, we could recognize better the anatomy and the tissue. We could control better and safer the artery and the veins, and we can act on it. And so that has been a revolution. And this revolution, and after this revolution, you see from 1988 until 2005, all indication in gynecology has been shifted to laparoscopy. What is interesting, so now you say in the early 2000s, all the field was covered, 100%. We are 2023 now, so we are 20 years later. And what happened in these 20 years is we didn't improve technically, we improved the technology, but we did not improve technically. And we see that, you see the red dots on the left part of my slide. We see a lot of warnings coming. And you remember the warning for the morcellation, the warning for the meshes, and lately the warning for the laparoscopy in oncology with the LAC study. Those warnings come 20 years or 30 years after the start of the technique. That prove that if we do not teach people, if we do not use what Philippe say, some experience-based improvement, and mainly also some evidence-based improvement. So I think evidence-based medicine is possible. Evidence-based surgery has this particularity to introduce a bias which is difficultly blinded. So just these few words before I give the floor to Philippe to explain that despite the fact that now, you see the color of my hair, and I remember the first time I came to Moscow, I was a very handsome young boy. Now I am I am an old crocodile, and despite that fact, we are still here to promote, to develop, and to diffuse minimal access surgery, but not only for Occidental country, but all over the world. And I think that this is very important to address, as well as the concept of being sustainable, not only for ecology, but also for our patient. And this is what we are going to discuss during this day. So I finish my few words with this. I will go to the operating room and I give the floor to Philippe. If I can stop.
Дорогой Филипп,
Dear Philip, dear colleagues, not a single surgery can be carried out without the use of energy. We know. Sorry, we have no sound. Sorry, the sound is gone. The mic is not on.
Can I start?
дорогие
Dear colleagues, we had some problem with the sound. Any surgery is impossible without energy. Energies that we have are surgical energies, bipolar, monopolar, laser energy, mechanical energy, and I would like to ask Philip Konings to say a few words about energies used in laparoscopy. Dear Philip, well, before Arnaud Batias starts his live surgery, please start your brief presentation on energies. Philip Konings, energy in laparoscopy, please.
Good morning. This is one of the first things you have to know about endoscopic surgery. This is energy, and more specifically, electrosurgery. That's one of I like about Sun Tzu. Strategy without tactics is the slowest route to victory. And Arnaud is going to explain you strategy, because tactics without a strategy is the noise before defeat. Energy is all about temperature. And these are the basics you have to know. 60 degree, you start tissue damage, 80 degree coagulation, 100% boiling. If you boil it slow, you only have the water gets away and you leave the solids. If it's very rapid, then you get some kind of an explosion and you take away water and solid. And when you have more than 300 degrees, you get this carbonization, this black charring tissue. Second thing, what is important is the time of contact. And if you take the contact for more time, it goes deeper and deeper. Electrosurgery equipment, you all know. You set a watch and you have the effect. You put it at 30 watts, 35 watts, and you have effect force 1, force 2, force 3. But let me explain what it means and why you have to do this. Electrosurgery is high frequency alternative currents, because if you have below 50,000 hertz alternative current, you get depolarization of the cells and you get this kind of an electric shock. The basics of electricity, alternative current, is the peak voltage and the frequency. Peak voltage is the highest voltage you have at some moment. So this compared to a waterfall, the intensity is the voltage divided by resistance, which means if it's higher, this is the voltage at that moment, and you have a lot of water, you have a lot of intensity. If there is a resistance, then you have less water. So that's very simple. These are the basics. The second, and this is the only second formula you have to know, is that watts is intensity times voltage. And this means that you can have a high amount of energy with an intensity which is low and high voltage, or you can have the same amount of energy with a low voltage and a high intensity. So that's very clear. This is like a waterfall, and this is the voltage. This is the effect. I explained this in a second. The watts is the maximal watts this machine is going to allow to have an output. And intensity, where is the intensity? Well, the intensity, that's the surgeon. This is the contact area. So these are the device settings. You set your voltage, this is the force. You set your maximum watts, which means resistance. Resistance is not there in the formula because it's wet tissue, and wet tissue has almost no resistance. Intensity is contact area. If you have a very small contact, there's little intensity. If you have large contact area, there's a lot of energy. So it's the surgeon who is going to control the energy you are using. One of the important concepts in surgery is the isowatt curve. It means that you can have the same energy with high voltage and low intensity, of with low voltage and high intensity. This is the isowatt curve. Show you in a second how you use this in surgery. So in practice, you're going to preset your watts and your voltage. This is the setting of the machine. So that if you have a very small area, you're only going to use a tiny part of the preset maximum energy you can have. So if you have a larger contact, you are going to use more, and you use this until you use all the energy. And if at that moment you still increase the contact, and that's why this isowatt curve is so important, if you increase the contact, you're going to decrease the voltage. This, I think, is one of the basics of electrosurgery, with a small contact area, low intensity, and only a fraction of the preset watt is used. Which means whether you have with the needle electrode, you put 30 or 300 watts, the setting, this is exactly the same effect. On the other side, if you have a large contact area, you have a high intensity, and if the watts intensity times voltage exceeds the watt setting, you have lower voltage, and you change how the tissue effect is of your electrosurgery, which means that 30 and 300 watts have a very different effect. I always like to show this again because I think it's the basics of electrosurgery that you grasp this well. The second thing you have to know about electrosurgery, this is the magic limit of 200 volts. Below 200 volts, you have no sparks. Above 200 volts, you always have sparks. And you see, if you have higher voltage, the spark is a little bit different. So cutting is sparking, which means that you have a bistoury is going to have contact over his whole area. That's why you need enough voltage. The needle electrode, you have a very small contact. So in bipolar cutting modes, above 200 volts and above and 35 watts, and that's what I think Arnaud is going to show you in a second in live surgery. If you have a very small bite of superficial, at that moment you use very little of the energy and you are going to have a spark. If you have a big bite and full contact, you are going to use a lot of energy and you drop the voltage. He is going to use this on the left side of the curve, small bite, superficial, just to have few spark to the peritoneum. And then he increase a big bite, can open, and then you have coagulation, which means that by contact, changing the contact area, you change your device from a cutting to a coagulating instrument. Maybe you ask yourself, but why does a spark cut? Why you need a spark to cut? Because a spark is this 1 millimeter or small, very small spark, which is at 2000 degrees Celsius. This is plasma in the air. And this 2000 degree makes explosion, superficial explosion of the cell, which means that if you have 200 volt, just enough to have a spark, and a needle electrode, you have exactly the same effect as with the CO2 laser, which means superficial vaporization. If you have a big contact, at that moment you are heating the tissue, and you heat, let's say, proportional to the distance. The farther away, the less heating you have. This is why slow heating goes deeper than fast heating. So this is the second, and I would say, important slide. On the left, with a big contact, you have soft coagulation. On the right, and this is when you have sparks from 200 onwards, 200, you have pure cutting. And then when the voltage increases, the higher it is, after the spark remains energy. And this energy is going to heat the tissue, which means that this is what they used to call blended curve and mix it. You have cutting and coagulation. So the effect cutting and coagulation is only a study of voltage. It also means when you have an electrical bistoury with the small area, the sharp side, you have sparks, you have small contact. So on your isowatt curve, you have a high voltage and you cut. The flat side, you have a large area, large intensity, and you drop your voltage. So by playing with your area of contact, you can manipulate your voltage and the tissue effect. You see this 200 volts, 400 volts, 800 volts, you have already coagulation. All this is very well known. You can manipulate this, and this is, I would say, the details. You can manipulate intensity and voltage independently because the same effect can be given by continuous current or an intermittent current with high voltage, so you can deliver the same amount of energy. In soft coagulation, the longer it takes, at some moment, you get this kind of heating, it starts boiling. And this is important to grasp, that the air is something what is limit the intensity of electricity. And that's why, for instance, if you have this kind of transport of electricity, you know this everywhere, this is because it's isolated by air, and these cables are not isolated. It's a vapor which stops the coagulation. And because the vapor stops, which means that if you go slow, it takes more time before you get vapor, so you coagulate deeper. This is the principle of soft coagulation and the principle of all coagulation. And bipolar coagulation is just the way the electricity goes, and it is all altogether exactly the same as with monopole. Stopped by vapor. Conclusion: the tissue effects varies with the voltage. A high intensity is fast cutting and fast heating. Choice of the surgery is how to use the cutting and how to use coagulation. Vapor stops coagulation, slower is deeper. So this is basically everything of electrosurgery. The watts is only a safety procedure, which means that if you only have 30 watts, you cannot use 50, which means that if you have an accidental movement, you are not going to cut a big area because at that moment the voltage has dropped. Coagulation of bigger arteries, these are few things I would like to explain. Since the flow through the arteries, you get cooling. That's why when you want to coagulate an artery, in principle, you have to stop the flow. And the way to stop the flow is turning 90 degrees, you stop the flow, and then you coagulate better. Capacitive coupling is something you have to understand in order to prevent mistakes. If this would be the trocar is in metal, and if the screw in the abdominal wall is plastic, isolates, then you get the effect that you have transmission of current without contact. And it's very clear if this is a big plate, when one is positive, the other is negative, and when one is negative, the other becomes positive, which means that the in electricity can go through it, but without direct contact, which in all, let's say, modern bathrooms is used in order to prevent electrocution. That's why metal trocars, when they are isolated from the skin, they are going to take up the energy, the alternative current of the electrosurgery instrument, and they can burn a bowel because they have exactly the same effect as the uh, instrument itself. Classic reason for accident, what they call capacitive coupling. So if you do not want to have accident with electrosurgery, avoid capacitive coupling. Of course, avoid insulation failure. And if there is a direct coupling, this is a mistake. This is another way of the right below of capacitive coupling. You can, if the scissors have this kind of electricity, and if you make a contact with your other instrument, you can have the other instrument which starts to burn. Few tricks. These were the tricks of microsurgery. If you have continuous irrigation, you are not going to have spreading of temperature left and right, and it limits the temperature to 100 degrees. You only are going to coagulate in between the two bipolars. You use this in egg white, you are going to see that you have just a coagulum between the 2 points of the bipolar and never nowhere else. So this is this kind of preventing diffusion. And then you have the little tricks. This is the semi, pardon, this is bipolar cutting. If you open the jaws of a bipolar a little bit, at that moment, you get a spark between the two electrodes, or between the electrode and the tissue. And this is what you're going to see in order to perforate the peritoneum. You do not have contact between the two electrodes. And when you come close to the tissue, you have a small spark. If you take a big bite, at that moment a voltage drop and you get coagulation. And this is the semi-bipolar, which is used in hysteroscopic surgery. Fulguration is a totally different story. Fulguration is conventional. Let's say all electrosurgery, cutting is fulguration, but fulguration with air. If you have a flow of argon, this fulguration is much more directed, is much more superficial, and that's why you have this kind of argon fulguration devices. And then you have the intelligent devices. And you have the PK device, the ligature. In fact, it ties down to measure the temperature and the steam. And the nice thing, this is where you, with the PK devices, when they steam, it means it gives ting ting, and then the noise change, so you know it's well coagulated. Ligature is another story. It mainly controls the temperature to 80, 85 degrees. What is the importance of this? 80, 85 degrees, collagen is going to become fluid and you can seal vessels. That's why with a ligature, you have a much better sealing of vessels. And then there's something where it's especially important. You need a fixed pressure, and which means the distance is always the same, and you're sealing the vessels even when you are working in a resistant area. And this is FAT. FAT is an isolator for electricity. The big generators are isolated internally with grease, with fat. That's why if you're going to do surgery on the epiploon with a ligature, where you have pressure and a constant distance, you have a perfect correlation because you heat everything to 80, 85 degrees, but it's much more difficult to do this with a classical bipolar. The second advantage of the ligature is there's a very little lateral thermal spread. And this fusion is so good that you can coagulate up to arteries of 4, 5, 6 millimeters. The problem of this is it's round, it's big, which means it's not so suited for dissection. There's a lot of data about modulation of electrical wave. As far as I know, this is reinventing the wheel and it's not making much difference. Anyway, I haven't seen any difference how it works. What nobody tells you, and what I do not want to tell you, those who make the devices, how with software you can modulate the current. And this means when you start to cut and to coagulate, you have this kind of beginning, which is software modulated. Nobody tells you, nobody knows. I'm trying to fish about this and to have an idea, but nobody wants to tell me. And then the third device, this is not electricity, ultracision. It's in fact the movement of two mechanical devices, which is going to create heat, and then you have always the same effect of each. This means that this friction energy has less lateral spread, less risk of accident, but there is also a problem that the jaws remain warm afterward, which means that after coagulating or cutting something, don't touch the bone because this can have an accident. Thermal spread, in order to discuss the importance of this, we talk about the amount of tissue which is remaining. And that would be another talk. It's mainly about adhesion formation. So my conclusion would be surgery is tactics and strategy. Tactics, this is the instruments. Tactics, this is the scissor and the bipolar and what you are using and which insufflator you are using and which these are your devices. And strategy is how to use them. So the first thing is what the surgeon does. He has a choice of his instruments, and then he has to know how to use them and understand what it does. For electrosurgery, the most important is voltage. And if your voltage below 200, it's soft coagulation, and then start coagulation, and higher voltage, cutting and coagulation. Your watch is only a safety device, which means that you cannot have more output than where you limit it. But the importance of the watt, it makes the instrument versatile, because with a large area, you drop your voltage if you have a limited watch. And there you see the importance of the surgeon. He uses the contact area to modulate the intensity by contact area, and this modulates the voltage, which means that you have the same instruments, the way you use it can have a low voltage and high intensity coagulation, and a high voltage and a low intensity sparks, which means cutting. And then you have steam that stops the current. I try to explain that intelligent device, and this is mainly the sealing devices where you limit the temperature to 85 degrees by having this kind of pressure. And then ultracision, which is mainly when you have problems of ultracision, which works well for fat for the same reason. This is the reason why many bowel surgeons like ultracision. I think I try to be short and to have the electrosurgery. If there are any question or whatever, thank you for your attention.
I like your lecture very much. Ой, извините. Спасибо большое.
I wanted to say thank you very much. I'm always amazed by your presentations, Philip. Every time I enjoy, every time I see it like for the first time, you know so much about electrosurgery and about the surgery in general. So, is Arnaud ready to do the surgery? Arnaud? Please, 1 minute of your time.
If Arnaud would need 5 minutes, I can say a few words about just to be complete.
У нас договор был с Арно, что он будет включаться. Окей. Дорогой Филипп.
Dear Philip, currently we are waiting for a signal from Arnaud. Yes, he's calling back. Please wait. Now we will have very small discussion with Philip before you go in, right? Okay, good. Dear Philip, it's really lucky. We have few minutes. Yes, about 5 minutes. So please, your comments.
Just that to show what is laser. Laser is sometimes looks a little bit strange. Laser is light, and light is an electromagnetic wave. Electromagnetic wave, which we know very well. These are the X-rays when they are very short, the ultraviolet. Then you have the light, which is, we know, the visible light, the microwave, and the radio waves. All these are electromagnetic waves. And then at the specific of a laser is that you have a tube when you send the energy from one side to the other, back and forth, and then you let it pass through a partial reflector, this collimated, which means that you have light which is coherent, collimated, and monochrome. Monochrome because of its the gas which is in here, where the energy between two levels make almost the same electromagnetic wave. This is the basics of a laser. When I said laser is light, it can reflect, it can transmit, and it absorbs. Reflect is like all reflection in a mirror. Transmission is with a small angle, like you know when you see in water. And absorption, this is heating of the tissue. The penetration of a laser depends on the absorption. All lasers have a certain depth that all the energy is absorbed. One is very superficial effect. On the right, you have a much deeper effect. Typically here is a CO2 laser, and this is the neodymium yak laser. I had this as an example. The CO2 laser on the right is the extreme, only superficial, all absorbed by water immediately. Then you have the neodymium yak. This is the other extreme, very deep, but that's why it coagulates much better, because there's always a cone of heating which is preceding the cutting. CO2 laser is so superficial that it's not useful for coagulation. I'm not going to talk about the KTP and the argon KTP. These are the fiber lasers of today, are in between, and depends on the type of energy, the laser you are using, which is going to give the characteristics. Maybe a few words about argon laser. What is the application? You can have it in continuous, you can have intermittent, and you can have in super pulse mode. What is the concept? Is that if you have continuous energy, you go deeper. If you have very high energy, very high energy and a short time, you can let tissue cool in between. And if it cools in between, you have less lateral spread. So this is the power density. What's the tissue effect? Depends on the spot diameter. It means how much area are you going to heat with this amount of energy. So if it's very small, you have a very high temperature and a very high effect. If it's larger, you are going to have more diffuse effect. The penetration, this is what I tried to explain before. The penetration depends mainly on the on the type of laser. There's something you have to understand very well. This is what are complementary colors. And red and green are complementary colors. It means that the argon laser, which is green, is going to be absorbed completely by the red, which means that if you have a wall with red and green tiles and you have an to shine with a lamp or with a red lamp, then you are going to the red tiles, you are not going to see them, and the rest is going to be absorbed. So this is the reason of complementary colors. This is the reason why an argon laser is also so dangerous, because it's going to go right through the cornea, and if it hits the vessels in the back of your eye, at that moment you have a coagulation and you can get blinding. Small details, we have a CO2 laser, so it's made with CO2, and we insufflate with CO2. So if this gas, the CO2, has a resonant frequency, the same as the laser, which means you are going to heat in the scope, you're going to heat the gas. This is the reason, in order to use this without blooming, opening of the spot, to use a laser, you need a high frequency insufflated, high flow insufflated. And this is, I think, something was one of the difficulties in the beginning. This was also the way how we developed the Storz insufflator, which at that moment was the only one who was able to deliver 20 liters per minute. 20 liters per minute is, you need at least more than 10 liters per minute in order to cool the CO2 laser in between. These are things which are very well described in the past. And the way to prevent this, they use an isotope of CO2 in order that you do not have this effect. I think this is to a large extent the past. When I would compare today the electrosurgery versus the CO2 laser, the electrosurgery is cheaper, it's much more versatile, but you need secondary punction. A laser is still my preference for superficial endometriosis, in order to have the minimal damage and not to have lateral spread. Problem is you have a lot of smoke, and in order to evacuate the smoke, you also need a high flow insufflator. And when you say high flow insufflator, you means a lot of gas which is going through the abdomen. It means a lot of desiccation, water that's taken away, and then we talk about adhesion formation. This is a very old slide where I tried to explain what is the difference. When I was young, more than 20 years ago, when we did hysterectomies, you can do hysterectomies with 2 secondary punctures. You don't need 3. When you go with electrosurgery, you need 3 punctures, because the laser has the advantage of having the surgeon and at the same moment the assistant. The surgeon has and the energy and the camera. The problem also for laser surgery is that you need a trained equipe, because the assistant becomes very important, because the assistant has to have the bipolar to coagulate. So not everybody is used to coagulate from the other side. So you have, it needs training, it needs time, and it's one of the reasons why the CO2 laser has been disappearing over the last years. We have a CO2 laser in Rome. We use them rarely because you cannot dissect with it, because it is a different type of training. But for superficial endometriosis, it's still the best. And then a high intensity laser, 880 watts, is very expensive. And that's why they had this kind of, let's say, just in focused, which makes a rotating movement, so you can scan an area, so you can vaporize an area. These are, let's say, mechanical adaptation of the use of a laser. And also difference, there you see what is the difference. If you want to cut an irregular area till the same depth, you have to use electrosurgery because you can cut as long as you stay below the maximum watt. If you want just to have a superficial effect, you use a CO2 laser because this is the preset values. So my conclusion for CO2 laser is the CO2 needs specific training. The assistant is coagulating. The surgeon is holding the camera and the laser, which is completely different effect. Still the best for superficial endometriosis, but you cannot dissect. The new diode lasers effect varies with wavelengths. Use the data to coagulate areas. It is similar to, let's say, plasma checks, but what you have to check when you use them is the depth of penetration and the amount of that energy. Thank you for listening. I hope Arno is going to be ready at this moment.
Thank you very much, dear Philip. Thank you very much. You are always like surgical maestro, electrosurgical maestro. Thank you very much. And what I like is that Anastasia is looking at us, she's smiling, and she's looking very good. So let's ask Arno. Arno, are you ready? Are you with us? Anastasia, please say something what you want to say in the framework of this discussion.
Congratulate Philippe. He did a very, very excellent presentation. It's time I hear this about. I learned electrosurgery from Philippe. I have to say thank you. And this presentation was excellent in order to understand how to use what is it, and I think was very useful for the audience. And he is also my teacher. Thank you, my dear.
Yeah, but you are the one who, for the courses in Rome, you are giving the lectures on electrosurgery.
Exactly.
So you listen to it to an other eye, and let's say, me too. When I listen to your electrosurgery, I say, how should I say things the other way to transmit the message in an easier way?
It was excellent. Thank you, Philippe. Very good. And now we wait for the surgery of Arnaud.
Дорогой, Арно пока не вышел.
Arno is not yet connecting back. We're waiting for him. Dear Philip, please tell me, you master with all of the types of energy. You are guru of energies, electric energy. You are master of laser surgery. Please advise, in what case do you prefer laser surgery? Please provide your preferable indications for the laser surgery and what is the state of the art of the laser surgery. Thank you.
Place of
Well,
laser surgery.
well, I
Место
think
лазерной
laser
хирургии в
surgery
лапароскопии. Да.
today, CO2 laser surgery, it's almost the past. I started with CO2 laser because I started with fertility surgery. And by the way, I will show this afternoon, I submitted a paper together, our last paper about the cardinal sins in surgery. Fertility surgery is a different kind of surgery. It means you try to limit adhesion formation, you like to limit damage. It's not the big surgery of hysterectomy, of oncology, of deep and endometriosis surgery. When you go for more advanced surgery, you need dissection. Is dissection and prevention of bleeding. When you need mainly dissection, don't use a CO2 laser. So it means that, like I told in Rome, the laser is there. We almost never use it. Only for, let's say, a woman with infertility, which only have this kind of superficial and endometriosis, there a laser has a big advantage. It's very fast. It has a minimal amount of adhesion. It does not get coagulation more than necessary. It's perfect for that. But I think today, for me, this is the only indication for a laser.
Дорогой Филипп, одно слово.
Dear Philip, just one word, Anastasia, I'm sorry. Back in 1999, I wrote a very big monography, which was called Surgical Energies in Gynecology. At that very moment, I was also very much amazed by the laser surgery. We were describing them there, electromonobipolar laser, cryosurgery, etc. All of them, all of them. And I totally agree with you that if this is a true surgery, big surgery, when we need to cut, do suturing, coagulation, well, there is nothing to do with laser there. But if this is elegant surgery, reproductive, fertility surgery, that we need to vaporize lesions of endometriosis in the abdomen, if we speak about the surgery on the tubes, uterine tubes where there should not be deep penetration, then definitely we use defocused laser, CO2 laser, and today we have it available, so-called fraction laser, that works fantastically, and this is very agile. But you are true that there is more and more electrical or mechanical surgery that takes a big part of our life. Anastasia, please.
I want to say something about the use of the CO2 laser. One of the reasons, I think also, Philippe, that we stopped to use it, it's because the vision was not good. With the vision, to treat deep endometriosis with a bad vision, with the CO2 laser, you don't have the same vision that you have without. And this is one of the problems. Do you think this?
Sure, but this is the chicken and the egg. The this kind bayonets for the telescope for a CO2 laser is the older telescopes, and the industry did not make the new bayonet scopes with the new technology because so few people are using the CO2 laser. So it's the chicken and egg, but it's clear the vision is not the same.
It's not the same.
And you have a problem. And you have a problem of the smoke, and you have a problem that, for instance, you are more used to electric surgery than with laser surgery, and are two different techniques. I think, today there are few people who are left with this, who have been really trained and used the laser surgery. Besides Jacques Donnet, but this was maybe a Belgian feature. Laser is today almost the past. That's what I think. And if I don't have it, I'm not unhappy.
Agree.
May I say
Дорогой
something
Филипп,
more?
скажи, пожалуйста.
Dear Philip and dear Anastasia, we worked quite a lot to prevent the adhesions. You know, adhesions is something terrible. It's something terrible. And it's completely unpredictable. You never know in what cases you can expect and in what cases you cannot expect the adhesions. For almost 50 years, 50, we are preventing the adhesions. And I know that you love, and we did it together with Karina, with Aspan, conditioning of the abdomen. Conditioning of the abdomen as adhesion prevention tool. First, let me know something new about adhesion preventions. What are the cutting-edge technologies available in the market? Besides that there is conditioning, and we will have another speech on conditioning. I will give you the floor. What else? What else can we say today? Maybe philosophical view of Philip Konings to adhesion prevention. Arno already started working. So let's transfer this question to the later discussion time. Arno? Arno, can you hear us? Can you hear us? Yes, we are with you. We are with you. Please speak up.
That apart that being a big uterus,
Connection нужно, нехорошая связь, чуть-чуть почетче. Связь, картинка хорошая.
Picture is very good, but the sound is quite poor. Could you please correct the sound? Could you please improve the sound?
Слышу тебя, но...
Yes, I hear you, but please correct the position of the microphone. I don't speak Russian, Leila. I don't speak Russian, Leila.
Apart the size of the fibroid is a simple hysterectomy. So I try to do it within the time, which is my time. You give me 1 hour. So here you see I start always to cut the runt ligament, and I use very simple bipolar scissors technology. And you see that very prudent, step by step, I will cut the runt ligament. So when that is done, I will discover two spaces, one above the broad ligament that drive me towards the towards the bladder, and I will incise. So I use monopolar energy here, and you see I will go back. This patient got 2 scissor sections, so we expect few adhesions, but so far I have no problem. I will show you the technique then. And if I go on the posterior aspect of the runt ligament, so here, I will go in the posterior part of the body. It's important because in between these two spaces, you have veins, okay? So it's better to coagulate them if you do that, and then you can cut the broad part of the ligament. So this patient got a new ring for tubalization, and that's why you have the adhesion here. I do not release them too much. I just release what I have, what I needed, and then I start to proceed with the hysterectomy. Okay, so now I will go posteriorly. Okay, and you see that she had all these adhesions made the peritoneum very fit, and with some adhesion, this is budatic. So now I can dissect more. I can go more down here. Okay, I will see the problem of the bladder later on. Then I will always, try to go further. So here I don't make the window because as she got this, the ovary is behind here.
Could you please move the microphone away from the mouth, a little bit away from the mouth? Make the microphone away.
So you see I can dissect a little bit more. I will find my ureter here and the uterine artery. So if I ask, can you take this? Just for showing you the anatomy. If I dissect here, I will find very probably the uterine artery first. Right here, you see. Let me dissect. I don't want to make bleeding. You see the uterine artery, okay? Here. So it means that the ureter is down there. Okay? So this is the uterine artery. Ureter is here, you see? It will move. Let's wait. You move. You see? Here is umbilical artery going up here, uterine artery. So if I want, I can take the uterine artery and I can coagulate it without trying to cut it, just to start to reduce the vascularization of the uterus. Okay? So I pay attention, ureter is down, it's fine. I have a small bleeder here that I will take. You see, and most small bleeders are small, but immediately they produce a lesion. That's why. I will continue to, okay, thank you. So now I will continue. I give back to Zainab and I incise and I try to see where is the uterosacral ligament insertion on the posterior aspect, which gives me the place of my colpotomy, because we know that we are above the one side is done. I will go for the bladder later on. I go to the other side. So you see, this is a quite easy technique. So here we will see better. We may have some adhesion also, but you see the ovary better, the membrane and the big vein. So let's do the classical way here. I think I remove the left over, but also the left ovary. We don't find it, but I don't want to look at it. Leila, did Armando connect or not?
Великолепно слышно.
We can hear you very well. It's all right. Please move on.
To eliminate the smoke, so you see how Zainab go inside here. I need larger vessels, so I will use the larger face of my scissors, and I cut, and I can go lower. Can you put more cranially, please? More cranially? More in the center? Yes, like this. You see the bladder is here. I see it very nicely, so I can. The role of everyone is very important. This point here, you see this uterus. I can also try to do the same as the other side. If I see the vein, I can convert. You see, there is a lot of veins. So if we want to see the origin, we have to be a little bit more lateral here. And this is the lateral part of the paramedical space. The uterine artery should be somewhere here. So it has to be easy. If not, maybe a window. Okay, so I can do the window here, for example. Voila. And I identify the gray zone that I open. Then now I can run my window parallel to the uterus. So you always have to pay attention. My assistant warned me to tell me there is something behind here, which is the bowel. Okay? But I make my, we can be very precise. And we don't, here I have a vessel, again, large face, you see? I have more coagulation. If it's not enough. Now we have the tube. I will leave the tube for the moment because she got this tube elevation. I will ask better to take. I will remove the tube at the head. I will see how the technique has been done now, stabilized. We know exactly every step. So my assistant knows what I will do. My assistant between the legs knows exactly what she has to do. Even Razan told her to make it more lateral. And she's right. Here we have the tube, so I will take the tube. For the moment, I let the tube attach to the uterus. It will help me. If you have any question, and ask me because I'm not disturbed by questions. You see at the placement of my trocar, because this baby is quite tall, are the same as the normal size uterus. Okay, so now you see, when you saw admitted, so I will ask Zainab to take the peritoneum, and I will just try to take it here. I will try to free the veins. Wow. And now I can do this with less risk of venous bleeding. And I can progress towards the direction. Here is the uterine artery. I have a small bleeder here that I will take. Again, this bleeding don't disturb me during the laparotomy, but they are disturbing me during laparoscopy. Let's try the bladder. I will see the bladder, we have a problem because we have this banana, and she has two hysterectomies, two ciliary sections. So I show, but look, we see the bladder. So I give the bladder to Zainab, and I will incise here because I know that as she got the bladder, I have no bladder here. And I will make my incision with a 90-degree angle to the wrist. No, it's too. But come down, you see the vision is a bit polluted, so I have to go in the plane. Now I will do in the plane. It's very important to not get here. So here you see, this is the vesico-vaginal plane. Okay, so because we have the fibroid, but it will, I will say it in a minute. You see the uterine artery on the right side now. Okay. I push, Voilà. We'll show you a little bit of anatomy. Now let's go to the left side, it will be better. Voilà, for you to see. Can we have someone that activate the manual mode of the section, please? Voilà. So you see we always have problem with smoke. Alors, I use my bipolar like this because the bipolar is a smooth device. Take the bladder. Take the bladder, I want, and then, well, and you see that always follow the bubbles and we dissect, so pay attention. The bladder is very well vascular, and you have always this vein here, okay? So the central vein, it's better to take it before it bleeds. Well, and then you can go. If we go on the side, I will show you here. If I go here, I will dissect the Yabuki space, the famous Yabuki space, and I will see at the bottom, I will see the little artery here, and down there, if I go down, I will see the ureter. Now I can go on my side, you see. Now the bladder is down here. The uterosacral is here, so in between, there is no chance to get the ureter. So I can coagulate. I coagulate up and down. You can use whatever energy you want to do so. I am a cheap doctor. So I go with very simple energy, step by step. What is important is to, when your coagulation is not perfect, is to come back and to dissect step by step, small bite by small bite. So we have, even if you have a vessel open, your bleeding is reduced because you are clamping. Okay? And here, you know, I stop at half of my cut to recut. Well, the artery is cut here. And even though we did you don't want me to cut the balloon. Okay, now I can ask Letty to pull the valve, and you will see the valve arriving here, anteriorly. I don't see the valve. I should see the valve. Something is wrong. The valve is not in. Let me follow up with my. Okay, pull the valve. Okay, so you see the valve now, and you see that the bladder is quasi enough, except in the side, but I will do it now by coagulation and suction pushing. This is the edge of the valve in that, so we are enough. I will take again a little bit more my vessel, because you see that as usual, when you cut, you have no bleeding there. After a few minutes, you may have some bleeders. Okay? So we are okay on that side. Let's do the other side. For this, I will give the bipolar to warm up. We're going to clean the picture. To clean the picture, you prepare the gel, you prepare the suture.
When you work on the uterine artery on the side of the pedicle, do you think at that point the assistant should reduce the stretch on the vessels?
Alors here, I will show you something. Okay, no, it's fine. Alors, I have to help, so I will take this and we are going to put it away. Voila. And again, we are going to follow not the. The question is, where is the ureter? The answer is the ureter is not where I cut or I coagulate. Why? Because the bladder is down here. You see, bladder is down here, and the uterosacral ligament is here. So in between, I cannot get the ureter. It's very simple. It's an anatomical reconstruction, and this is okay. You will do the posterior also. On that side, I do not coagulate the artery. I like to coagulate the artery at the origin rapidly because then I save a notable quantity of blood. You see, we work together. So I hold expose for Zainab. Zainab do the job, then she will take my position. Okay, and I will be able to come and cut. Artery is open. This is the vein is open here. So artery is right above. The artery is not cut yet. Huh? Okay, so the artery is here. You see, I will show you the artery. Bouge pas. Artery is here. You see. Voilà. Now she has the artery in her forceps, so we can take it separately. And if you can take the return of the vein, you see even the vein lower here. You see, even if the vein is open, we still have no bleeding, probably because we have, I cut the artery. Okay. Wow. I cut the vein. Wow. Artery, vein. Artery, vein. Here I go. So here are the cervicovaginal vessel here. You see, it starts to bleed. So you will take it before I cut. Voilà. Cervical anterior, you have 4 pedicles, 2 anterior, 1 in, 1 out. And then you have 4 pedicles of cervicovaginal, and you have the inferior vesical vein, which is satellite. Okay? So you have to know this if you want to go down. Okay, finished. We are going to put the disc inside. I'm going to take the hook in my side. I will take the, you see how the uterus become white. We have to prepare the cabinet in case it's ready. Okay, good. And a 10mm trocarine. Okay. Oh, you see. And now we are only almost perfect. We put the disc inside. It's moving a little bit, but it will stay. Don't worry. If you have any question, Leila, ask me. Huh? You have to push up.
Remove the stoplight.
Okay. Push voilà. And push, but
Remove the stoplight away.
Don't move. Push.
Arno.
Push. Okay.
Arno, my dear, I'm watching this surgery and I have a feeling that we are from the same kindergarten and we are from the same school, because you are going like me, one by one, very detailed, very precise, very clear. Thank you very much for that.
Because I don't take my technician to get the English version. So now they move. So can you repeat, please?
По-английски. Arno, my dear, I am so happy that you decide to show this case. It's absolutely typical. And this is the class. You do first step, second step. And when I'm watching the surgery, I feel that I do maybe it myself. So it's very important to show to audience the real classical variant of hysterectomy. It's very important because most of the people, they do real hysterectomy, they don't do why hysterectomy for cancer. So, nice, typical case. Tell me please, Arno, do you... Хорошо.
But the robot is not available to all. Bipolar seizures are very available for everyone. And so it's just now a matter of technique. And so we can do what I do we just open a market in Rwanda. So you can do it in the big part of Africa. You can do it in Dubai, you can do it in Moscow, you can do it in every place in the world. No, push towards to me. No. This is, we have a small bleeder here that we are going to fix the bleeder on the artery first. Okay. And then I cut above the vessel, voilà, like this. I know the difference between intrafascial and extrafascial. So here I am almost extrafascial. Not totally, but almost. Here you have the uterosacral on the right side, voilà, which is coagulated, treated. We have always, when we are on that right side, we have always this problem with the, voilà, finished. Unfortunately, I think this uterus is too big to go out, so I will cut it in two. You see what time it is now? So you see, we do the surgery in 40 minutes. I think
Yes, I see very well.
Yes, I see very well. We see very well.
that the time is linked to the complication rate. So the faster you go, better it is for the patient. So I will check. I put my 10 millimeter trocar now, and I will use the on my side of tenaculum. Can I unscrew them? Use unscrew. Okay. Put the, we do that in benign uterus, we don't do it in malignant. That's why all our patients has before we do a hysterectomy, we do not only a pap smear, but we do also people. We want to be sure that we don't deal with any malignancy. And now I cut it, so it's very important for the safety of the patient here because I use a blade. It's very important, first of all, that the blade is sharp, and two, that we have two grasping forceps, and that we do not move the two forceps at the same time. I mean, that here, Zainab has a tenaculum, I have a tenaculum, I cut, as long as I can, I cut, voila. If I want to change, she don't move, I change, now she changed. Okay? We pull up to be far away from the bowel, and I continue to. The sharper your blade, if you feel the cavity, if you feel that your blade becomes more smooth, stop and change. Because if you do not do that, you put too much force in your movement, and you become dangerous. Should it be okay? How is the vagina now? It's small. Now I identify the cervix. Where is the cervix? Here. Yeah. And I will give the cervix. So let's say if it passes now. Okay. Wait a minute. Okay, look like this. Allez, pass your forceps above. Okay, open, largely, open, large. Okay, close, and go. Now it's a little bit. Lift up you can lift up the legs. And it is. Yes. Voilà. The patient, in addition, the patient is a little bit obese. Okay, so I think we have 1/2. Only 1/2, no? All? All? Oh my God.
Oh, one remove?
All right.
This is the small one.
And I put the small myoma inside. Voilà. the small myoma. The uterus is total, entire? Yes? You have the myoma, the small myoma. Voilà. And now we clear using the bipolar instead of my. Voilà. The blood that was trapped into the cavity. I will just have to not pass inside this. Voilà. And now I will. Alors, is Armando there or not? Because then we can do some comment the time I do the vaginal closure with suturing. If not, Philippe can also comment. We have a breather, okay. You have to resist to the fact that you always want to be very dry. And so at the level of the vagina is not very good. So try to do the normal hemostasis, the minimal hemostasis necessary to do the suture. And if you do so,
Arno,
yes.
дорогой,
Arno, please, when you do the suturing, speak into the mic. The sound is very poor.
My mic on the microphone. I will change the mic. Okay, the suture. Okay,
Да.
I consider that I am fine. I will remove the
Не,
tube
я
first.
вас хорошо слышу, вижу, но надо,
Well, I can see you, I can hear you, but when you make any comments, please speak into the mic. Please speak into the mic.
I am speaking in the mic.
а то
Action.
лучше.
Okay? Mila? My technician Mila said that the problem of sync is on your hands, not in your hands. Mimi? Hello? Mimi? Did you get something? But the voice you're hearing? Милана,
Да ладно, ну что я буду кричать?
Лейла?
Все видно, пусть говорит.
washing, please. What? Yeah. No problem. We'll check after.
Дорогой Арно,
Dear Arno, it's a classical approach, and as we see, you performed hysterectomy for less than 30 minutes, and this is standard approach, and this is what we learned 100 years ago, and this is how we work all these years. It's very important that during suturing, you show us your technique. So how to do the suturing of the wall, of the uterus wall, especially in the aspect that should be the prevention of future prolapse. Please show us the suturing. Show us the suturing technique.
I think you're right, Leila. You see, I will close the vagina in 2 layers and with a continuous suture. Alors, some people use barb suture, I don't, but it's same. So what I do a first row that just close the vagina. Okay. Just close the vagina is more than 50, 25. Okay, and I start, I stay in the vaginal mucosa. Sorry? Mm-hmm. Okay, and then you see that I'm going to close this first knot, doing the famous not half inch, but flat knot H1, H2. Here I am asymmetric, but it's no problem. And then I will just, alors here I just do 3 because I will come back. So I will explain to you later. So now my assistant hold my suture, and this is probably the advantage of the barb suture that no one has to hold, but when you hold the suture, you're also exposed, you see? Vaginal mucosa, no more. I leave the fascial pericervical ring for the second layer, okay? Okay. You see the fascia here, and you see the vagina there. I hope you hear me.
Yes, yes, we can hear you very clear.
Close the vaginal wall. Leila, can you confirm that you hear me?
Yes, we can hear you very clear. I can hear you and I see you very well, and I love you so strong. I love you so strong. Arnaud, please reply.
I love you too. When do we get married?
Не разрешает, у него так...
Well, well, I know your wife, very passionate Brazilian wife. I know. She's also a fantastic doctor. And Arnaud and his wife, they are great friends of ours. Not to everyone you can call and tell, you know what, I need you at 6 a.m. Please do the teaching course. They are always together with me. It's a pity that we are not on the same side. For 30 years we are working together. But even now, regardless all the challenges, our work is ongoing, our cooperation is ongoing, and our friendship is forever. Dear Arnaud, please tell me, do you do additional support for the vagina to avoid prolapse, additional support? How do you strengthen the ligaments? Please share.
Look, here, now I have closed the vagina, first row. Now I don't take the vagina, I take the fascia, pubocervical fascia and uterosacral complex. And look, so now I go back and I will do my second layer, taking this very strong tissue lateral to the cervix, which is the pericervical ring. I turn a little bit, much better, okay? And I will cover, let me take, voila. I will cover my first layer with this fascial ring. You see, it's a little bit like a McCall without being a McCall. It's just an anatomical reconstruction. Fascia, pubocervical fascia. Alors, at the center of the vagina, posteriorly, there is a very little fascia, very weak. So it doesn't count. What counts is the lateral part of the cervical ring, okay? Both in anterior and posterior aspect. Huh? You know that the pubocervical fascia is attached only on the lateral third of the vagina. So, and you see how I cover my first row, and I continue now more on the side, take the fascia, and then you will see posteriorly, and I will make it more clear for you by pulling this suture up. You see, here I take the the uterosacral cardinal complex. You see, goodbye. And I take it medial to the uterosacral ligament, so I have no danger for the ureter. And though I close, okay, I will ask now Zainab to block at the edge of the vagina. And so without any problem, I can now finish and close using my initial suture. Alors, you will see with Armando, if he gets connected, that I draw the line of the horizon, I pass on the back, first loop, same, second loop, okay? I do not open, I don't use the gladiator because I'm not used to it, but you can, okay? But you have to tie, okay? Okay, and you do the same, and now I lock.
And as this is my last one, I will follow the advice that we established with Armando, that you have, and Philippe, that you have to do 5 sequences to be sure of the stability of your node. This is my 5th one. Okay. First is H2 and then H1, H1, H1 inverted. Okay. So it means that is blocked. Now it's finished. So I am glad because I am strictly on time, Leila, for your opening ceremony. I will. So now is the time of the check. Always do check, hemostatic check. You should do it in that order. Huh? Do hemostatic check.
Нет.
All the
Дорогой Арно, у тебя все нормально со временем.
Dear Arno, you are absolutely perfect with time, so you can continue. We have some time. Could you please say, well, cooperation, it's all very clear, fantastic surgery, very clear, very effective and classical. In what cases do you perform amputation? It's either over uterus amputation. Do you do it or not anymore? For example, in case of prolapse, or if you need to do the fixation, or if woman insists on that, on subtotal hysterectomy. Do you do amputations? Please speak up.
subtotal hysterectomy.
Do you do? No, yes.
Yes. Do you do any subtotal, or do you stop doing subtotal? No more subtotal. Please speak up.
I do only subtotal. I need a monocryl 30, full length. I do only subtotal in case of prolapse when I put meshes, because we know we know from our experience that if you do subtotal, you divide by 4 the risk of vaginal erosion with the mesh. So we do not do anymore total hysterectomy when we put a mesh in sacrocolpopexy. And this is quasi only the indication, or sometime here, because when women has big myoma and they are very reluctant to full hysterectomy, we offer a subtotal hysterectomy to convince them. Now I finished my hemostasis, so I will try to see. I will see the ureter. You remember that anatomically the ureter, hold the ovary, please. The ureter is the first structure close to the IP ligament. So if I go here, I will see it. It's right behind. You see, huh? We are not in Moscow. You see the ureter is moving is here. Okay, so it means we are not in Moscow. I love to operate in Moscow because the BMI of patient is very small compared to here. Here, the average of the BMI is 30. Okay, give me the monocryl. Now you see that in my case here, I find that this ovary is a bit mobile, so the risk of torsion is there. So what I do, I will take a monocryl filament, and I will, as we have time, give me the Johan, I will finish. And here I will use, to show you differently, I will use an extracorporeal knotting technique. So again, you always, the difficulty is to load the needle. I take the rent ligament. I take also the meso to avoid to let a hole. And I make this shrinking on the meso. Voilà. And I finish at the level of the utero-ovarian ligament at the level of the ovar, like this. Okay. And then you can go out.
Арно, скажи, пожалуйста.
Arno, perfect. Please tell me, do you remove tubes? Do you always remove tubes? Or if the tubes look normal, maybe you preserve them? Because many colleagues say that if there are residual tubes, it could be potential risk of further malignancies, malignancy of the ovaries. What about uterus tubes? What about tubes?
I think we remove tube because there are some evidence that the ovarian cancer may start by a dysplasia at the level of the fimbrial ligament. This is the base of the prophylactic sapingectomy.
So I do it systematically. And plus, there are studies that shows that in case of hysterectomy, the fact that you do a prophylactic salpingectomy do not impair the ovarian function, do not accelerate the time of the menopause. We are not in the case of endo, where in endo, when you have a lot of adhesion between the tube and the ovary, the fact that you do a salpingectomy for hydrosalpinx may impair the vascularization of the ovary, and then it's better to do a clipping. So you see that now when I will deflate the patient, you know, and we will do it now because we finished, I will deflate slowly the patient, and you will see that give me artery. You will see that doing so, the peritoneum will close, you see? And so the peritonized area will close itself, and that explains that we have a very little adhesion post-op normally, because if we are not in inflammation, look, totally closing. And so, I mean, when the patient will be totally deflated and flat, and that's why it's probably better to deflate before you re-put your patient in flat position. Voilà. So she's almost deflated here. Okay, go down with the scope, go down, go down.
Но скажите, пожалуйста, Арно, проводите...
Arno, please say, do you do preventive ovarectomy? Do you remove ovaries if this is mature age of the patient and if ovaries are not changed? Because oncologists, they frequently say, so we can remove the ovaries. Why do we need ovaries? They say it's postmenopausal, no point. Do you perform prophylactic ovarectomy?
I think that there are two attitudes. You have the attitude of the oncologist that say if the patient is menopause, let's say 50, you remove systematically the ovary. This is what we were doing years ago. But now, after a lot of study, and mainly started by the paper of William Parker, that shows that if you remove the ovary before 60, you reduce the lifetime of the patient, because you will save from patients from cancer, but you will increase the disease linked to the early menopause and the early removal of the ovary. That should be balanced by now we have excellent hormonal replacement therapy. And so I think that you have a choice to remove early the ovary for patients that accept the principle of accept and are indicated for an HRT of high quality, and you have the patient that cannot. And so here in the Middle East, we have the problem of the very low observance from patient of HRT. So if you remove the ovary at 48, the patient will be without hormone for life. So I think it's not that easy answer. I am very conservative, I must say.
Dear Arno, we can talk for about 5 more minutes, and I cannot lose this lucky opportunity to talk to you directly. So please advise, what is the difference of hysterectomy with benign process like today, fibroids? So what were the indications, adenomyosis and fibroids? And what is the difference of this benign hysterectomy versus hysterectomy with adenomyosis plus retrocervical endometriosis? Well, I don't mean the situation when we have ingrowing of the gut wall. So, difference between hysterectomies in different pathologies. Please advise.
Well, I mean, you have the standard simple hysterectomy. I think that the one we have done today is probably one of the most simple. It means that the uterus is a bit enlarged, so spaces has been dissected by myoma, and so this one was mobile. So I mean, no difficulty. You just follow the anatomy.
And this is also the case. When you have very small uterus, it's not always very easy because the spaces are not very easy to dissect. That's where the manipulator is very important. And then you have disease. The disease mainly is adenomyosis and deep endo that makes, you know that adenomyosis is a marker of the risk of complication. So it means that when you look at the data, you look at the most of the complication for hysterectomy occur when the patient has adenomyosis. So you have to take adenomyosis like a risk factor for complication. So you have to be aware on that. And obviously, this morning we did another hysterectomy with a rectovaginal nodule. So you have to treat fully the nodule to separate the rectum, to do everything, and then you go back to an hysterectomy. So obviously there are difficulties, but this one we just finished is really in my opinion, the easiest one.
Dear Arno, could you tell me, please, if a patient has the same surgery for benign pathology, benign tumor, and the patient also has a stress urinary incontinence, and the patient has a minor prolapse, and you choose the laparoscopic approach. In this case, do you do simultaneously the entire range of all these procedures, or just first you treat for stress urinary incontinence when there is no need for sacrocolpopexy? So do you do this simultaneously, or first you do hysterectomy and then you do TLT or TVT? So what is your approach toward the combination therapy? In the past, we tried to do everything during one procedure, during one surgery. Now we are convinced that when you do all these things simultaneously, there will be more risks. It's not quite right. That's a topic for discussion, a combination of different procedures during one surgery. What are the indications for a procedure like a uterine pathology? Please.
I think that if you have, just speak about stress incontinence. If you have a very moderate stress incontinence associated with a big uterus, I think it's better to do two-step procedure because most of the time the hysterectomy may solve the problem. So you have to look if the patient has stress incontinence and bladder instability. So don't do it at the same time. If the patient has just a clear stress incontinence, what we do, we do now, we do hysterectomy and we come back to do Birch. And we have an excellent result with Birch that avoid the mesh that patients now are a bit reluctant on and let the door open with the mesh in the future if she recurs to be incontinent. Now, prolapse is a total different approach. If you have a patient with prolapse that go for hysterectomy, you have to treat the prolapse because otherwise she will do a prolapse post-hysterectomy and then they will say is the fault of the hysterectomy, which is not. It's just the fact that she got already an hysterectomy, a prolapse, and you don't treat it at the time of hysterectomy. We got recently the case where one patient of us come here and we indicate a sacrocolpopexy with subtotal hysterectomy, and she went somewhere else and she got a robotic hysterectomy. And 2 months after, she come back here with a full vagina out. But it's not the fault of the robot, it's the fault of the wrong surgery for the wrong patient. So when you have prolapse, you should treat the prolapse. Or you can treat it by sacrocolpopexy, by macrocultoplasty, by whatever you want, but you have to treat it.
Dear Professor Vaties, thank you very much. Well, you and us have the same religion as far as surgery is concerned. I do not like to mix different things. I am absolutely convinced. I totally agree with you. First, I tell the patient we must treat the major disease to figure out what to do next. Well, dear colleagues, dear friends who are watching this streaming right now, I'd like to thank all of you. I'd like to thank Arno Vaties, who is the co-chairman of our course, and Professor Konings, who from the first days of our congresses has been the co-chairman of this course, and of course, Professor Anastasio here. We are a big international team. Thank you very much. So we wrap up the first day of surgery. We're convinced that all other days will be like that. Tomorrow we start our course at 8 Moscow time with Armando. He will show you the fantastic suturing technique, the gladiator technique, as he calls it. Here's our main teacher in suturing. So, Professor Konings, Professor Vatiers, please join us at 8 o'clock tomorrow. And now let's move on to the opening ceremony. We have 60 international speakers, 21 Russian presenters, and we're going to cover a lot of issues today. It will be a fantastic program. So right now, we have more than 3,000 participants registered for this Congress. Thank you for your trust, and I am absolutely sure that our course, this Congress, is fantastic against all odds. Thank you again, and I will see you in a few minutes at the opening ceremony. Thank you, Nastya. Thank you, Philip. Thank you, Arnaud. Let's have a short break, and we'll start after a short video with the opening ceremony.
Уважаемые коллеги, дорогие наши друзья,
Dear colleagues, dear friends, it's a great honor for me, on behalf of the National Center for Obstetrics and Gynecology and Perinatology, the Kulikov Center, to open the 36th International Congress, New Technologies for Diagnosis and Treatment of Gynecological Diseases. We understand perfectly well that this Congress started in 1990. There was a time when we had this Congress twice a year. That's why it's the 36th Congress right now. This Congress has great importance for us. We have a lot of people participating from different parts of Russia, from different foreign countries. Well, history changed a lot. And as usual, first, this is an international congress. of course, with the endoscopic course, because in each day, and there are 4 days on the schedule, we will start the Congress with live surgeries. It's a pragmatic course, it's an endoscopic course devoted to hysteroscopy and endoscopic surgery, and of course, with the participation of not just Russian specialists, but foreign specialists who are ready to share their competencies, colleagues from different countries. And that is why we're moving further toward high-tech surgery. There will be also plenary sessions. There are 7 of them. Of course, endometriosis and adenomyosis, new techniques in gynecological surgery, and of course, we're not going to go away from treatment and diagnosis of oncogynecological diseases. There will be a special breakout session on that. Also, there will be new technologies used in this field and naturally the problems of rehabilitation because both diagnosis and treatment go hand in hand. They're the focus of our attention. And of course, we'll be talking about endoscopic methods of treatment, but mostly we'll be talking about robotic surgery in this field and its place in surgery. Going back to the fact that our Congress is international, you can see participants from different countries, from 14 countries to be more precise, 40 international experts. You can see the countries participating in this Congress. The biggest number of specialists will be from the United States, and our friends from Italy rank number 2, also Germany, Belgium, France, Spain, Hungary, China, Japan, Canada, India, and Israel. So we're going to have 60 international experts. And I would like to thank Asya Stepanian. We know that Asya Stepanian, who is Leila's daughter, she worked at the Kulakov Center in the past, and we continue to maintain friendship, not just with her, but with all our colleagues in the United States. The US has delegated most of the speakers. So thank you, Arthur, for this, as well as other colleagues who, in this difficult time against all odds, allows us to realize that we're all friends, that we're all colleagues, that we have the same philosophy. Life goes on. There is no stopping it. And I'd like to say that there will be 45 presentations that are going to be made by Russian speakers, including 27 from the Kulakov Center. That's all I wanted to say, and I think that I'd like to thank Leila Adamian and to remind you that she is a member of the Russian Academy of Sciences. She is Deputy Director of the Kulakov National Center for Obstetrics, Gynecology and Perinatology and the Chief Non-Staff Specialists in the field of gynecology in the Russian Federation. Starting from 2020, we've been using this online format, live streaming, but as the co-chairman, Leila Adamian has done a lot to advance our congresses. She did more than I did, and we can say that she is the focal point as far as the organization of the Congress is concerned. Dear colleagues, it's a great honor for us and a great pleasure at the same time that the Minister of Health of the Russian Federation, Mikhail Murashko, found time to say a few words, a few welcoming words. And now I should say that each time when the Minister of Health, Mikhail Murashko, speaks in a real-time mode like today, we must remember that Mikhail Murashko is an OBGYN himself, and he worked in a very important region of Russia. Professor Murashko, in fact, set up the first perinatal center in Russia. That was a long time ago. Please, Mr. Murashko, we are waiting for your welcoming words. Dear colleagues, I would like to welcome you at the opening ceremony of the 36th International Congress, New Technologies for Diagnosis and Treatment of Gynecological Diseases. The congresses have been on since 1990. The Congress is an authoritative platform where the staff of the Kulakov Center of the Ministry of Health of Russia and other professionals meet each year online and before in person to discuss different types of knowledge. They discover different issues related to women's health, from modern methods of imaging and diagnosis of gynecological pathologies to new technologies in operative gynecology, including reconstructive and organ-sparing technologies. When we talk about malignant tumors, each topic will be covered through the prism of preserving the reproductive potential and health. I'd like to note that motivation is the most important factor for an OBGYN, because in this case, women can prolong their reproductive function. This is one of the major goals for OBGYNs. That is why I urge you that when you perform your duties, please do everything possible so that women could make their choice in favor of multiple births. Together with the Russian experts, 58 foreign specialists will be participating in the Congress from Brazil, India, China, Japan, and other countries. This proves that this Congress is very authoritative, and I am absolutely confident that this Congress will be one of the major educational platforms for young scientists. I'd like to note that within this Congress, there will be new opportunities to present their works by young specialists. I wish you every success in your endeavors, fruitful discussions, and I would like to wish you good health. Thank you. Mr. Murashko, we're very glad and thankful to you. Thank you for your emotions. Thank you for your wishes. And of course, this is very important for us. We're grateful to you for your support provided to our center, and we realize that your attitude is critical, but at the same time very creative. We know that you are a wonderful obstetrician and gynecologist, and each time I try to remind everyone that we have critical obstetric conditions and how to treat such critical obstetric conditions. You were the first in this country to start this area of medicine, and you've achieved very good results on the territory of Russia. Dear colleagues, it's a great honor for us that Alla Samoilova, head of Roszdravnadzor, Russia's healthcare surveillance service of the Russian Federation, she also finds time to welcome us at this Congress, and we're very grateful to Alla Samoilova for her attention to our Congress. But also, we're very grateful to her for the colossal work that has been done by Roszdravnadzor in terms of preparation of permits, registration documents, because Roszdravnadzor is a big empire. Without it, it's impossible to work in the healthcare system. Dear colleagues, dear friends, on behalf of the Russia's healthcare surveillance service and on my behalf, I would like to congratulate you on the occasion of the opening ceremony of this 36th International Congress that brought together the leading experts in the field of gynecology and reproductive medicine who are going to discuss innovative methods and practices and the best achievements in this field. Today, the Russian president outlined ambitious tasks, increasing the birth rate, reduction in the mortality rate, and increasing the life expectancy of the people in the Russian Federation. In order to achieve these goals, it is important to strengthen reproductive health and to improve the reproductive potential of the population. And this Congress is devoted to solving these issues. It is important that a very significant time will be devoted to master classes on endoscopic surgery as well as online live surgeries in the real-time mode. I know that not just Russian experts, but also 59 foreign surgeons will share their experiences. It's nice that we continue our cooperation, that we have a chance to exchange views and opinions. It's a value for every doctor. New knowledge will expand the professional horizon of all participants in this conference. Dear colleagues, currently, the preservation of health of the population in Russia is one of the major priorities of the Russian Federation. A lot has been done in the development of technologies to treat gynecological diseases. A lot has been done, but we should not rest on our laurels. We still have unresolved questions, and we must find answers to them. These answers will be provided at this International Congress, New Technologies for Diagnosis and Treatment of Gynecological Diseases. I'd like to wish you every success in all your beginnings. Thank you, Allah, for these kind words. I'd like to remind you that Alla Samoilova is also a famous OBGYN who, starting from January 2020, is in charge of Russia's healthcare surveillance agency. And during all these years, and especially several months ago, as far as I remember, you adopted a very important document for us, well, certifying our institution. Now we're certified as the National Center for Obstetrics, Gynecology, and Perinatology. Thank you very much for this certificate, and we've never forgotten your help and your assistance. Thank you very much. Dear colleagues, now I would like to give the floor to Leila Adamian, an academician of the Russian Academy of Sciences, Deputy Director of the Kulakov National Center for Obstetrics and Gynecology and the Chief Non-Staff Specialist on Gynecology. And Leila Adamian for the last 15 years has been dealing with obstetrics, gynecology, and reproductive health at the same time. And of course, these 4 days will not be easy for us, but a lot of preparatory work has been performed before we started this Congress to bring together international and national speakers. The program is very jammed, and there will be presentations on different scientific subjects. So I would like to thank you for this superb job she and her staff have done. I would like to thank Professor Yekaterina Yarodskaya, who has been with us for many years. She's a key person in the organization of this big Congress. And I hope that there will be a time when 3,500 staff of the Kolokov Center at the Parina 4 will see all these wonderful speakers, Russian and foreign, in person. And there will be a time when we'll be able to bring all these people to our center. Leila, I would like to give the floor to you right now and thank you once again for taking part in this 4-day marathon of the Congress. Please have patience. Leila? Dear colleagues, dear Professor Suhik, dear representatives from the regions, dear foreign colleagues, today all of Russia is waiting for our Congress. This is the 36th Congress. Together we've had 52 Congresses, 16 winter, 36 summer Congresses. This has become possible because this Congress is relevant. Many people want to participate in it. It's important for training staff, for education, for spreading educational information, for introducing new technologies, for improving the quality of life, for improving reproductive outcomes. This Congress, and I'm very proud of having such congresses with Vladimir Kolokov, and our center was named after his death. In his name, we had reproductive medicine congresses, an endoscopy course, and endometriosis course, and during all these years, well, it was a kind of a hobby for us at first, but now many people are expecting the beginning of our Congress. We have an unusual program, I would say a real program with the participation of many foreign colleagues. Some of our foreign colleagues say, why am I not on the schedule? Well, imagine that, dear colleagues. It has become possible right now. And Gennady Suhik, I'd like to thank you because you're also involved in endoscopy, you're interested in surgery, and you also enriched surgery, endoscopic, and the introduction of new technologies. So thank you very much for using the significant potential of our center. This Congress is not just important in terms of surgery. It's called, well, new technologies for diagnosis and treatment of gynecological diseases. The Ministry of Health helps us, maybe because the Minister of Health of the Russian Federation is also an OBGYN, and he attended our congresses many times, as well as Alla Samoilova, who spoke before. But I would like to thank our colleagues first and foremost. Today, we have more than 3,000 people registered as participants. I am very proud of it, dear colleagues. It's impossible to have such a Congress without wonderful foreign guests and colleagues. and friends, today we have 60 stars, mega stars of international medicine, stars in obstetrics, gynecology, and oncology. Each of these names was written into the history of medicine. Those victories they had achieved, such as Philip Collix, Arnaud Thiers, Armando Romeo, Anastasia Rossier, Mr. Moresca, Jacques Camus, Professor Bitocchi, Professor Bigotti, my friends from the United States, Phil Taylor, Magrina, and many others. And thanks to this project, well, we use this word project, we've had more than 500, well, surgeons who worked at our center in one operating room, competing with one another. 3 operating rooms, 4 operating rooms at the same time, and each showed classy surgeries. I am dreaming of the time when, again, at the Kolokov Center, we'll be able to bring together all these wonderful specialists, wonderful surgeons, all my colleagues from other countries and from Russia. Dear colleagues, today there will be 63 foreign presentations from 9 countries, and I am absolutely confident that this program will be a success. I don't want to speak volumes, but I would like to wish all of you, especially in this difficult time, all the best. Without the help of people who are dear to us, without the help of our friends who believe in us, who believe us and who bless us. First of all, of course, my family, my daughter, as Professor Suhik has mentioned, she lives in the United States, but she is also in charge of this program. My, well, grandson Edik helps me in organizing this Congress. My colleagues and the students, I have more than 100 of them who have PhD and advanced degrees. They are members of our team. Thank you very much. And I give green light to our Congress. Thank you, and let's start the Congress per se. Well, dear colleagues, I would like to give the floor to the director of our center for his presentation. Director of the National Medical Research Center for Obstetrics, Gynecology, and Perinatalology, Mr. Gennady Suhik. And after this wonderful opening ceremony, and please, the floor is given to Gennady Suhik for his presentation. Dear colleagues, dear friends, of course, it's a great honor for me to open the 36th International Congress, New Technologies for Diagnosis and Treatment of Gynecological Diseases. This Congress has its own history, and it's an interesting history reflecting the development of obstetrics and gynecology in modern Russia, and it will be a 4-day Congress, and there will be training courses each morning, and of course there will be a young scientist contest on Friday. Also, there will be 8 plenary sessions, so that's a classical format. I'd like to remind our foreign colleagues that the Kulakov Center is the only center for obstetrics and gynecology in Russia that has such a strong potential, and we had almost 9,000 births. Last year, we have 25 operating rooms, 20 delivery rooms, more than 28 labs. We have about 200,000 counseling per year, more than 1 million tests per year, and we have 9 institutions within the framework of the Kolokov Center in different parts of Russia besides obstetrics and neonatology. We also are in charge of the Institute of Reproductive Medicine, Institute of Microbiology and Antimicrobial Therapy, such areas as anesthesiology and resuscitation, professional education, and other issues. So we also have the Western Educational Center. We have the Tolson Center on our grounds, and of course there is a medical center that plays an important role of Russia. We're talking about more than 30,000 patients treated per year altogether, 26,000 surgeries, and we have almost 200,000 women counseled. Of course, we're talking about women's health first and foremost, but we do not forget about the male factor. We're talking about personalized medicine. Women's health is not just medicine, it's also emotions. The social part is an integral component of it. Spiritual issues are also of paramount importance, as well as economic factors, cultural factors, political factors. At the same time, we understand it perfectly well that the biological component remains dominant. Unfortunately, I must say, as I look at the slide, well, of course, we're glad that in November 2022, officially the population of the Earth achieved 8 billion people, but the right part of the slide says that the birth coefficient, the birth rate is very low. In 1960, it was 2.54 children per one woman. In 2022, it's 1.5 births per one woman. For reproduction, we need at least 2.2 births per one woman. And it's not just our problem, it's the global problem. Well, except for India and China and many Western countries, countries of North America, countries of Europe have the same problems of low birth rates. And of course, that means we need to reduce the number of medical abortions. We must do everything possible to use the mechanisms shown on the slide, all the instruments to reduce the number of abortions in the future. And we did some calculations and, well, advertising, counseling, well, educational activities, psychological support of women at this stage, as well as the financial support, can preserve from 45,000 births and even more. So the government of the Russian Federation is doing a lot to achieve that. We understand it perfectly well that we live in a special time, the time of scientific achievements, and today that means we use a different kind of therapy than yesterday's therapy. That means new means of diagnosis, and even if we look at women's support, we understand it perfectly well that 1% of women in the population needs ART, and by the end of this century, the situation will be different in terms of the age of women who need ART, and ART will gain importance. We can see that ART has become more technologically advanced. ART has a lot of potential in surgery. ART means providing more support for women, including the introduction of AI, artificial intelligence, as well as genetic testing, well, the use of hormone replacement therapy, but in the future, there will be also modifications of our microbiota or microbiome. In the future, we will see the use of cellular technology and gene therapy. So step by step, we'll be paying more and more attention to these aspects. As for reproductive genetics or genomics, of course, that means an integration of technologies. And we cannot solve the existing problems without this. Of course, we need data management, bioinformatics, clinical management in the process of diagnosis, the selection of the best possible treatment. That is why reproductive genomics today means PGT and full exome sequencing, also female infertility due to aberrations, chromosomal aberrations. Mitochondria has its own DNA and genetically important molecules. Of course, here we're talking about ethical issues when we deal with this important problem, which hasn't been fully studied yet, but our American colleagues will be talking about that, issues related to genome editing, especially non-semitic cells. We understand it perfectly well that with the development of molecular and cellular biology, we have a better understanding of cellular management. Evolution has done a lot in this field, and we realize that when we're talking about reproduction, when the oocyte meets sperm, it's a kind of a workplace affair, a workplace romance. It's kind of war and peace in terms of complexities, including different stages of diagnosis, treatment, where modern scientific thought can be used. We understand it perfectly well that when we study the early problems of embryogenesis, we now have a better understanding of male and female pronucleus, what contribution the pronucleus makes, the complexity of all these processes when we use different time-lapse systems. Well, you can see the pronucleus dance shown here, and these are the first steps for future life. Of course, well, the blastocyst staging is also important. This process is very complex. That means new development in science. And of course, this is a multifaceted process. It is being described here. Something is marked in red, and you can see the blastocyst stage development, different genetic events after implantation or epiblast polarization, differentiation of trophoblasts. All these stages are very important. All stages are of paramount importance. Nothing fades into the background. It's important for a future life, for the early development of the embryo to the transfer to the fetal stage and then to the birth of a human being and to the future diseases that this human being is going to have. There are a lot of factors involved in all these processes which take place in vitro. So we go back to reproductive technologies, and you can see different statements here related to blastocyst implantation. Like Goethe said, that life means symmetry, the cellular orchestra and the cellular symmetry. And Here you can see the results of the work of our center, and well, now we can cultivate embryos up to the 14th day. We can see the different cellular composition. It's very important for the fetal studies and analysis of early embryogenesis, especially when we use transcriptomic technologies, modern genetic studies in reproductive and perinatal medicine. And in fact, these three slides were devoted to this issue. And now, as for reproductive medicine, we use modern methods at the early stage of the embryo development, at the early stage of fetal development, and especially when we have chromosomal aberrations or genetic surgeries. Like in the United States or like in the UK in 2021 as part of the Exome project, we did the analysis of 8.5 thousand newly born children, and you can see that we're trying to detect monogenic disorders within the first 7 days, and you can see the percentage of chromosome aberrations, and this percent is quite significant. So out of 8.5 thousand newly borns, well, you can see more than 120 such chromosomal aberrations, and patients with a critical phenotype, 122 to be more precise. And thus we can say that out of 245 people, well, there are 8 newly borns who are subjected to extended neonatal screening for 36 diseases, like in the United States or in Western Europe. Within this project, we've had a chance to describe 39 mutations which hadn't been described earlier, associated with monogenic diseases, and 3 genes which are not associated with monogenic diseases. So the question is what these programs are for. And the answer is very simple. The earlier we diagnose these immunogenic diseases, the faster we can treat them. And in Russia, about 8,000 children are born with this pathology in every year. So we need personalized genetic drugs that will be used as part of personalized medicine. Sometimes a specific drug can be used for one patient only. I'm very proud that we have embarked on this path, and personalized medicine, personalized drugs will be used for our patients. Gynecology involves 4 groups of tumors. That's ovarian tumor, breast cancer, cervical cancer, endometrial cancer. And the sad thing is that in 2021, we had about 130,000 women diagnosed with this pathology, and a little bit more than 40,000 women died because of cancer of reproductive organs. That's very sad statistics. So right now, without molecular diagnosis, modern oncogynecology is impossible. It involves a lot of different technologies, such as surgical technologies, and of course, there are fundamental questions. What does the tumor consist of? How did it appear? Well, what is the structure of the tumor? How does the tumor develop? And of course, well, the signature profiles, molecular signatures, well, also intra-tumor heterogeneity. We're talking also about the algorithms of testing. Well, what's the time allocated for each test, and many other issues related to tumors. Interpretation of the results of testing, that's another big problem of modern oncogynecology. And of course, what's the goal? We do this to make the right diagnosis and to improve treatment. So without molecular testing in oncogynecology, we cannot achieve our goals. And here you can see issues related to the selection of therapy, identification of sensitivity, recurrence, well, clarifying the diagnosis, and many other issues. That is why, going back to what I have already said, well, and here you can see signal cell transcriptome technology or sequencing provides a lot, not just for science, but also for practical medicine. We understand it better what particular cells work well or do not work in this situation over the last 3 years. A lot has been done in our labs because we used different types of gene expressions, especially different methods such as PCR, cervical epithelial neoplasia, as you can see it here on the slide, how it can be treated using the blood lipid profile. We developed a system for treating this disease, also the diagnosis of epithelial ovarian cancer and issues related to rational therapies. Well, as for molecular biology, it opens up new prospects in early diagnosis and in treatment of cervical cancer, human papillomavirus. This pathology can develop very quickly among young girls, and also you can see that as a result of microRNA study, we have come up with new markers, and they allow us to choose the proper treatment and to make the right diagnosis. Of course, well, this kind of diagnosis is important to make prognosis about metastatic diseases into lymph nodes and to identify the lipid profile of the tissue, especially the tumorous tissue. The Kolakov Center has purchased a new system, DESI or DAISY as we call it, and we use the molecular profiling of biological tissues, which allows us to see the stages of cancer, to properly diagnose the tumor, to do the mapping, how the drugs are being distributed in this heterogenic tumor, and also molecular methods of imaging. Within the next 6 or 12 months, we will prepare more slides on this issue. And as for precision oncology, it has new goals. That is, when to start therapy, when a mutation can be considered as pathogen that has a clinical importance, what is the tropism of the tissue, to what extent, well, knowledge can be used to solve the patient's problems. And again, you're going back to Agatha Christie, ABC's murder. Knowledge is our weapon. Personalized cellular therapy is being developed, and targeted therapy, well, organ replacement therapy, it's part of personalized medicine. We've had a lot of experience. 30 years ago, in 1994, we had the first patient who was subjected to targeted therapy. It's a very powerful weapon. And right now, we are talking about ethical issues, perinatal sources of multipotent mesenchymal stromal cells from the umbilical cord.
And definitely amniotic fluid cells that to us, especially recently, became extremely important source, surprising source of information for using in cell technologies. We fully understand that definitely we use very wide panels. So this is cells from bone marrow, from the cord blood. So these are multiple sources of the cells. And this is outer and our sources, and at the same time definitely we use very actively use in gynecology different schemes of treatment, for example syndrome of premature ovarian failure, and you see methods how we get it, how we cultivate the results, etc., and also how and when we use it. Definitely these are not mainly myomas, but Asherman syndrome and also fibroids and reproductive infertility, male and female reproductive infertility associated with the premature ovarian failure, with the natural aging, polycystic disease, and definitely we start first works on extremely difficult area in cell technologies, and we are doing the attempts to recover spermatogenesis, which is deteriorated. So Sherman syndrome, endometrium, and atrophy, definitely receptivity of endometrial, and here we see very strong and realistic perspectives of using cell technologies in our practice. So probably about 3 years ago, we started getting different understanding of this philosophy. So different cells of the organism, especially stem cells, they release microvesicles, different molecules, and these molecules could be changed pharmaceutically, systemically, in order to clarify the diagnosis. And here we see the first options that allow us to master this technology and to use it. Speaking about modern achievements, within several phrases, we can say how important is endometrial microbiome and how seriously it could influence different reproductive processes shown here. This is endometrium, these are fibroids, polyps, hyperplasia, endometriosis, etc. And definitely this topic requires separate presentations, and definitely it is not the time to dive into the depth right now. At the same time, we go back to our center, we say that we have very strong equipment. Our journal, which is celebrating 100-year anniversary, which is called Obstetrics and Gynecology, it is extremely popular in our country, and currently we are doing it both in print and in online, and we started translating it into English, and hopefully our colleagues will aware about our recent achievements. So these are the schools which are carried out. We're very grateful to Academician Serov, who is the president of Russian Obstetric and Gynecology Association, and we're always grateful that Vladimir is now crossed 19-year-old age, and he's with us. He's very active, shining brightly, continuously generating new ideas. And for us, it's very important that within the next 6 months, we will launch the digital channel of our center. We see the project of the new studio that will be done, and then we'll be able to create us sort of a TV channel where we will represent obstetrics, gynecology, neonatology, reproductive, ART, molecular biology. All these areas would be shown here, so it will work for us, for Moscow, for 1 million plus population cities, and for the whole country all around Russia. And later on, we may think on how we can do it. So maybe some invitations with some presentations and bright presentations of our international colleagues. So the studio would be available for our cooperation. So unfortunately, the time is over. So life is like piano, playing piano, white steps, love and happiness, black one, sadness. And in order to get true music of life, We should touch both black and white. We should touch both black and white. With that, I'm extremely grateful for your attention and I wish you all the best. And I'm very grateful to the colleagues whose names are here on the slide. Without their help, this presentation would never be possible. Thank you very much. And I wish you all the best and very fruitful Congress. Dear colleagues, dear friends, exactly at 11 a.m., we should have the connection of Professor Mareska, and we have few minutes of time. So once again, just for a couple of minutes, I would like to draw your attention to the following. So currently, in our Congress, we have registered more than 3,000 participants, and they are registered in advance, and they are waiting for our broadcast. I remind you that daily our Congress will start with the broadcasts every morning, and every morning we'll start from endoscopy from 8 to 10, 8 to 10. So today we had a broadcast of Arno Vatiez from Dubai, hysterectomy from Dubai, Arno Vatiez, and tomorrow we expect broadcast of Professor Malzoni from Italy. And the day after tomorrow, we are expecting broadcast on hysteroscopic surgery. This is very important, and I kindly ask you to be with us exactly at 8 a.m. So that's extremely useful and interesting. Let me remind you that our Congress is providing credits of continuous medical education, so it has great educational potential. Besides, all those participants who are registered at our Congress, who registered in advance, would have access to all the materials of the Congress within few minutes. Then the access would be closed. And another notification. You see that our agenda includes multiple sessions, and you will see presentations from 19 countries. You will be able to listen best surgeons of the planet. Listen to them. You will see fantastic geneticists. You will get acquainted with new immunologists and also our national professors who will speak about surgery, about rehabilitation, about the implementation of new materials. And I would be happy if Jacques Maresco, who is in the agenda, would start his presentation, and I would be happy to give him a few more minutes for the welcoming. Dear Professor Maresco, it's a great honor and pleasure that you are with us today and always. It's a great happiness that you are our teacher, that you are our friend. I personally know you for many, many years, and I twice got specialization of robotic surgery in two sites, first in Strasbourg, and you allowed me to work with pigs for 2 days and then to complete the course and to pass the exam with this fantastic electronic course and also to do the surgeries in your center. So fantastic, great, fabulous center in Strasbourg that is established by Professor Maraska, who is a true leader, true pioneer in this robotic area. So I do hope that in your lecture our colleagues will know the most important and most sensitive things in the robotic surgery, but also we would be happy to get your vision, your view for the future. So how far we will go there? Who is most important, AI or human intelligence? And now, who are important? Maresco, Adamian, Tots, Vatiez, Konix, and many others, or robots are more important. So it's a special bonus, and I start your presentation. So, dear colleagues, now we start our marathon, our great marathon, and the first here to run is the professor of surgery, and the president and the founder of the Scientific and Technical Institution of Intestinal Cancers, ERCAD, Strasbourg, France. Professor Jacques Marasca, our great friend and our great teacher. How computer technologies are changing surgeries in the small pelvis organ. How do they change, Jacques? Please let us know. Microphone is yours.
Thank you very much, Leila, for this kind introduction. You know that for me, it's always a pleasure, an honor to be connected with you. And each year I say, next year I hope to be physically present, and I hope that next year I can travel in Moscow because it is really a city that I love. So you asked me to speak about how computer science changed pelvic surgical procedure. And I will try to answer and to see how important today is artificial intelligence, robotics, especially for pelvic surgery. So just as an introduction, that is IRCAD France. That is the institute we work in. We start by one building. Today we have 4 buildings connected together. And we work on only on this concept of augmented surgery. And the place of gynecology is a very important position also for us. You know that, especially with you, Leila, because you were a lot of time in Strasbourg, and with Professor Vattiers. So what is the concept of augmented surgery? For all the specialty, it is the same. The first one is augmented vision. And you all know in all the specialty that that can be fluorescence, hyperspectral, multispectral, but also what we call augmented reality. And we will see that in your field of interest, especially for endometriosis, how important it is. The second one is robotics. And you know that you have normal robots for gynecologic surgery, but you have also specific robot. And we will speak about the new one who is going to arrive in IRCAD in some weeks, which is a Momentis robot, totally dedicated to a hysterectomy by a transvaginal way. And after that, you have, you know, artificial intelligence, which is totally connected to augmented vision and augmented hands. That means for the robot. So that is a team of 30 engineers here in Strasbourg. We work on that, but also we work with a team in Taiwan, and we don't work with, but we have a team in Rwanda, because in Rwanda, in Africa, which is the smallest country in Africa, they have the 2 best university and schools for artificial intelligence. The one is a subsidiary of Carnegie and Mellon University, and the other one is African Institute for Mathematical and Science. So we have a lot of engineers also in Africa. So just to speak about the first challenge, which is augmented eye. So for your specialty, that means pelvic surgery, that can be, for example, for retrograde, that is our indication of pelvic surgery. That means how by transanal way we can see all the details of the anatomy. So that is an example of a transanal way. You imagine that the transvaginal way, it's exactly the same thing. And that means you can have like a GPS to understand all the anatomy. That is a fantastic example for you. It is endometriosis, because we all know, I don't know, I have never operated severe endometriosis, but I have seen a lot of live procedure, especially by Arnaud Vattiers, and we know how difficult it is. And the first thing which is difficult is to know how endometriosis is going inside, for example, rectum or sigmoid. And here you see that we can have in green the position of the endometriosis, and to know if there is an invasion in the rectum or in the sigmoid, what we have to do is just to do a navigation inside. So here we see very well the rectum, we see the vessel, we see the ureter, but we need to see inside if there is really an invasion, because in this case, we know that we need to do also a resection. And you see that immediately we see that the endometriosis is inside the rectal wall, so that changed totally the operation. And after that, so you have seen the planning. After that, what is important here is just an image for for the liver, but it's the same, it's the fusion between the virtual image and the real image. And we know that if we have a fusion, we can see in transparency without any problem. And that is the reason we have performed a specific operating room, an hybrid operating room for the image. And you see that in this operating room, we have the CT scan, we have the MRI, we have the robotized CT scan. But for your specialty, what is the most important is the MRI, because we know that we need to have, especially the details of all the pelvic nerves to avoid any injury, because we know how important are the sequela. And the unique way to do it, not only to have the CT scan, but you see to have the MRI. And with the MRI, we are able to reconstruct the pelvic nerve, but we know that is today long. You see some example that has been done before the operation, and before artificial intelligence, it was some hours, but that changed. And we know that that is the reason why we have created a spin-off, which is Visible Patients, today in exclusive license for Johnson & Johnson. And you will see that for all the organ, today I want to show the most difficult organ to reconstruct, which is the liver. And you see that with artificial intelligence, before the COVID, it was, so 2019, it was to reconstruct the trachea, the bronchus, the veins, the arteries. It was 4 hours semi-automatic. And 1 year after, because we had 1,000 of cases of COVID to analyze for the machine, it was 9 minutes, fully automatic, with 2 patents, 1 American patent and 1 European patent. And we know that in 2020, it was 9 minutes. Today, it is 6 minutes for the pelvic, for example. It is 4 minutes for the liver, and it is 3 minutes for all the vascularization of the colorectal approach. So exactly the same for the reconstruction of the uterus today. That means all the pelvic part will be between 3 and 4 minutes, totally automatic, without any human resources. So that is for the vision, augmented vision, which is certainly the most important part for all the specialty to improve surgery. Now we have to speak about augmented hand, and especially for you. So first of all, how we can integrate the image in the robotic system. So here you see the robot that you know, which is a Da Vinci robot. It is a robot, Leila, I know you work with. And you see that for pelvic surgery, which is here my specialty, that means rectal cancer, but it's the same for an uterus cancer. You see that the surgeon has, like a GPS, the 3D image, and when he is immersed in the master part of the robot, you see that he can see the normal view and he can see the virtual view. So on the left, the virtual view, on the right, the normal view. So you imagine how important it is to improve the surgery for the surgeon. Something interesting also, not only because we have done that 20 years ago, but you are going to see how many teams today develop that after 20 years. We were impressed, and that is very important, especially for severe endometriosis, to have another team which can be connected with one team to support not only like telemedicine, to support intelligence or knowledge, but also the skill. And that was what we have demonstrated in 2001 with the Lindbergh operation, where I was in New York and my patient was in Strasbourg. And it was a simple operation. It was a cholecystectomy, but it was a revolution of what we call the information area, because it was the first time that with a very low delay, we were able to do a total procedure for one continent to another continent. So that was a Lindbergh operation published in high priority in Nature. And today, after Lindbergh, what we see a lot, so Lindbergh, we have performed 2001. And that is very important, how to share the skill of a procedure. It was done with 14,000 kilometers. Now with the 5G, you see that you have a lot of preclinical, we have a lot of publication from Chinese team. It was with a 5G, it was 3,000 kilometers, and still they had a latency time of 264 milliseconds, which was difficult to operate with that because we need to have less than 200 milliseconds. Some months ago, you had a publication of a Chinese team, clinical case, also cholecystectomy, nearly 5,000 kilometers, but in the publication, we don't know what was the latency time. And last week, Vipu Patel, which is certainly one of the best pelvic surgeon for male, that means for prostatectomy. He has performed more than 15,000 prostatectomy with a robot. You see that with this company, Chinese company, he has performed telesurgery with 120 kilometers. And this time we need to confirm, but he said to me by phone this morning that the latency time was 50 milliseconds. If it is really the latency time for the gestual, for the skill, that is a fantastic project, because that means that for free of charge, you can do a teleoperation, and that is the only way to totally decrease what we call the learning curve, and that is for all the different specialties. One word, so you have seen what we have done with the robot. Another thing which is important, and also for your specialty, is what we call robotics and flexible endoscopy. And for you, because we need the triangulation, you have a robot which is on the market. We will have one prototype in the next 2 weeks. It is Momentis. So Momentis company has a robot whose name is Anovo Surgical System. Momentis is the name of the robot. You see that it is a very, very light robot. A part is rigid to go through the vagina, and you have a flexible, two flexible system of operation, and you can perform a retrograde hysterectomy per the transvaginal way. You have just to put a little optic of 2 millimeters, for example, in the umbilic, because you see that this robot has no camera. So you have the rigid system, the flexible system, and you need to add this little camera through the umbilicus. And today you have a lot of other robots progressively. Another one is EndoQuest. EndoQuest is a flexible robot that you see here. Today it's only for low GI application. That means, for example, to do the reduction of a tumor of the low sigmoid or the rectal tumors, but you imagine that because it is exactly the same, we can imagine also a transvaginal hysterectomy. And this robot has not only 2 instruments, but he has also at the tip of the flexible system a camera. And another one is EndoMaster. EndoMaster is developed today in partnership with Pentax in Hong Kong. So that means that you will have a lot of robots, especially for your specialty, if you want to have and to develop what we call a no-scar surgery. I want to finish about augmented brain, and that is validation for all the specialties. That means how we can imagine to have a better strategy, how we imagine to have a total control during the operation of what we do, and how artificial intelligence can inform the surgeon if he doesn't follow the international recommendation. So we have 3 steps. We can have artificial intelligence and surgery. The first one is a diagnosis, And if we can have some sound, but it's not mandatory, you see that that is the robot Watson. That was the first generation of 7 years ago. And what is important is now they will have a new generation that was done only by MD Anderson. But what is important will be that Watson 7 years ago was able to read nearly 4,000 books and 250,000 journal articles. And now you imagine, especially with the progress of artificial intelligence, that it will be more than the double. That means something that the human brain is totally unable to do, to give for the patient the best strategy that you want to perform. So step two, so that is the step one before the operation. During the operation, you have two possibilities. One is to say we need to control the operating room. That means we need, as an airport, you have a control tower. In the operating room, you can have a control tower, and you see that we can have, and we can integrate all the preoperative image, the external image during the operation, the minimal invasive image given by the laparoscopic camera or the robot, and all the physiological signals given by the anesthesiologist. And after that, what we have done with a subsidiary of Medtronic, whose name is Integration Health System, we can follow the impact of a minimal invasive access surgery until the patient go back to work, which is the most important for a society and especially to do some economy. Another possibility, I have no example for gynecology, but that is what we can call a pelvic surgery because it is hernia repair. You see that today the machine is able to recognize all the different anatomy, and we know that for hernia repair, for example, we have what we call the triangle of pain that you see on the right. We know that we have to do no suture, no clip at this part. So you understand how more and more intelligence artificial will be able to analyze in real time the operation you perform and can give some alarm is what you do is not what you need to do. And the step three is how artificial intelligence is important for the postoperative period. You know that it is exactly the same for gynecological surgery than for digestive surgery or the other one. We need to say to the patient to go out of the hospital before 48 hours. And for that, we need to have a connection. And we met a fantastic startup from California who moved in Strasbourg, and you see that with a little patch, the size of a patch of nicotine patch, you have in real time continuously electrocardiogram, saturation of oxygen, respiration rate, activity, detection of falling, skin temperature. So that means because it is continuously parameters that the patient has a better follow when he is outside of the hospital than if he was still in the hospital. So that is for me also a revolution. And we need to understand that minimal invasive approach for pelvic surgery, which is the same that abdominal surgery, it's a total environment was to be minimal invasive, and that is also for the postoperative period. One word about real life, and that is also true for your specialty. It's is that we speak about very sophisticated system, but the real life is not this one, because a report of WHO 2 years ago, 2021, is that 5 billion of the worldwide population don't have access to any medical imaging. And in Lancet of the same year, that 2.3 billion of the world population don't have access to surgery. So that is not only for Africa, that is really worldwide. And that is the reason why we have developed what we call a low-cost system of detection of tumors. And you imagine that would be exactly the same for pelvic tumors. So with a very low-cost probe, we can do an automatic detection of tumors. And we know that if the tumor is less than 2 centimeters, we can destroy the tumor. That can be by radiofrequency, cryoablation, microwave, electroporation. And I just want to show you how it works. That is a mannequin, but all the data are from human data. You see automatically with a low-cost probe between $500 and $2,000 for the most sophisticated probe, you can have an automatic detection of a little mass. But after that, we know that it is difficult to have to understand a 2D image. So we need to transform this 2D image in a 3D image. And for that, when we have a lot of data, the best way is a low-cost robot, because if you do the ultrasonography with a low-cost robot, first of all, you don't need any radiologist, and you see that we can acquire 100 images per second. So you see, I repeat, with a low-cost probe and a low-cost robot, and immediately in real time, you have the 3D modeling. So it is not a 3D probe, it is a low-cost 2D probe, but you see, we have all the 3D arteries, vein, and we can see the tumor. So that is the best way for the surgeon to do a procedure of thermoablation. Just a word about the training of robotics, because we speak about robotics, artificial intelligence, but we need training on site. And today you see that certainly in Europe, we have the most important training center. We have 16 robots from Da Vinci, from Intuitive Surgical. Leila knows very well that. We have 1.5 floors. And during the COVID, we decided to open another building just connected to our building, just dedicated to robotics education. And you see that we have different type of robot. We have the robot from Versus from Cambridge Medical. We have the robot Hugo for laparoscopic surgery, but not only, we have also neuronavigation for neurosurgeons. We have a robot for spine surgery. And today, because we have a lot of new company, EndoQuest, Medicaroid, Avaterra, Momentis, we have renovated again 800 square meters to have 10 robots more. A word which is important also for all the specialty, and we have a big part for pelvic surgery, it is free of charge. So it's not a publicity I do, it is free of charge. It is web search, virtual university, and with the development of artificial intelligence, we can have that more and more efficient. And you see that we have nearly 500,000 of active members following this virtual university with all the different specialty. And I finish to say that today for research and for training, we cannot do that only on one site in Strasbourg. So today you see that we have 8 IRCAD in the world. We have France, we have Taiwan, we have 2 in Brazil, we have Rwanda, Lebanon, India. And my dream, Leila, know that I would like absolutely to have one day a center in Moscow, because I know that in Russia today you have no training center like what we have in IRCAD. And when I say training center, it's not a training center just for education. It's also a big part for research and to be a really actor of application of artificial intelligence and surgery. So thank you very much for your attention. And if you have any question.
My dear Professor Maresco, when I visited you, and it was many years ago, and for the first time I saw that fantastic universe, that fairy tale, I was amazed, I was knocked down, and you allowed me to touch this genius creature, I call it like this. And I asked it, why do we need all that? And you simply told me, Leila, believe me, not in every corner of this planet you can be operated, or you can operate. The point of this robot robot is that if there is a technology available and the master is somewhere in the available place, here is Leila, there is Maresca there, Harry Rich and Vatias are in their sites, then this technology could be easily transported in distance and the surgery can be done in distance. So today you are telling us that we already, for 5,000 kilometers, we can easily do the surgery. So we are here and you are there, and somewhere in the islands or in the ocean, some catastrophe happens, and they have the robot, and we can do the surgery. So today I'm completely knocked down by your dreams, by your vision. But life shows sometimes that the dreams of Professor Maresca always come to reality, always come true. Dear Professor Maresca, please tell me, from all the robots you mentioned in your presentation, I performed 18 robotic surgeries using Da Vinci. But these 18 surgeries performed by me, I performed all spectrum of gynecological surgeries. So that was hysterectomy, myomectomy with ovaries, endometriosis, and congenital defects, and colpopiasis, everything. And I really loved the robot. I was amazed by the situation, that intuitive feeling, like robotic surgery, it's a continuation of your fingers. It's a work inside the cell, but not outside the cell. So I'm your fan. I love you. And I think I'm most aged student who already twice got certification of robotic surgeon. And now my question. Dreams. Dreams of Professor Maresco. You showed us your vision and your dreams, and I even put them down here on paper. So these are not just the surgeries, this is also diagnostics, etc. Could you tell us once again, from today, what would be next? What could be next step? What else can we do in the robotic surgery? Definitely, sometimes the price is quite toxic, price of disposables, price of robots. But if we speak about the global significance of this surgery, then price is probably not so important. But what is very important is that we can widespread it. What are your projects that are next steps, and how far we can go with robots? So, aren't you afraid that we allow artificial intelligence let go so far? So maybe 5 more minutes of your time and 5 more minutes your philosophical realization of the future. You know how much I love you. I love to listen to you. Please, floor is yours.
Ваши мечты.
Your dreams. Your dreams.
Leila, for me it's very simple, because you have the problem of cost and you have the problem of the evolution of surgery for the future. You know that the problem of cost is only a problem of competition. And I think that very few surgeons know that the number of companies you have today of medical surgical robots, 131 companies. Every year you have 3 new companies in China, for example. So that means the cost, and you have seen, for example, Intuitive Surgical, they just decreased the cost nearly 1 million less when they have seen a competitor like Medtronic, etc. What we have to say is today it is a prehistory of robot. That means it is a robot which just allow to democratize minimal invasive surgery due to the number of degrees of freedom. And you know that a lot of surgeons are not able to do a very focused surgery with this rigid laparoscopic instrument. That was the case of all the urologists in the United States. They were unable to do that by laparoscopic surgery, and they moved immediately from open surgery to robotic surgery because it was absolutely easier. For all the specialty today, you have 100 papers about the role of robots, cost effectiveness, etc. And it is very difficult today to see the real advantage for the profit of the patient, except the fact that you democratize minimal invasive surgery. But more and more, you see that the robot is more and more smart. That means you have the integration of the image that exists for intuitive surgical. That will be for the robot of Johnson & Johnson using our spin-off visible patient. That will be for Hugo using the Fuji system. So that means the robot is going to be more intelligent because you will have something like a GPS in a car. And the evolution of surgery for the safety of the patient is exactly the evolution of the car, artificial intelligence and car. And you know that's something that never we would have imagined 20 years ago. Today, nearly all the new generation of car, not only Tesla, but BMW, Mercedes, you can have a total automatic control. That means they understand everything because they have not two eyes of the driver, but they have 9 cameras, etc. So it's exactly the same. And what I have shown, that means the integration of artificial intelligence to control in real time the procedure of the surgeon, that will be an exceptional revolution because you imagine that, for example, a simple operation like a cholecystectomy, if the surgeon has not very well dissected what we call the triangle of safety, immediately the robot will stop. That means the artificial intelligence will say, no, stop. You need to continue a perfect dissection. And after that, you can go and move on for the second step. So just to understand to your question, I think that robot is going to democratize minimal invasive surgery for all the different countries. The cost will decrease. The quality will be a total change. I say today it is a prehistory of robotics. We will have smart robot, semi-automatic, and one day, certainly perhaps 20, 30 years ago, it will be automatic. Because when we speak with our engineer, we see that we can imagine an automatic right hepatectomy, for example. They say there is not a problem if the machine has all the data. So what you say, that is our dream, but progressively we see that these dreams can give reality. So that is the evolution. We work a lot, and we are very proud to have a very, very strong team in Africa for artificial intelligence, and they support us a lot, so we go faster and faster. And I want to thank you again for your kind invitation. I hope to see you in the near future in Moscow. Thank you very much, Leila.
Еще один вопрос, последний.
One more question, the last one. Could you tell me, please, Professor Maresco, aren't you afraid of robots? That we won't be able to control robots? That the robot will be so smart that he will tell you, wait, Professor Maresco, you made a mistake here. Leila, you're doing the wrong surgery. Let me do it. Aren't you afraid that robot might say that? Can you answer this question? The patient might suffer.
My question is no. I am not afraid. It is exactly again like the automatic car. Nobody today is afraid about automatic car. No pilot is afraid by automatic fly because the machine is better than the human. So what you have to understand is that always it will be the control of the surgeon to make the best operation, but the surgeon will do the operation the day before with the machine. That means the day before, with the digital clone of the patient that I have seen, you are going to propose the operation. And you will be in a phase you can have a mistake. So you stop and you continue again. And I remember that the chairman of Stanford, for the first paper we have published, that was in 1998, he said the vision they have in IRCAD in Strasbourg is exactly like a realizer makes a movie. That means the surgeon is going to do the operation. He has a little saying, 2-3 minutes, he's happy, it's okay. He keep. He's not happy, he do again, etc., etc. And at the end, you have the fantastic good movie. At the end, the surgeon would have the fantastic best operation he can imagine. And after that, he gives all this data to the robot, and the robot will perform the operation, and the surgeon will be the supervisor to be able to stop the machine in case something happens. But we are not afraid by the machine. We need to because we need to give all the information to the machine, and that is still the human brain to give that.
Jacques, sometimes people ask me, you know, my age. Well, I'm not young anymore. And they say, Leila, well, maybe you're sick and tired of surgeries. You're every day in the operating room. You've achieved a lot. But I want to say, well, maybe my brain is still working and my brain still dreams because each day I encounter people's problems, people's grief. I can help them. And I am dreaming of meeting with you. Well, because it's our destiny. Such people like you make progress in medicine. Thank you very much. Thank you for your friendship and thank you for your presentation. Thank you very much. Well, dear colleagues,
Last word. You look 20 years old, Leila. So don't say that you have some age. Goodbye.
Спасибо.
thank you very much. Dear colleagues, one more fantastic person, and his name is Javier Magrina. Javier Magrina is our real teacher of all gynecologists who are involved in robotic surgery. Professor Magrina is a professor of obstetrics and gynecology of the Mayo Medical Clinic. He's the director of the program on minimally invasive surgery at the Mayo Clinic, the state of Arizona. And he woke up early in the morning, especially for us, and he will be talking about robotic applications in surgical gynecology. Professor Magrin, please tell us about the stages and our opportunities. Dear Javier, good morning to you. The floor is yours.
Good morning, Leila. It's a pleasure again to being here with you. And I look forward that the time that we're going to spend that is going to be worthwhile for your people attending your course. And again, congratulations for another successful course that you have up here. So I'm going to share the screen, and we're going to be addressing today what we consider being about indications for robotic surgery. So I need to put this one up here. We're going to change this. This is our institution that is on Arizona, and it was started in 1987 with 45 physicians, and now it's 651. I started doing robotics and gynecology in 1997 using a system called ESAP. Then we used Zoo's robotic system in 2003, and since 2004, we've used the Da Vinci standard, the S system, the SI, the XI, and since 2019, we're using the single port, which, by the way, in the United States is not approved for general use for gynecology, but is being used as a research tool. So basically, what does the robotic do for you? It allows you to reach areas of difficult access, like in the liver, the diaphragm, the deep pelvis, areas for extensive suturing, like sacrocolpopexy, fistulas, complex dissections, where you need to be very precise in your dissection, high precision lymph nodes, reimplantation of ureters, and then in the United States, because of the epidemic of obesity, which is a problem, the robotic system does not increase the OR time as compared to patients which are thin, like laparoscopy. So the main indications are going to be obviously oncological surgeries because they tend to be more complex, as well as advanced endometriosis. And then obviously on patients with obesity. And then anytime you need to use high precision and suturing like fistula repair. So I'm going to show you now a few examples of some of those surgeries. This example of a suture that was placed by a vaginal surgeon to suspend the vaginal, but it was including the right sciatic nerve and the superior gluteal artery. So we're now here into the right side of the pelvis. This is the external iliac artery up here, right there. That's the superior gluteal artery. This is the lumbosacral trunk, and this is sacral root 1, totally inflamed by the suture, which is shown up here in the black color and in the yellow color. Now, this is the lumbosacral trunk, superior gluteal artery, and all my surgery was here to discovering the suture, find a suture, cut it, and it's great pleasure to cure a patient by removing the suture. Like I said, this suture is supposed to be in the sacrospinous ligament, but it was placed much higher through a vaginal approach that incorporated this. You can see here that it involves the sacral root 1, it involves the lumbosacral trunk, and here is the nut that it was already outside of the vagina. So you can see that it incorporated all the structures, and that with a single cut allows you to do this. Now, this is a perfect indication for a robotic system, a small space where the articulation is very helpful. Another example is endometriosis that is involving the pericardium. You see up here the area of endometriosis in the diaphragm, that it was covering the area of the pericardium, and in the process, there was a couple of openings up here where we put them together and then just sutured this in one piece. Again, this laparoscopically is accessible, but it's much easier to do because of the articulation and the suturing when you're doing this robotically. We have at least about 5 patients with this condition. As you know, the pericardium is only about 1 or 2 millimeters thick. And when we finish, we want to have a good closure of the pericardium because it has about 60 cc's of the mucopolysaccharide fluid, so that the heart doesn't get attached to the pericardium and produces problems for the contraction of the ventricles. That's the second suture. The most important here is so that the sutures can be dissolved so that the heart does not get attached to this area. This is the same suture or type suturing that you will see later in another video, where we are actually attaching, closing the diaphragm for a recurrence of ovarian cancer. That's a patient that had an adenosarcoma of the uterus. She did not follow up. She had a recurrent adenosarcoma into the right pelvis. And then we proceeded to the resection. Here is, I'll stop for a second, external iliac vein, the right external iliac artery, the hypogastric vein and the hypogastric artery, which were being involved by the tumor. You'll see up here, this is the tumor, and this is the hypogastric vessels. The pelvic side wall was free of involvement. This is the ureter, which was totally blocked. The right kidney was non-functioning. So the urologist, when I finished, removed the right kidney. We didn't have to reimplant it. And now, because of the advancement of the stapling that we have, we're able to, instead of ligating those vessels, we just proceed to vascular staples. Also very important to take them separately, because if those artery and vein get connected, you could actually produce an arteriovenous fistula. So we want to take them separately. And we finished with the monopolar spatula. That's my favorite instrument for monopolar in robotics, because it concentrates the electricity, and I use a maximum of 35 watts. There was no tumor attaching the pelvic side wall, so we had free margins. And we resected a portion of the bladder, a portion of the small bowel, and also a portion of the vagina. And then we sutured it back together. This is a probe into the vagina. And then the tumor is free in that case. Another good example of indications. Now, recurrent cervical cancer, sometimes patients need exenteration. That's an example of a total pelvic exenteration. Supraelevator. That's for us the main indication to proceed with this. So we are right here on the right side, dividing the paravesical space.
And vital structures are now adequately identified, with the ureter being medial and the major vessels lateral. Ureter dissection. The ureter is further isolated with adequate blood supply along its sheath and clipped before it is transected. Proximal clip is attached to a suture to help with identification and traction during the surgical procedure.
That's important.
The ureter on the left
Dilates the
will
ureter.
later allow for injection to the ileal conduit, and the ileal conduit will be on the patient's right. The same step is then performed on the other side.
That's the other ureter. And
Posterior
we go
dissection.
posteriorly for the rectum.
Posterior dissection is then performed after completion of the lateral dissection. The rectum is dissected off the sacrum and coccyx along the filmy presacral space. The remaining mesentery of the rectum sigmoid is separated as shown here. The dissection is performed bluntly to the level of the coccyx and puborectalis muscles posteriorly. The rectal stalks containing the middle rectal vessels on each side are ligated with an energy device down to the levator muscles. This frees up the posterior portion of the specimen.
That's a robotic vessel sealer. And we go for the bladder.
The anterior dissection is performed at the end to avoid having the loose bladder interfere with visualization during posterior dissection. The space of retius is developed anterior to the bladder and posterior to the symphysis pubis. Anterior peritoneum of the bladder is preserved for later reconstruction of the pelvis.
That's very important.
Using adequate traction and a combination of thermal energy with blunt dissection, the space can be easily developed with minimal blood loss. The superior vesical artery is then transected to connect the lateral space to the anterior space. The pubourethral ligaments are also transected.
Now we're going to cut into the urethra. You'll see the Foley
Inferior
catheter.
dissection.
That's the Foley
Inferior
catheter.
dissection is the pelvic diaphragm and levator muscles. The urethra, vagina, and rectum are transected to free up the specimen. A vaginal probe is utilized to identify the vaginal margin.
That's the vagina. And that's the rectum.
The mesentery around the rectum is dissected off the rectum to skeletonize the bowel and allow for a better seal with the robotic stapler. Again, a rectal probe is utilized to identify the rectal margin. Once dissected appropriately, the rectum is transected as distal as possible.
That's a robotic stapler.
The stapler on the outside of the chi robot allows for better angulation and wrist maneuvering to obtain the proper angle required to transect the rectum. The specimen is now free and is introduced into a bag for extraction through the vaginal hiatus.
So it's removed through the vagina in the back.
Reconstruction. The vaginal mucosa is closed with V-lock in the running manner. A second imbricating layer is placed. An omental flap is then created, and the omentum is placed distally over the base of the pelvic diaphragm to provide further tissue support to the closure. This shows the final appearance of the pelvis after extraction of the pelvic viscera as part of a total pelvic exenteration.
Recurrent ovarian cancer sometimes will happen involving the diaphragm, and in this case, the liver segment 7. This is an example of the CAT scan that shows the lesion located posteriorly. This is the lesion, the diaphragm, and the liver. I'm in the habit of marking my margins in the diaphragm and in the liver. This is a bipolar saline, which is a very excellent coagulator, not available robotically, so the assistant is using this. You can go deep into the liver and still have a good hemostatic feel. For the diaphragm is only a muscle that is about 2.5 millimeters thick, so it's very easy to transect with monopolar surgery, except that it has a contraction of the muscle if you use higher energy than 35. So once it's detached from the diaphragm, then we can elevate it and complete the resection from the liver by pulling up on the specimen up here. Again, this is the assistant because that's not available robotically. Then all we have to do is close the diaphragm, and I usually tell our trainees, think about it, would be the vaginal cuff, with the only difference that we do up here is that we lock the suture, and then those edges, which of the diaphragm, which continues to produce fluid and blood, you want to have them in the peritoneal cavity. So we pay attention to little details like this, bringing the edges into the peritoneal cavity, not into the pleural cavity to prevent a hydrothorax. This is an absorbable PDS suture. Before closure, we introduce a Red Robinson catheter. It's connected to suction. The anesthesiologist will give a Valsalva maneuver to eliminate all the fluid and all the CO2 that's present in the pleural cavity. Then we close it, we tie it immediately. And then after this, we put a lapretite, an absorbable, that's the assistant, an absorbable thing, and we have the diaphragm closed. Very easy because of the articulation of the robotic instruments. Another example of pure liver metastasis, but through a suprapubic approach, which is not possible to do laparoscopically. So this is the liver. This is the kidney right here. And I'm separating and elevating the assistant with a fan retractor, separating the coronary ligament until I can reach the tumor that is involving the liver. It was not known whether it's involving the diaphragm, but this is the diaphragm. It's free. You can see it's a nice plane. And once it's separated by division of the coronary ligament, then we leave the tumor that is attached to the right there. This is all free, and this is the tumor involving up here in the liver. So all we have to do up here is resect it from the liver, again, using the same saline solution. And the articulation here allows us to work in a small area with high precision. Then once this is done, we put it again into a bag, and then we remove it so there is no contamination. And we'll remove it at the end of the case. We just close it and we'll leave it in place. We check for hemostasis. And then another case of ovarian.
Professor Magrin.
Professor Magrin, I'm sorry. Could you tell me, please, how much time do you need to finish your presentation, because we're pressed for time?
No, I had 2 minutes left.
Сколько?
So we're good. Let's go to
Хорошо,
a
спасибо большое.
Thank you. 2 more minutes. Thank you. 2 more minutes.
No, I'm done. Alrighty, go ahead with any questions, Leila.
Professor Magrina, you made a brilliant presentation and showed everything. To add up what we mentioned before, I have no questions. I would like to thank you for being with us. Thank you for being our teacher of all robotic surgeons. I'm very happy that you participated in our conference. Thank you very much and good luck. Bye-bye.
See you. Great success. Bye-bye.
Thank you. All right. Now it's time for my presentation. Dear colleagues, it's time for my presentation. We must also mention our achievements. The title of the presentation is New Issues in the Treatment of Gynecological Diseases, Issues to be Discussed. I will show you several videos. And today, Russian medicine has made specific advances. We are pioneers in modeling of surgeries, in intraoperative navigation. This is particularly true of reconstructive medicine and reconstructive surgery. Dear colleagues, these pictures are very important because without them, you cannot do an organ-sparing procedure. Thanks to the achievements of the Kolokov Center and thanks to the development of 3D technology, MRI, CT, IVUS, and thanks to the achievements made by my students, we can do without the robot, but we can reconstruct different procedures. In the future, I will make a special presentation on my own operations. That's a spiral operation in case of adenomyosis that allows us to preserve the uterine wall. I don't have time for this right now, and I try to give more time to our colleagues, and I will mention these procedures later in our course. The helix technology that allows us to see the boundaries of the lesion to see what part of uterus can be preserved in case of diffused or cystic endometriosis. Only the good preparation for the procedure allows us to make a differential diagnosis, whether it's nodular adenomyosis or the patient has malformations. Like in this case, we performed an organ-preserving procedure. After this, the woman got pregnant. Before that, she had been infertile for 10 years. Well, the cystic adenomyosis was described by us in 1993, and it became the basis of the existing classification. Keep the sound, and when I show such surgeries, and there will be a separate presentation on cystic adenomyosis, often there is a confusion here, and they administer hormones to women, and they do it uncontrollably. But we have a lot of experience with surgical procedures. Today, cesarean section also plays an important role. As a result of cesarean section, and there are lots of C-sections done, we have scars and adenomyosis in cesarean section, scar, and the Kolokov Center is the leading institution in Russia to treat such conditions. And I would say not just in Russia. We can see adenomyosis in scars, and we know how to reduce the number of cesarean sections. Cesarean sections must be indicated, and we can also do a reconstructive procedure on the uterus. We can incise this part of endometriosis to do the uterine reconstruction and to allow the patient to get pregnant in the future because, well, our center is probably the champion in this issue. This is a very serious pathology, and often it can turn into bleeding, major bleeding during the surgery. All surgeries are done according to our technology. Hysteroscopy has new opportunities. Hysteroscopy allows us to do the procedure by removing endometriosis from the inside of the uterus. Here is a woman diagnosed with pregnancy inside the uterus, and that was the endometrial cyst on the wall of the uterus. We have patents for performing such procedures, which are carried out in the Kulakov Center, at least 20 to 30 surgeries per day like that. And also the center has the Department of Operative Gynecology, Oncology, etc. Today we're talking about 5P medicine. It means personalized medicine, predictive, preventive, participating, and positive. And it's important to know all these 5Ps. In our center, we're not talking about women and the fetus, but also about the egg and the sperm and the embryos. We say no to monogenic diseases. The director of our center, Professor Sukik, has done a lot of work in terms of education for our colleagues, and not just colleagues in our center, but in other centers as well. There should be an alliance between the child gynecologist, the reproductive specialist, and gynecologist of adults. We have a project, Reproductive Health, under the auspices of the vice premier of our country, Tatiana Golikova, and all our team of chief specialists who are all at the Kulakov Center are involved in this. That's Professor Dolgushina, Professor Shmakov, yours truly, Professor Uvarova. We deal with preconception diagnosis, pregnancy planning, also preconception preparation, prenatal diagnosis. We are developing new technologies so that every pregnancy could be safe, so that every pregnancy could be successful. Dear colleagues, well, medical checkups, yearly medical checkups are important. It's free of charge in Russia. Once a year, everyone should go for a regular yearly medical checkup. Unfortunately, the coverage rate is very low, only 36%. If everyone could do that, we would be able to diagnose diseases earlier, especially diagnose cancer, STDs. We could better prepare women for pregnancy, to identify complaints in children and adolescents at the early stage. Well, it's our fault when we come for a yearly checkup too late, late presentation. And here you can see a child who was born as a result of artificial insemination, and often we do not pay a lot of attention to many factors. Often there may be problems during pregnancy, including the use of alcohol, drug addiction, the use of psychotropic substances, and also you can see during those weeks shown on the slide, there is the development of different organs, and there might be malformations developed. Hopefully they do not occur all too often, but malformations are an important problem. The title of my presentation is New in the Treatment of Gynecological Diseases. What about STDs, sexually transmitted diseases? A man and a woman get together and they do not know anything about one another, and STDs can lead to malformations, poor implantation, infertility, chronic pelvic pain, preterm births, intrauterine pathologies. STDs are responsible for different malignancies. That is why we must fight against STDs and against abortion. Abortion leads to many problems, and obviously all the measures should be taken, psychological, financial, and others, to minimize the number of abortions. An abortion should not be a method of pregnancy planning. Vaccination and pre-conception and post-conception preparation, vaccination against cervical cancer is a must. And that means a woman has responsibility for her health and for the health of her future baby. And that means vaccination against all infections. Here are the factors impacting on the reproductive health and behavior. 15% is genetics and epigenetics, but 50% is epigenetics, such as the conditions of the environment, our food, our behavior. 15% genetics, 15% stress, 20% medicine. And then a lot depends on us. The use of different microelements is important. Sometimes, well, changing our food can not solve all the problem, but iodine, vitamin D should be taken on a regular basis. As for proliferative diseases, we must remember that proliferative diseases usually have one mechanism of development. One disease triggers another disease, endometriosis and myoma. Up to 80% of cases, myoma and hyperplasia up to 60% in combination. Hyperplasia and myoma up to 80%. They go hand in hand. Well, mammary gland tumors occur in almost 50% of cases when there is a hyperproliferative disease. Our center is the leading institution to develop different methods of treating endometriosis. In 1993, the classification was published, developed in our center, the classification of endometriosis. And Dr. Abrao introduced the classification of adenomyosis, including nodular cystic form of adenomyosis and the classification of retrocervical adenomyosis shown here. Today, we know that the true prevalence rate of diaphragmal endometriosis and severe endometriosis is underestimated, as was shown by Dr. Magrina. And, well, there is the diaphragmal endometriosis confirmed. In many cases, there should be an alliance between a reproductive specialist and a specialist in the field of reproduction. Well, you can see Professor Leonov, who many years ago started this program, and there was the first child born in our center. So we made our minor contribution to this. Well, the degenerative forms of oocytes were detected in 1976 in patients with endometriosis when we started using laparoscopy. During laparoscopy, we just took follicular fluid and studied oocytes, tested oocytes. Right now, immunology is playing an important role. We started dealing with immunology about 30 years ago when Gennady Sukhik came to our center, and we studied hereditary immunity, and we got unique data that will be presented by Dr. Kretchetov. A lot of dissertations were written on the subject under the auspices and under the guidance of Professor Sukhik. Adenomyosis is a new disease. Why? Because these are the foci of endometriosis in myometrium, and they are of fundamental importance for reproductive medicine. If adenomyosis develops in the junctional zone, well, and these signs, these foci of adenomyosis are sensitive to treatment. In my metrium, they're not sensitive. And this is the picture obtained. In case of adenomyosis, there are inlets of epithelium of endometrium in the muscular layer. This modification in embryogenesis, and there are a lot of studies trying to figure out what is meant by endometriosis. That's the enigma of the 21st century, because adenomyosis has an impact on our reproductive health. We use different imaging methods, functional MRI, other methods which allow us to do preoperative modeling and intraoperative navigation, thus allowing us to detect congenital malformations in patients with endometriosis. And in case of polycystic ovaries, adenomyosis is not just the distension of muscles, not just nodules, but endometriosis can have an impact on ICSI, on ART, and we have had several studies which are important for us. I usually provide our own data, not just my personal data, but the data of our team, the Department of Endocrinology, Immunology, Genetics, because genetics is developing rapidly at our center. So we publish unique data, not just in Russia, but also abroad. We have started using new methods. We know the ASAT method, but we use the spiral method, the spiral incision of endometriosis, and we do achieve very good results. Another important area, which is the subject of our study, is premature ovarian failure. And as for premature ovarian failure, sometimes it's our fault when we do not do proper surgeries on ovaries, especially when general surgeons do that, because we must be very careful about ovaries. We must do everything possible so that endometrioidal cysts are removed by doctors who have no experience. So these should not be surgeries just for training. There will be a special presentation devoted to polycystic ovaries, and of course, ovarian failure can be spontaneous, genetic, autoimmune, and iatrogenic. And there were several dissertations written on this subject, and we can see that as for premature ovarian failure, surgeons should take part in the treatment when other methods are not effective. And there are also surgeries developed in our center. It's not a panacea for all problems, but this surgery allows patients to get pregnant. And I did this with Victoria Dementieva, my student, and our reproductive lab. So when I say our, that means our center, because I've been working at the center for 51 years. 51 years. Well, when I graduated from the medical school, I've been working in the Kulakov Center for 51 years. Well, I became a fixture there. And, well, you can see also superficious endometrium, new things related to the surface of the ovaries. New data have already been published, and the first child who had been operated on was born on October 1st, 2020. We published the data on this child. That was our joint team the alliance between surgeons and reproductive medicine specialists. Well, this woman, Maria Densova, had a child thanks to this, as you can see it here. I should say that uterine surgeries should be minimal. C-section should be used only as indicated, because otherwise there are niches, scars after a C-section, and we have to deal with them. So what is Asherman syndrome? You're all aware of that. It occurs after embolization, and we have to divide synechia using our methods, and we cannot stand idle when we talk about prevention. Well, medical checkups, vaccination, screening, well, taking into account oncological risks, and also prevention of breast cancer. Well, if we're talking about BRCA gene mutations, well, this slide is talking about artificial intelligence. EDIC helped me a lot in this. And you can see a combination of oncology and pregnancy. That's a separate subject. We have a special team of Professor Ashrafan, our oncologists and reproductive medicine specialists. Well, we do everything possible so that a woman could become pregnant. There is a surgery performed a year ago. The woman was on the operating table, and I personally, and by the way, that was a complex procedure. We aspirated 3 follicles. We found 3 eggs. While she was on the operating table, she got 3 embryos, and 1 is ready. Well, all the women who would like to get pregnant, but we should tell every woman, please remember that the secretion of sex hormones changes. The ovarian reserve drops with age. The risks are increasing. And of course, pre-implantation genetic testing, PGT, helps a lot. Now we can say no to monogenic diseases, to congenital malformations, and near-miss conditions. And I'm very happy that together with the specialists from our center, we've done a lot. We're ahead of many other centers in other countries. That's all I wanted to say, dear colleagues. And again, I try to reduce the time for my presentation, and I did my best to show our data. Thank you very much. Artificial intelligence, new technologies, that's what we use at our center. But of course, the doctor, the physician, still remains the key person in a patient's life, and there should be an alliance between the patient and the doctor. Thank you very much. Let's have a 5-minute break before we start the next plenary session. Thank you.
So this is a plenary session, complex approach to the diagnosis and treatment of adenomyosis and endometriosis. And we start this session. Professor Go is a fantastic specialist, and he is one of the founders of classification. And we know nobody better than Professor Go, who knows everything about adenomyosis, endometriosis, and anomaly uterine bleeds. Shanghai Hospital of Obstetrics and Gynecology, Fudan University. Professor Go, microphone is yours. You're welcome.
Thank you. Thank you very much for your invitation, kind introduction as well. I guess I'm going to share my screen. Okay. Now, can you see the
Очень прошу
slide?
всех, очень прошу всех соблюдать регламент.
Yes, we can see you, we can hear you, we can see your slides, and please stick to the timing. You have about 20 minutes.
Good. Thank you, Leila, for inviting me. Now, what I'm going to do is talk about a little bit about coagulation, adenomyosis, and also heavy menstrual bleeding. Now, we do know that the adenomyosis is one of the structural causes of abnormal uterine bleeding, or AUB. In fact, there's a Figo palm coin classification. And AUBA, it often manifests as a heavy menstrual bleeding, or HMB. But we know very little about adenomyosis-induced HMB. And adenomyosis-induced HMB can cause anemia, and it's one of the important indicators for hysterectomy. And we do know that the fibrosis in adenomyotic lesions is a proximal cause for adenomyosis-induced heavy menstrual bleeding. Now, there should be some connections, and I'm going to try to give you some of the reasons why that adenomyosis has the connection with the hypercoagulability. Because there's numerous reports, case reports mostly, of adenomyosis patients. They actually had increased the risk of thromboembolism, cerebral infarction, and also DIC. And 7 years ago, a Japanese group reported the activated coagulation pathway in patients with adenomyosis, especially those with enlarged uterus. However, the sample size is a bit small because they had 8 patients and there was no control. And there's also some evidence suggesting that there's some connections. Now, similar to endometriotic lesions, adenomyotic lesions are actually wounds undergoing repeated tissue injury and repair. And we do know that platelets actually play important roles in adenomyosis. And ectopic endometrium can secrete thromboxane A2, which is actually potent platelet activator. And antiplatelet therapy has shown to be have therapeutic potentials. And activated platelets can induce the PII-1, and PI1 is actually overexpressed in adenomyotic lesions. And, and also the amount of menstrual blood loss is intimately linked with endometrial repair. So coagulation is involved in tissue repair. So and also AUB coagulation is as another reason for HMB. Also, in particular, for adenomyosis, we do know that the inflammation often goes hand in hand with coagulation because of the overexpression of COX-2 and also presence of pro-inflammatory cytokines and elevated CA125. And also, enlarged uterus may cause venous stenus and causing coagulation. And 13 years ago, actually, we reported the elevated immunoreactivity to tissue factor and its association with dysmenorrhea and also the amount of menses in adenomyosis. As you can see that the tissue repair, a tissue factor actually staining is elevated significantly. and it's actually especially elevated in endometrium in those reporting heavy menstrual bleeding. And because tissue factor plays an important role in coagulation pathways, so we suspect that there's some more going on here. So in 2015, we actually reported that for women with ovarian endometrioma, they seem to have in a state of hypercoagulable state, manifested as the shorter TT and also a shorter APTT level. And also the systemic blood, the platelet activation rate is seen to be increased, but 1 month after the surgery, they seem to be reduced. Now, 3 years after, one Italian group reported, well, they only found the APTT is shorter, but did not find that the TT group is actually shorter. So the conclusion is hypercoagulation in women with endometriosis is a bit questionable. But then we actually, in 2018, we actually provided further evidence for hypercoagulability in women with ovarian endometrioma. We reported that the platelet counts and also the TT, APTT, and also the soluble p-selectin levels, they all increased. And the D-dimer levels are increased. But 3 months after the removal of the lesions, and supposedly patients are fully recovered, the elevated level returned to the normal levels. And that's a strong evidence for hypercoagulability. And we can see that this is actually the platelet activation rate 3 months after is actually reduced to a normal level. And this is D-dimer, again, it's reduced to a normal level. This is TT, and actually elevated 3 months after surgical removal of lesions. Fibrinogen levels actually decreased, and also the fibrinogen degradation products are also reduced. So that's another kind of independent validation from another group from China. They actually reported the same thing, that the TT and APTT level actually are shorter, suggesting there's a correlation between inflammatory markers and coagulation markers in women with advanced ovarian endometriosis. Now, again, the Italian group, they eventually acknowledged that there's a modest coagulation going on in women with endometriosis. You can see the APTT ratio in OMA, DIE, and also superficial peritoneal endometriosis actually a little bit increased here. But interestingly, that although we reported that the platelets plays an important role in adenomyosis, one group from Belgium, they reported that contrary to what we reported, they didn't find any signs for platelet activation, but they did report that the lesional fibrosis in adenomyosis increased significantly as compared with the normal endometrium. There's several possible reasons for discrepancy. One is the technicality, because they only used one antibody to stain platelets, and also selection of controls may be different, because the controls consisted of controls those patients with fibroids or unknown causes of HMB, and they're willing to receive hysterectomy, indicating that these patients are actually very severe. But it's possible that these women actually may already have coagulation problems. So when they compare with the adenomyosis patients, didn't see any evidence. And we also know that the patients with the fibroids, especially with big uterus, tend to have increased risk of VTE. So selection of cases is also a little bit different because they actually looked at the very severe adenomyosis, and the lesions may be highly fibrotic, and so the vascularity is actually reduced. So you don't see any blood or platelets. So just last year, the Hangzhou group, they also reported that the anemia-associated platelets and plasma prothrombin time actually increase in patients with adenomyosis. As you can see that the platelet counts actually correlated negatively with the hemoglobin levels. And also PT also correlates negatively with the hemoglobin levels, suggesting that indeed a woman with adenomyosis, they are actually in a hypercoagulable state. As you can see that this is actually the platelet count. This is adenomyosis, this is fibroid, this is actual controls. You can see this is actually the significantly higher than fibroids and also than controls. This is PT, and this is actually the APTT. As you can see that the adenomyosis group actually is significantly shorter than the control group. And we recently focused on women with adenomyosis who also complained heavy menstrual bleeding. We actually looked at 72 patients. We actually also recruited 50 controls, healthy women. They're mostly hospital staff, some patients with teratoma, and also with the the early signs of the cervical cancer. But for those patients with adenomyosis, that about 37 of them actually, they had amount of menstrual blood loss greater than 60 ml, but smaller than 100 ml. Another 35, actually the menstrual blood loss actually is greater than 100 ml. So these are actually two groups. And for adenomyosis group and also the control group, you can see that the platelet counts actually significantly increased. Fibrinogen levels is also increased. D-dimer levels is also increased. And this is PT, which is significantly shorter in women with adenomyosis as compared with the controls. TT's same thing, is significantly shorter. And the APTT, again, is also significantly shorter. And for women with adenomyosis, this is actually uterine size. The diffuse adenomyosis usually have larger uterine size, which is actually understandable because they have multiple lesions. And diffuse adenomyosis, they also tend to have a higher amount of menstrual bleeding. And as a result, the diffuse adenomyosis patients also have lower level of hemoglobin, and the APTT level is also shorter in a woman with diffuse adenomyosis. And this is actually antithrombin activity, and it's also kind of reduced in a woman with diffuse adenomyosis. And also that for fibrinogen degradation products and women with adenomyosis, they also had co-occurrence of fibroids. They seem to have a lower FDP levels as compared with those without fibroids. Now, among those patients complained heavy menstrual bleeding, you can see that the woman with excessive bleeding, they tend to have higher platelet counts. They also have tend to have significantly higher D-dimer levels, and also FDP, fibrinogen degradation products as well. And fibrinogen levels is actually a bit lower, and APTT level is actually lower. So in this case, I think that we can conclude that the woman with adenomyosis who complained of heavy menstrual bleeding are actually in a hypercoagulable state, especially in women who complain excessive bleeding. There could be some possible causes, activation of tissue factor in ectopic endometrium, causing vascular aberration and platelet activation. But we don't know much about this, and I think that the more research on this molecular mechanism are needed. But there's some notable clinical significance. So for women with adenomyosis and also complain heavy menstrual bleeding, caution should be exercised because we probably need to take some preventive measures in order to avoid some thromboembolism. So coagulation parameters may be used to monitor treatment response, and we actually have some data to show this is the case. But whether anticoagulation therapy has any therapeutic potential, and this actually will need further investigation. Now, with this, I will conclude my talk, and I'll just draw your attention to a new journal. It's called the Journal of Endometriosis and Uterine Disorders, which is the official journal for Society of Endometriosis and Uterine Disorders. And also call your attention to the Asian Conference on Endometriosis, which will be held in September 25th to 26th, will be held in Manila, Philippines. And the deadline for abstract submission is 16th of this month. So thank you very much.
Thank you very much. Thank you very much, Professor Go. Your participation in any conference, especially when you speak about endometriosis, is something very special and it is very important. Thank you very much for the connection. And I hope you like our agenda. And if you can, please stay with us for some time and you can listen to our colleagues to other presentations. Thank you very much. And we move to the next presentation. Professor Otto Yushiaki, the diagnosis and the treatment of malignant transformation of endometriosis. Senior researcher of obstetric and gynecology department, Medical School Kawasaki, Kurashige, Japan. Professor Ota, please stick to the timing. The floor is yours. Thank you.
It's a great honor to be able to speak to you today. My thanks to Leila.
Звука.
I'd like to focus on malignant transformation of endometriosis. In 1927, Sampson first published a report of malignancy associated with endometriosis. He described specific criteria for endometriosis-associated ovarian cancer, EAOC. The criterion is the presence of endometriosis is close proximity to the cancer. The tumor must be an endometriosis origin, not another primary tumor. In 1953, Scott modified Sampson's criteria. The malignant transformation of endometriosis must show a continuous morphologic progression from benign to malignant. There are many reports of relationship between endometriosis and carcinoma. In 1993 reports, about 20% of patients with endometrioid and clear cell carcinomas had a history of endometriosis. In 1997, it has reported that the probability of endometriosis complications in ovarian carcinoma was 40% for clear cell carcinoma and 23% for endometrioid carcinoma. In a recent Canadian ovarian cancer database, endometriosis was identified in 51% of clear cell ovarian carcinomas and 43% of endometrial carcinomas at the last pathology report. The Lancet Oncology report that endometriosis is benign, but has similar characteristics to malignancy, including invasion, implantation, and metastasis. Endometriosis was significantly associated with an increased risk of clear cell carcinoma, with an odds ratio of 3.05. Early diagnosis of endometriosis-associated ovarian cancer, EAOC, is difficult by ultrasound. In the case of EAOC, cystic lesion must be removed without rupture to avoid leakage of malignant cells into the abdominal cavity. EAOC is associated with inflammation and epigenic process. Therefore, treatment with immunocheckpoint inhibitors is important. Malignant transformation of endometriosis occurs mostly in ovarian endometriosis, but is rare in deep endometriosis. Malignant transformation of deep endometriosis occurs in the pelvic floor, in close to the rectum and cervix. So therefore, it has been reported that it is often misdiagnosed as rectal or cervical carcinoma. Thus, there may be more cases of malignant transformation of deep endometriosis than we think. Here are our cases of malignant transformation of deep endometriosis stand, published in 2020. The patient was late 40s. MRI showed a light ovary of 4 centimeters with multiple solid contents, and ovarian carcinoma was suspected. In addition, left ovarian endometrioma and uterine adenomyosis were observed. Because of suspected malignant transformation of endometrioma, the tumor was removed laparoscopically to prevent its rupture. We planned to remove it with the peritoneum to avoid rupture. The right ureter was identified and the infundibulopelvic pelvic ligament was incised. The tumor was also adhered to the right uterosacral ligament. The right ovarian tumor was removed without rupture with the peritoneum. The right ovarian tumor was placed in the retriever pouch. As a result, DE at the right uterosacral ligament was removed. However, DE on the left side was not removed. Right ovary was removed with the peritoneum without rupture. AT staining showed front formation where the cyst wall of endometrioma transitioned to endometrial borderline malignancy. It was considered as stage 1A ovarian endometrial borderline malignancy, and follow-up was planned. 6 years after the first surgery, a recurrent tumor of 3 centimeters was detected on the left side of Douglas pouch with contrast-enhanced CT and MRI. And PET-CT showed uptake at the same site. we diagnosed the case as recurrent ovarian tumor and laparoscopically performed lymph node dissection and removed the uterus and the tumor. The tumor was visualized between the sigmoid colon and the left side of the uterus. The tumor was extended the rectovaginal septum. Resection was performed while taking care not to incite the tumor. If the resection line moves away from the rectum, the tumor will be incised, but the space is limited. The tumor was markedly extended to the dorsal side of the lateral rectum. Next, the parametrium is dissected, so the tumor becomes incised. The vaginal canal was resected, and the uterus and the tumor were placed in the retriever pouch. The resected lymph node and omentum were also placed in the retriever pouch. They were removed from the body transvaginally. The pathological picture is shown below. Deep endometriosis is seen in the area marked by the orange circle. Surrounded by the deep endometriosis, endometrioid carcinoma was observed in the blue circle. A front formation, possibly, and the endometrioid carcinoma transition site from deep endometriosis was also observed. We diagnosed FIGO stage 2B peritoneal carcinoma. The patient was treated with paclitaxel carprotein as postoperative adjuvant chemotherapy and followed up. This was reported in 2020. 4 years later, a recurrent tumor was suspected by CT and PET in the left inguinal region. So we resected the tumor. 3.5 centimeters solid tumor was removed. The split surface shows yellow to white enrichment components. The tumor showed endometriosis lesion, adenoductal structures resembling endometrial glands. Endometrial tumor was seen along with endometrial glands. Granular duct cell resembling endometrial glands proliferate and fuse. Thus, the diagnosis of endometrioid carcinoma was made. Differentiation into squamous epithelium and keratinization is observed. A continuous site of transition from deep endometriosis to endometrioid carcinoma was identified. And a clear cell carcinoma was identified in the sum of removed tumors, along with endometriosis and endometrioid carcinoma. A tuber growth pattern characteristic of clear cell carcinoma was observed. Stained with napsizin A and HNF1 beta, which are specific for clear cell carcinoma. See the schedule to receive postoperative adjuvant chemotherapy and maintenance therapy with bevacizumab plus olaparib and niraparib. as FIGO stage 4B peritoneal cancer. Only 8 cases of malignant transformation of deep endometriosis were reported in the last 10 years. The mean age of onset was 48 years. Approximately 50% of the patients received adjuvant chemotherapy after surgical treatment, and there are no recurrence in the literature. The case presented here was those underlined in red. The next patient was 51 years. MRI showed fallopian tube hematoma and right endometrioma, and she was scheduled for laparoscopic bilateral salping oophorectomy. The left endometrioma was adherent to the surrounding area. The fluid was chocolate-like. The endometrioma was removed in a retrieval bag. The excised specimen, borderline malignancy was found in the yellow area and microinvasive carcinoma in the red area. The cyst wall shows tubal epithelialization and can be diagnosed as an endometrioma. A small area of serous mucous borderline malignancy was observed, and 4 by 2 millimeter endometrial carcinoma was observed. Because it was only 4 by 2 millimeter microinvasive carcinoma, it was stage 1C, but was follow-up for observation. Seven years after surgery, CT imaging showed a soft shadow with a contrast effect on the medial side of the right external iliac artery, and a recurrent tumor was suspected. A contrast-enhanced MRI scan showed a similar diagnosis. Tumor was located between the bladder and the left umbilical ligament. Tumor was strongly adherent to the bladder and resulted the bladder injury. There was no muscle layer invasion into the bladder, as the tumor could be removed. The bladder was repaired laparoscopically, as the surgery was completed after the it was a white and solid tumor. Tumor showed endometriosis and endometrioid carcinoma. A continuous transition site from endometriosis to endometrioid carcinoma was identified. It was thought that residual deep endometriosis in around the bladder had transformed into malignancy 7 years later. The patient is currently scheduled for restaging and post-operative adjuvant chemotherapy. Last slide. Endometriosis must consider endometriosis-associated ovarian cancer, EAOC, in addition to pain and infertility. Malignant transformation from deep endometriosis is rare, with only 8 cases reported in the last 10 years. Since malignant transformation of endometriosis is a recurrent process, so genetic factor should be taken into the consideration. Thank you for your attention.
Thank you very much, Professor Otter. You've always made brilliant presentations. Thank you very much. How often do you see this malignant disease or the results of endometriosis? We know that it is linked to square cell tumor. How often do you see such cases? Can you hear us? Can you hear us? How often do you see such cases?
Yes, I have only 2 cases and transformation to the deep endometriosis. But I have many cases of malignant transformation to the endometrioma.
Thank you very much once again for your answer. Thank you, Professor Otter, and good luck. Dear colleagues, now I'd like to announce my presentation, which was supposed to be at 17:30, because due to technical reasons, we cannot give the floor to another doctor. New in the treatment of adenomyosis, video demonstration of own operations. Please put on my presentation. Dear colleagues, often, as I have already mentioned, we cannot perform a radical surgery because women are young and they want to have their reproductive function restored. That is why, in some cases, we use different technologies. I have already shown you this picture, and thanks to the fact that we have new technologies right now in treatment of endometriosis and adenomyosis in particular, thanks to this 3D model, we can see the boundaries of endometriosis, but we can also visualize adjacent organs, neighboring organs, combined lesions, combined diseases. So we can do our own surgery at our center, taking into account these factors. We have a brilliant lab. We have also a brilliant department of operative oncology. We have other surgical departments like general surgery, etc. And they allow us to expand the spectrum of our surgeries. Well, right now, I would like to show you 5 or 6 organ-sparing procedures. Adenomyosis, that was your request. That is why I decided to call this presentation as presentation of own operations. As for adenomyosis, it always starts with hysteroscopy, because almost all women with adenomyosis have bleedings, have acyclic uterine discharges, poor cycle, poor menstrual cycle, and hormonal therapy usually does not help. Hormonal therapy is the first method of treatment of adenomyosis, especially of women of reproductive age. I'm not talking about those patients who are 40 or 50 years old. For such women, hysterectomy is indicated. When we detect what's in the uterine cavity, we finish the major stage of the procedure. This procedure, well, will last for a short period of time for you, but in reality, it takes a longer time. Here we use the spiral method of removing a huge focus of adenomyosis. I would like all doctors in outpatient clinics who diagnose patients with adenomyosis and administer long-term therapy, despite the size of adenomyosis, despite the clinical manifestations, could see in real life what adenomyosis is. How much time do I have? All right, so we use the spiral incision. It is patent. We do the incision of adenomyosis and we study the area which is affected with adenomyosis. And 3D ultrasound helps a lot in this case. Well, this demonstration video shows the horrible area up to 5 to 6 centimeters that adenomyosis can take up. It has no boundaries, but it has no boundaries for those doctors who do not see the boundaries or borders between the normal and pathology. So we can remove this part. This is a young woman who was hospitalized to our center with the diagnosis uterine defect. Well, the left horn turned out to be adenomyotic. In this horn, there was an area that was very painful, extremely painful. There was blood in it, and we managed, and that's possible, to remove this piece and to restore the anatomy. Again, 3D modeling helps a lot, as well as intraoperative navigation. For that, you do not need the Assad's method. Well, but as for this specific situation, as for this patient, we managed to remove the nodular part of adenomyosis and to restore the uterus. Of course, before the surgery, histogens must be administered according to clinical guidelines. Here is another case, the cystic form of adenomyosis. Again, pay attention to this patient. This patient was diagnosed for uterine pregnancy which did not develop, and this pregnancy, in fact, was just the cystic form of adenomyosis. Intraoperative palpation was performed. Then we did the revision, but the situation is aggravated. We did the functional MRI. We can use different diagnostic techniques. We suspected malignancy inside the uterine cavity. Again, see what the endometrioid cyst cavity looks like. I just do the rotation so that you can see it's very dangerous. This patient cannot be treated conservatively, especially when we do not know the boundaries of the lesion. This Congress is called New Technologies, and new technologies do allow us to remove the focus and to restore the uterus, to allow a woman to become pregnant in the future. Hysteroscopy that I showed you at the beginning, I showed you what adenomyosis looks like inside. I will show you the details right now. This video will last for 4 minutes. As soon as we localize the situation, we identify the boundaries of the lesion inside the uterus. Again, pay attention to what endometrium looks like in this woman. These are foci of the dark color. When you touch it, they start bleeding, and you can see that this uterus cannot be left without treatment. There are also polyps, and as for oncoprevention, we should do intrauterine surgical intervention. Moreover, these patients have also external endometriosis. They have often retrocervical endometriosis, so it is important during the surgery to see where the boundary is. Only the surgeon who knows what endometriosis is can do the proper incision of this tissue layer by layer without affecting the adjacent organs. Here you can see the tissue dissection around the external genital endometriosis, around retrostrovical endometriosis, which was hidden behind this adenomyosis and formed just one mass, adenomyosis and the peritoneum, stomach and adenomyosis. Professor Sada just showed this operation, and you should know where the boundaries are to do this shaving. And you can see there is the huge focus of endometriosis that should be removed. In some cases, there is the vaginal wall, which is involved. We do posterior colpotomy. I open the posterior wall of the vagina, and I can see the way this wall is being involved. It should be incised totally, and this is the so-called non-dangerous retrocervical endometriosis. You cannot just diagnose this condition on the basis of ultrasound. It should be also verified after this. And of course, there is a possibility of developing of malignant process, and endometriosis can be manifested when there is clear cell carcinoma, when the endometrium involved, and of course you should assess the situation using oncomarkers. That's the same patient with the internal endometriosis, which grows into the submucosal layer, the endometrioid nodule, which is quite huge, and retrocervical endometriosis. Right now, we remove the node of adenomyosis, and of course, it takes a lot of efforts, and when it is removed fully, well, maybe not fully, it's not the uterine myoma, it has no capsule, but we have also intraoperative ultrasound that we can use. We clarify the boundary of the lesion, and then along the edge, we remove endometriosis, or at least reduce its size. Then we do the suturing, and 6 or 8 months later, this woman allows to start the process of the restoration of reproductive function. You can see this is adenomyosis. I am removing it not in a bag so that you could see it. You can see the cell-like structure, the density of the tissue. It reminds us of B cells. When you palpate it, well, you can see there is a kind of granular formation along the posterior uterine wall. Of course, you should do the rectovaginal examination to identify the boundaries of the lesion. Here is another case, adenomyosis in the internal lining of the uterus. It is under the mucus. The patient was hospitalized due to the manifested pain. No effect from the previous intervention. And you can see, using hysteroscopy, we can see the uterine cavity from within. It takes a lot of efforts. In this case, when we're talking about a situation like this, we can see that endometriosis is located along the scar after the cesarean section. The patient had 2 C-sections, and those doctors who wanted to restore the reproductive function of this woman told her that there are embryos, but they cannot be placed here in this uterine cavity because of the deep niche. Removing a niche is not a simple thing, because removing a niche would mean that we need to remove this endometrioidal lesion and cooptate the tissues of the neck of uterus with other uterine tissues. Well, you can see we use a monopolar and electrode. We incise the entire niche, the entire scar, and we use a three-layer suture to restore the uterine wall. Well, we do this at our center. Usually it's about 20 procedures like that we perform. And in fact, we treat all the patients from all over Russia with all regions. We can also use telemedicine to plan this procedure, and we are very happy because practically in all cases we can restore fertility, and these women can later become mothers. The procedure is over, the adenomyosis in CS scar is removed, metroplasty, total metroplasty was done using the laparoscopic approach. Here is another patient. Well, this is the situation when we have the cystic form of adenomyosis. Again, laparoscopic metroplasty is performed. Of course, there is a need to do the abdominal cavity revision. And you can see those lesions caused by endometriosis. Well, you can see the uterus is involved. It has a thin structure. In the right part of the uterus is a huge cyst, which is basically transparent, but also there are multiple lesions with endometriosis in the abdomen, Oliver-Master's syndrome, the different pockets, as you can see it here, and they should be removed. Hysteroscopy is used to see how deep the cyst or other cysts are located. In this case, a decision was taken to remove this cyst using the laparoscopic approach. But because the patient suffers from infertility, we also check the patency of uterine tubes. We do the incision on the part which protrudes, which shows that the cyst walls are located very closely to the surface of serosa. This particular chocolate-like liquid, which was described more than 100 years ago, affects the entire right wall of the uterus. Well, I do not just show my operations in Russia, but also in other countries. I should say this is a very complex surgery. Without new technologies, without a lot of experience, it's hard to perform them. Of course, it's easier to remove the uterus, but I cannot lay my hand on that, especially when a woman is 30, 32, 34 years old, and it's not her fault that she has this thin-walled cyst inside the uterine cavity. This procedure takes up a lot of time, and here you can see, well, usually it's 4.5 hours, but as for my presentation, it is devoted to different forms of adenomyosis. Today, adenomyosis is a separate subject. It's a separate subject because here the situation is different, but it leads to the same kind of pain, the same kind of infertility, but the manifestation can be different in terms of sensitivity to different drugs. It requires primarily, if the standard care doesn't help, like with histogens or agonists, it requires a surgical correction. Again, see the way it looks for the first time. You can see the wall of the cyst in the uterine cavity. If you do not know that it is from the uterine cavity, you can think it is the endometrioid ovarian cyst. Well, this cyst is thick-walled. It looks different when we use a histological drug. The surgeon is not quite happy, so I decided to move on and started to remove the remaining part. It requires a lot of attention, and for the patient, that was the only option to show you the effectiveness of this procedure. This patient, after the surgery, and you can see we do the suturing layer by layer. As you can see it here, this is the third layer already. We do the suturing layer by layer after the surgery. It is mandatory to administer gonadotropin-releasing hormones or histogens, and I prefer to administer for women of reproductive age those drugs which do not block the menstrual function or the ovarian reserve. Usually, after 6 months pass, we can send a woman for counseling, and we can think about the implantation of the egg. Well, what about time? Well, let me just show you one more video because Professor Konings is ready to make his presentation, and I'm going to wrap up in a minute and give the floor to Professor Konings. Here you can see the use of new technologies in the treatment of adenomyosis. This is a special presentation which I named like this: video demonstration of own surgeries for adenomyosis. Dear colleagues, if I have time, I will show you other surgeries. Thank you very much. And right now, I'd like to give the floor to Professor Philip Konings. Please, we need a connection from Professor Konings and stop this demonstration. Dear Professor Konings, I can see that you are connected, and Professor Konings is a great specialist in the treatment of endometriosis. Evidence in surgery should be incorporated with evidence-based medicine. That's the title of the presentation. Professor Konings is a great specialist in OBGYN, a professor in Leuven, a professor at Oxford. Well, he also represents the Italian-Belgian group. Leuven, Belgium, please. Philip Konings, the floor is yours. Dear Philip, 20 minutes for your presentation. Please do not exceed the time limit. Thank you very much. Please, the floor is yours. Philip, please start your presentation.
Звук.
Yeah. Wait a second. I am at 1 second. I am. That's okay. Is that okay? Everybody hears me, sees me?
Yes, everything is okay. Please, go ahead.
A pity not being there because evidence and experience is something which we have discussed so many times in Moscow in the last years. And I would say this is a work of money which I'm presenting alone. I would start with Mark Twain. There's so much we know, but there is so much that ain't so, which means there's a lot of things which we think to know which are not correct. So recently we wrote, and you see with the authors, I call this the group of the usual suspects. This was last year. We wrote endometriosis, evidence-based medicine. What do we know? And at the end of the day, we know very little. We know very little because there are no experiments which we can do because there's no adequate animal model. Medical therapy cannot be blinded because the woman knows whether she is taking GnRH analogs. Randomized controlled trial in surgery, this is it's not real because surgery is too variable, and deep endometriosis surgery, those who have done more than 1,000, there are not so many. So we do not have the numbers. The experience is divided over several subspecialists, and the p-value fallacy. This is something I would like to explain. We do not understand what it is. Is it an implanted endometrium, or is it a genetic epigenetic disease? Like this group, we propose this. The first is a normal cell in an abnormal environment, but then the animal models become a normal endometrium in an abnormal environment, a normal endometrium. We think, Professor Gandamian, Wattier, Ucia, let's say the whole group, we think it's a genetic epigenetic disease, which means there's a predisposition, and then something happens. Highest risk during puberty, because then things change. It becomes a clonal reason, which are all variable, and it's a variable disease. So this is the basic. Medical therapy is very variable. Some lesions have aromatase, some have progesterone resistance. Efficacy for pain, 10 to 30% is ineffective. And very important, it works very well for a group, but 30%, it doesn't work at all. There's no blinding, and we even do not know whether the pain was caused for endometriosis. There is a lot of problems, and I would say there as a conclusion, traditional statistics are not useful because too variable. You should look at the individual data, and they are industry-dominated data, and we even don't know women with proven endometriosis mean they had a laparoscopy, and if I did a laparoscopy in a woman with endometriosis, she has no endometriosis after. Surgery, randomized controlled trial, it's unrealistic because it's variable disease, low numbers, and the case series, what you find in the literature, this is just individual experience. Stay with me 1 second about probability. If you're a poker player or chess player or go to the casino, this tossing a coin is 1 chance in 2, and dice is 1 in 6, and so on. These are and if you have this kind of, and you do it 10 times, you can have 5 times red and 5 times green, or 4 or 3, and 2 and 8, a 1 in 9, and you get a distribution that the 5-5 is the most frequent. You feel this, and 1-9, and then you can ask yourself, if you have one experiment, how can I judge this? The nice thing is that if you have a lot of experiment, you always have a Gaussian distribution, not to make life difficult, but it's always like that. And the nice thing is that you see that mean and 1 standard deviation is 68%, and mean and 2, and mean and 3, which means on this curve, you can always know exactly what is the number of an experiment, which is more or less. So if you have 9 red and 1 green, you can ask yourself, is this caused by accident, just by chance, or is this not by chance? And this is what we do with statistics. This probability that it is by chance, the extremeness, this is the p-value. Remember, p-value. And then in the 2020s began the t-test, And null hypothesis is there's no difference. And calculate the probability that difference is just caused by chance. And then, crucially important, this means that with a t-test, a p-value, you can say this hypothesis is very unlikely. But a p-value can never confirm a hypothesis. And then we come to the 90s, where the management, they say, should be based on evidence. Of course, we all agree. And in the 90s, we could calculate those t-tests and all more and more sophisticated statistics. And the first thing that happened to say, yes, there should be no bias, no bias of randomization. It should be double blind. The patient should not know whether she has disease or the active drug, and the doctor should not know. The randomized double blind trial. And so this became the pyramid of evidence, and all this is done on p-values. So here begins the problem. Let's take an example. Men are taller than women. P equals 0.001, which means there is only 0.1% chance that this is just occasional, that this is not true. And then the mistake is that to turn around the argument. If you conclude from this that men are taller than women, you cannot do. Because traditional or frequentist statistics can refute a hypothesis, but never can confirm a hypothesis. This is the p-value fallacy. And you see, then we are already 2016. 2016, the American Statistical Association explained this in a nice publication. And there are two things which you all should remember. Never use again significant, because the word significant is arbitrary. Why is P 0.5 5% by chance is significant, and 5.5% or 6% is not significant? Significant is a word that doesn't mean anything and should be abandoned for all publication. And second, do not invert the conclusion. With the classic traditional statistics, you can only say this hypothesis is likely not true, but you never can confirm the hypothesis. There were more problems with the randomized controlled trials. The randomized controlled trials is limited for blinding, it's not ethical, not suited for multivariate event. Try to do a multivariate randomized controlled trial. Explain this later. It does rare events. To study a 1% event, you need a trial of 3,000 patients and another 3,000, 6,000. It takes years to do that. It's not realistic in extremes, because or you know already so well that it's going to be effective that it becomes hardly ethical to do it, or the effect is so small that whatever the result is, it's not going to be clinical important. And I'm not going to discuss the non-perfect randomized controlled trial. So what do you do? But it's the best we have. It's not good, it's the best we have. Evidence-based medicine, because it was not very applicable in medicine, they added the grades of evidence, and then you have above the randomized trial, the systematic reviews, and then there's the appreciation of evidence. This is the idea of a group of specialists, how this would be integrated in statistics. Not going to talk about bias for meta-analysis, but all this is, if you ignore that a hypothesis cannot be confirmed with classical statistics, and you ignore the Bayesian message, which came later, that more than 90% of the data in medicine are wrong. Wrong exactly because of this p-value fallacy. So the traditional statistics begin with the null hypothesis, no difference. The Bayesian statistics say the null hypothesis, there is a difference. So this is what is used to calculate the probability that the result is true. I'm not going to get you in details of the Bayesian statistics, but basically you update the past with new experience. And where this is used, Google search, self-driving cars, hedge funds, weather prediction. This is in fact Bayesian statistics. A Bayesian statistic here below, you have the basic formula, which means this part of the two overlapping circles they are the same. You can say B if A times A is the same as, okay. The Bayesian statistics, not going to explain this. With this, you can, simple question, 18 years old, severe dysmenorrhea, 17, what's the probability of deep endometriosis? As a clinician, you estimate that. You have a real estimate. If you fill this in, you find 45%, and I hope it fills with your thinking of clinics. Second conclusion, Bayesian inference updates knowledge using new data. It's like cooking. When you cook a cake and it's not good a cake, at that moment, next time you do it a little bit different. And so you update each time you cook something, you update a little bit. It's the same thing in medicine. It means the past is never forgotten. You always update the past, and each result is interpreted in the context of what is known. What should be done in a publication, in the discussion, but what's not always done. Data are not standalone. That is in the light of the past. I give you an example, but you feel there must be a connection between the two. If you have a drug, you don't know whether it works, you start with 50% chance. And if it's significant, it means that a p-value of 0.005 changed the probability of truth from 50 to 70%. But 30% remains not true, not 5%. 5% is the probability it's just due to chance. 0.001, you go to 85%. There is a relationship, but do not invert the argument. And then I would say, like to go to clinical medicine. Research is a sample of a population, and you do an experiment to reduce the variability, inclusion, exclusion. You all know that. You limit the factors to investigate to one. Why? If you have two factors, you need 4 groups. You get randomization problems, and you need a huge number. That's why the randomized controlled trial are generally one group. The p-value improves with the accuracy, which means that if you have enough numbers, everything, the smallest difference is going to become significant, less probable, but the p-value never indicates how important the effect is. Clinical medicine, it's not about the sample, it's about the population, it's about everybody, including the multimorbidity, the rare events. And the clinical medicine is an answer to the difficulty of extrapolation the results of research. And then we come to experience. Each diagnosis, this Bayesian thinking, a diagnosis and a treatment gives a result. So each patient you treat, consider it like an experiment, and the result you're going to use to next time change your treatment, do the same treatment or so on. You learn always from the past. This is clinical medicine. So you have 3 types of evidence. Evidence-based, experience-based, opinion-based. This is theory. If from the theory something is logic, if you understand very well, then you say, we are going to do. Same thing, I'm going to go quick on it. Evidence-based, experience-based, and opinion-based on the literature. Now, let's just go to diagnosis. The clinical question is how good is not how good the test is. is what is the probability, if it's positive, that this patient has a disease, which means that the sensitivity and specificity are characteristics of a test just for the scientist. But what the clinician needs are the predictive values. And then when you talk about a test, a diagnosis for endometriosis, see, if you have something where you have a 1% a cancer, endometriosis, which means 100 with and 10,000 without. 99 sensitivity, 99% specificity, which means that you have 90 and 100, which means a predictive value of 50%. With this, if a specificity is not better than 99% for a rare disease, it's better to toss a coin because it's not going to be better than that. This is one of the things which we recently published. I'm not going to get in details for this on the value of ultrasound. So the key thing is that if you have something which is rare, like deep endometriosis, if you do not have a high specificity, you have too much false positives and forget about the test. It's clinically not useful. Conclusion 3, this is research. Clinical medicine is about predictive values. A screening test with a prevalence needs a high specificity. And then what do? History and symptoms and clinical exam and imaging and blood test. All this together, we turn into a prediction, which means if you then add the diagnostic test, the question is there an added value? And for a screening test, is there a risk of false positive? It is the clinician who judge all together. You could calculate, although this it becomes too complex for a Bayesian. Bayesian can do, but it's complex mathematics. And then for surgery, we have everything we do in surgery, there's almost nothing proven. Einstein knew already that learning is experience, everything else is information. So this we have. So in order to update this, the difference between the person versus collective experience, this was a trial which we did together with Arnaud, where in fact we had a proof of concept. All of it is visual analog scales from no pain to very severe pain, and then you have for pain for whatever questions what we think. And then what we did is to judge the answers. And there you see, for instance, one of the answers that comes, severity of pain below a 3 in 10, nobody does surgery. Above 7, 8, everybody does surgery. The cis-diameter age of the woman. But in fact, the clinician takes the 3 together. 1 is a line. 2 factors together is an area. 3 is a sphere in space. So you see it becomes complex. So you get answer with this kind of frequency distribution. All of them agree. You have other ones where you have, let's say, a group says no and a group says yes. So this is the important thing. Difference between men and women. I'm not going to explain why, but there are differences. And the overall conclusion for everything about 250 questions, there is no discrepancy. We all confirm the evidence-based conclusions, the guidelines, but we extend the guidelines. The evidence-based guidelines, and this is a problem of it, are interpreted by a small group of experts of all disciplines. And what I think we have to change is surgery should be judged by surgeons. Those who never come in an operating theater has little opinion about how to do surgery. And this is, I think, we have to have this kind of much more multivariate. This letter is one of the papers I submitted this morning, the cardinal sins. This is the same thing, where we together, you see the authors, where we together agreed, and this group together with the winners meeting, the winners group, is a collective experience of more than 50,000 treatments of endometriosis. So this is the background, progressively update. And we agree on a series of this. This is just a paper to say what do we have an opinion about, what you cannot have in a trial. Endometriosis is more than one disease. Consider prevention before puberty. Predictive values of imaging vary with prevalence. This I explained already. Medical therapy should not be given to avoid surgery. Quality of infertility surgery is decreasing because less and less fertility people are doing, and those are doing endometriosis surgery are not fertility specialists. No repetitive IVF with rectovaginal nodule. So in order to stay in time, surgery should have a quality control. So you can ask for the publication to Professor Adamian, but what my final conclusion is, for all of you, you should understand statistical inference and conclusions, which means frequentist means that the traditional statistics, the probability that the results occur by chance. This means forget the word significant. Significant is a no meaning, is something to be abandoned. Understand the limitations of evidence-based medicine and randomized controlled and guidelines. And then make the difference between collective and personal experience. A personal experience is your personal experience where you update all your past management. But when all of us, we agree about something, this becomes a collective experience, and this can evaluate a population because we treat all them, the hypertensive, the obese, the multi-morbidity. This permits to extrapolate the conclusions of evidence-based medicine to the population and can add things to evidence-based medicine what is too difficult or too slow to investigate in a randomized control trial. For the young people, there's still a lot of work to do. I thank my co-authors for their help, and I thank you all for listening. Thank you.
Dear Professor Konings, it's always great pleasure and honor to see you and to hear you in the regimen of the broadcast, in the regimen of the Zoom presentation. Thank you very much. That was fantastic. And I'm happy to give the floor to our speaker, next speaker from the United States, from Massachusetts, Boston. And this is Professor Antonio Gargiulo. He will speak about the current status of art of the robotic reproductive surgery. He's a medical director of the Robotic Surgical Center of Infertility and Reproductive Surgery, Bergamo, and Female Hospital, Associate Professor of Obstetrics and Gynecology Chair and Reproductive Biology of Harvard Medical School. My big compliments to you, dear Professor Gargiulo, and I want to say that our next speaker is Professor Tinenberg. So we are extremely waiting for your presentation, but please try to stick to the timing, dear Antonio. And now microphone is yours. You're welcome.
You hear me, Dr. Adamian?
Yes, we can hear you very clearly.
Good morning. Apologies for missing my earlier slot. It was all my mistake for time change. And again, I'm honored by this invitation. And to be in such a phenomenal panel of speakers. I will try to stick to time, and I will stick to time, in fact, and I am starting a timer for myself. I wanted to start by telling you that even though we're going to be talking about robotic reproductive surgery, there is no question that all of us robotic surgeons owe an enormous debt of gratitude to the generation of laparoscopic pioneers, of which robotic surgery is only a new version or a diversion, but in the end, we still talk about laparoscopy. All the principles are the same, obviously, and I will only endeavor to tell you why in the realm of reproductive surgery, I have found this tool to be a phenomenal tool for our program. Our program of robotic surgery goes now in its 18th year. So we've been operating with the robot for most of my professional life at this point. I have some financial relationships. It would be impossible for me to not mention the products of these producers. So apologies for that, but so that now you're warned. Boston Scientific, Medicaroid, I consult. I would like to again explain why the robot contributes particularly, in my view, to the field of reproductive surgery. And this will be very data light, because I think that among surgeons of this level, it's important also to show what the machine can do for me so that it's immediately evident. There is probably one data slide that's an important data slide that I'm going to show, and the rest is going to be mostly movie clips to show you what I'm doing. And my comments on why I use the machine for several procedures. There is no doubt that many fertility specialists around the world tend to be, on average, less aggressive laparoscopists. And I find this tool to be a very good equalizer tool, and a tool that's going to be important for our particular field of fertility surgery. And I'm going to show some new data as I will tell you. And I also will make a point, hopefully a provocative point, that in fact, when we talk about robotic surgery the way we have it today, we're talking about a technology that's already old. And I'm going to go over these things in particular. Hopefully that will generate some food for thought. Obviously, all of us, especially when we're at the top of our game, we think that we have attained some level of surgery that's going to be very hard to improve upon. Just like this important French surgeon of a century and a half ago, we risk to be set in our ways. And robotics, I think, is a big disruptor in that sense. And I think that's going to show us the way to an even more standardized approach to good level surgery. I don't have many data slides, so I really hope that you can follow me on this. This is our own data from Brigham and Women's Hospital. This paper is being written in collaboration. As you can see, there is a lot of dollar signs here in collaboration with the Harvard School of Business. And we're trying to come down to some idea of whether robotics can, in our hospital system, in fact, bring about a saving of money. So this is very important, because if you think about all the things that can be said about robotics, number one is always going to be about cost. I want to show you that we have about 200 to 250 patients in each of these groups. This is open myomectomy, laparoscopic myomectomy, and robotic myomectomy. And I have to show you that the complication rate at our hospital between 2014 and 2019 is 33 times for open compared to robotic, and 12 times for laparoscopic compared to robotic. These are ratios that we usually don't see in surgery. We usually see a fraction, but not 3,300% higher complication rate or 1,200% higher complication rate. So this is an important improvement on the technique. Conversion rate is also very little, and it's comparable because we have obviously one of the best laparoscopic groups in the country here at Brigham, but the complication rate is different. And the readmission rate is also half, by the way. So very important data that is coming down the pike and is going to impact the way we see robotics. What are the advantages of current robotic systems? I think this is important to say it. We have a decoupling of learning curve from patient experience. That is to say that I can guarantee to my patients that my residents, my fellows, are going to be 100% trained on the machine and will perform, at least mechanically, on the machine at the same fashion of an expert robotic surgeon, because the reality is that through digital simulation, you can reach the same perfection. Obviously, you have to learn the operation, you have to learn the anatomy, you have to learn the strategy, you have to learn tissue response, you have to learn the response to energy tools. But the reality is that you don't have to learn how to move your hands, which is not true in open or laparoscopic surgery. You have to learn those on the patient, mostly. There is an unrestricted use of microsurgical techniques in laparoscopy. That is, I can replicate 100% the microsurgical techniques as they were created in gynecology, and they are perpetuated in robotic surgery. It's a multi-specialty platform fostering collaboration. I'm about to scrub in a big endometriosis case with a colorectal surgeon. Yesterday, I did half of my case with a urology surgeon. And these are things that on the robotic platform are very easy, because the doctor comes in, usually uses the same instrument. If not, they can just change instruments. But the reality is they have a field that's familiar to them. Immediately they can step in. And with double console, you can even stay at the field. There are many studies on the superior ergonomics resulting in decreased fatigue, decreased operator injury. Our own group published on ambidexterity. We basically don't have a dominant hand in robotics. I can operate with my left hand, even though I could never do it before robotics. And I do all of the left side, for example, of a hysterectomy with my left hand, the right side with the right hand on the vessels. And that is something that changes a little bit the ability of the surgeon. 3D perception and tremor cancellation allow my tool of choice, which is a laser knife, to achieve micron level accuracy. And I'm not exaggerating on this, because the lateral thermal spread of the CO2 laser is only 100 microns. Now, after having said all these beautiful things, I'm also saying that robotic surgery is conceptually primitive. And why is that? Because there are many technologies that are currently being evaluated for application, and some of them will probably be applied sooner than most of us think. They include the optimization of natural orifice and single port surgery. You know that we're expecting some studies being done soon, hopefully on the Da Vinci single port, but there are other several other single port platforms that are being evaluated. Optimization of telesurgery and telementoring, which are very important, specifically in very large countries like Russia, like Canada, United States, where you have centers of excellence that can be hours of plane flight from where the patients need the surgery. And we can already technologically telebeam a surgeon from one city to another to help into difficult cases. This is going to be very important, and is going to be developed significantly in the future. Visual enhancement, real-time fusion, when we can actually see our MRI and CT images in real time, movement with the video feed from laparoscopy. That is going to be also that is actively being investigated at all levels in medical robotics industry. And then to a higher level, we will actually reach AI-assisted anatomical navigation, such as avoidance of large vessels and other areas that will basically not allow the machine to proceed beyond a certain proximity to vital organs. Semi-automation, in my view, is still almost a generation away, but that one will be something obviously that a true robot will have to do at some point. But what is already here is major financial logistic advantages to health systems through different ways of intending the acquisition of robots. Particularly, I'm referring to the models of pay-per-click, where you actually don't purchase the machine and you only purchase the semi-disposable and the right to use the robot, which are already a model in some robots available for sale, such as the CMR robot in Britain and even the Da Vinci now in the United States. Now, for what I do, I'm an IVF physician and I do robotic surgery for my fertility patients. Are there real indications for these patients? The reality is that my entire practice both academic and solo practice, are completely robotic for many, many years now. And I perform with it excision of endomyomectomy, hydrosalpingectomy in the frozen pelvis for patients with IVF, management of complex adnexal masses, tubal reanastomosis for patients with voluntary ligation, excisions of hemivaginas in patients with ovira, adenomyomectomy in the few indications, and more recently, a lot of isthmosil excision and repair. Obviously, you can do ovarian transposition, although you arguably don't need a robot for that. And ovarian tissue reimplantation. We have an uterine transplantation program, which at this point is frozen by the lingering effects of the pandemic, politically and socially, but we hope to revamp. I'm going to go here to something very simple, which is the, let's see, which is the excision of dermoid, which we perform in a containment system to avoid the spillage. It's very hard to do this in with straight six because of what you see. There is a conflict on the rim of the container, but with the robotics, you can completely operate in the bag because of the flexibility of the instruments. And so basically, we insert a 10 or 15 bag and perform the entire operation then in the bag or just above the bag so that we don't have to worry about leakage of fluid. And I have a bigger one that I can show. This is a large dermoid that's inside the bag. So when you get to the area which would create the spill, you're able to then start the dissection inside, and you can now, especially with a large cyst of this kind, you can see how it is significantly easier to work with instruments that can where the tips can bend and do not interfere with the edge of the bag, so that the entire cyst can be removed and placed in the bag without any spillage of potentially toxic fluid. Everybody here, I'm sure, has seen or has heard of the potential peritonitis, chemical peritonitis, very difficult to treat with steroids and everything. So I'm going to go to the next one. And we have already discussed why robot is helpful for this. Tubal reanastomosis is also something that we do, and we're very happy to use the standard microsurgical techniques. This is an 8-0 suture that we use for transluminal reanastomosis. And again, here we have ambidexterity at play. We have tremor cancellation at play. You can see there is no tremor of the camera, obviously, but it's also there is no tremor of the needle, which is again an 8-0 needle skimming the tubal lumen, and we allow this to occur, and we have excellent results. This has been, in fact, one of the first described gynecologic operation. Dr. De Geld from Belgium has the best paper on this, in my view, because it divided the outcomes by patient ages, which makes more sense. We lay out the sutures, and then we are able to do the knot tying. Again, remember, these are ophthalmic grade sutures, so these are the ones that you can use on the cornea as well. Very small sutures, and they really do express one of the best potentials of the robot. But whereas this is you cannot argue about the merit of this. There are other applications of the robot that may be less shared by everybody as why you would need the robot. This is our flexible laser that we use, and for example, you have this nodule endometriosis. This is peritoneal, but with more than half a centimeter depth. So you can consider this a deep endo. Obviously, it's a very mild form of deep endo. But I want to point out how helpful this tool is to wield a type of energy that has only 100 micron lateral thermal spread, because you can use this over vessels, over the ureter, around the rectum, with a fire and forget type of attitude, in that you will never have delayed thermal spread that can surprise you. I've used this tool, which was developed here in Boston at MIT, as a means of telecommunication, and then eventually repurposed for endometriosis and other surgeries that we do, as well as for neurosurgery. It's used in 2 or 3 fields in medicine. This is CO2, but I think the main beauty of this is it's a fiber, it's not a line of sight. So you can see I don't even use a backstop, because even if you go through on the other side, you're not going to do significant damage. For time purposes, because I only have probably about 3 minutes, I have to move on. But I assure you that I use this tool for the deepest forms of endometriosis in the retroperitoneum, and works exceedingly well. So for both high-end, high-stage and low-stage endo, with the high stage, I particularly use the ICG staining of the ureter, so that I can use low infrared to evaluate the ureter location, and it's very important. I don't think I should talk about endometrioma after Dr. Koenig's, and it's all my my point here is that we do a full cold technique. We address the anchor. We do a full cold technique for endometrioma, and we use the beauty of the robot here is excellent plane visualization, and also significant help for those of us who repair the ovary without strangulating, with very light suturing. It makes it very easy for us to do that. Again, this is I have very little time, so I don't want to go over all of the technologies and the techniques, but here I'm using standard robotic instruments with a endo shear, basically on number 2, on arm number 2. And I'm showing how you can use cut only, and then you can use the ability of the robot to suture. And I show this, and when I have time, I show all of it, but not today, to show that this, in the end, I disclose that this is my fellow operating and reconstructing. The fellows do almost all of the reconstructions for our myomectomies, and they do extremely well. And as we all know, with myomectomy, you're working against time because the uterus bleeds during it. So it's an operation where speed is very important. And in my view, this actually helps a lot. And also in training, you don't have to sacrifice patient safety, because you can tell the fellows that if they don't operate as fast as you will take them off the console immediately, and they will go to the simulator, and they will work hard to get better on the speed and economy of movements. This is a single-site adenomyomectomy. It is hard to talk about adenomyomectomy in the house of adenomyosis with Dr. Adamian, but this is also just to show you use of a single-site technique. This was done through a single port, and it shows how you can push the envelope for small adenomyosis. This is a focal adenomyoma, and I find the laser helpful, but also the visualization that the robot allows is very important. And this is another technique that we do is the isthmosil repair. In isthmosil repair, this is a good example of how you can use the near infrared technology to show the location of the isthmosil. We're publishing this on Fertility and Sterility this summer, has been accepted for publication. So this is a nice technique where the robot actually has a couple of good things. This is a hysteroscopic light shining inside, and then it allows us to identify all of the isthmosil by way of a near infrared technology. Ovarian tissue reimplantation, and it's the last technology that I'm showing. This is also something that is a classic reproductive surgery technique for which I think the robot really adds a lot from the orientation of the specimen. Remember that there is a medullary and a cortical one, to the placement with 6-0. These are 6-0 vicryl sutures for placement of the tissue. This is orthotopic, so is within the location of the ovary. It was previously removed. So this is just to show the technique, but again, there are several aspects of techniques that where the robot can help significantly. And this one allows a complete replica. And then one last comment, and this is really the end, is that this is not at all at this point, 2005, when we started with one player only, intuitive surgical. We have important competition coming, and I showed this picture specifically because it shows an arm of an upcoming robot where you have, instead of 3 joints, as we have in the Da Vinci robot now, you have 9 joints. So we're now going really like to the quadratic, to the square of potentials. These joints allow, by the way, this machine to avoid external collision by moving one arm in front of the other when necessary. And I'm going to conclude here because I think we are right at time, and I don't want to take more time. But again, I hope that this has given you, a good perspective of why I think there is significant good future for the robot in this field. And again, Dr. Adamian and the scientific committee, thank you again for this very kind invitation. I'm honored to speak at this conference. Thank you.
Thank you very much, dear Antonio. Thank you very much. As usual, brilliant presentation. And I extremely like your approach. All these surgeries that we normally do manually. You do it through the robotic hand, robotica manually. It all sounds good. It all sounds good. Well, I already tried many times. Probably you never heard and never saw such adult surgeon who gained robotic certification at my age, because last year I got second certification for robotic surgeries, and I performed already 18 cases for 10 days in different clinics. And I used all standard methods known by that time using the robot. So I am in love with robot, but unfortunately, we need to talk more about it because I think there are some challenges with the installation of arms, with some, preparation to the robotic session. I have no question about robot itself, but definitely price toxicity is still quite toxic. But you are a brilliant surgeon, and thank you very much for connecting. So we are happy to have 9 joints instead of 3, and we will do the ovarian reimplantation as soon as we need it using robot. Thank you very much, and I wish you a very good day. Thank you very much for the connection. And now I'm happy to give the floor to Professor Hans Steinenbrink. He will speak about the review of lab studies in endometriosis, director of the female clinic. And I have to say, by the way, that Marburg in Germany together with Professor Tinenberg. Well, we know each other for about 40 years, and every time, I'm amazed by his very progressive vision. And I'm surprised a little bit by the title of your presentation, Professor Tinenberg. So you will speak about the search of markers, I hope. Maybe not. And you will speak about pre-op diagnosis. And well, I think there are not yet such markers, so we're happy to listen to you. And I appreciate if you stick to the timing. You have your 20 minutes. Floor is yours. Thank you very much.
Dear Laila, respected audience, it's a great pleasure of mine to be here with you, even though I would prefer to be on site, not at least to give you a big hug, Laila. So we have to put up with this way, but it still is quite helpful. And you're right, this is not usually my topic to talk about lab testings, but my lab itself spent a lot of time in developing laboratory tests to, at least for screening of endometriosis. And I'm glad that you had the presentation of Philip Connings before, because what I'm talking about again highlights that medicine is mainly a science of experience rather than of developing significance. Now, when talking about laboratory testing, we have to ask ourselves the question, why are we fond of laboratory testings? And it is quite obvious. We probably need some screening, and this is mainly looking at adolescent women or girls that we do not want to subject to surgery, because so far surgery still might be the gold standard because it allows us to have a histological diagnosis. Now, a screening would be by far less expensive than a surgery, and as I said, it would be very, very helpful for adolescents. If we can avoid surgery, it would be very helpful, because every surgery, even whether it's robotic or not robotic, open or laparoscopic or whatever, it involves a risk. And since we know, and Philip also highlighted the new tools like ultrasound and MRI, they are very helpful, and they added a new dimension to diagnosis of endometriosis, but only if there is already a focus. So that is what we have. That is what we have to deal with, and that is what we want to see. Now, there has been a very interesting and very comprehensive meta-analysis by Niesenblatt, and I have summarized this because this is a huge paper, and I hope you do not mind that I sort of try to simplify by saying minus or plus. And plus means it did not meet the criteria for a triage testing, but at least it was so good and so prospectively helpful that the conclusion was further studies recommended. And a minus means there was insufficient evidence. And now I have listed all different aspects, and I will just go through the headlines. And first of all, it's cell adhesion molecules and other matrix-related proteins, apoptosis markers and angiogenesis and growth factors and their receptors. So this is very comprehensively concluding all that has been done. It is high throughput molecular markers, hormonal markers, immune system, and inflammatory markers, which we all think because we know endometriosis as a chronic inflammation. But what has evolved from the study is that it lacks the specificity that is only related to endometriosis. Now, it continues like investigating other peptides, oxidation stress markers, tumor markers, and mainly CA12-5 has been the top hit of it. And we can see that other peptides and oxidation stress markers showed some promise. Now, how it is with transcriptional regulators of gene expression. And here we can see these mRNAs, they also showed some promise, but nothing was really conclusive. Let's go further. And that is, since most of these parameters on themselves showed that they are not really helpful, that they are not at all statistically significant or sufficient, they combine two markers like CA12.5 and CA19.9, and again, it could not go beyond the level of being promising, but further studies needed. Now, CA12.5 and VEGF, very clever combination, but still not helpful. And inflammatory markers and tumor-related factors, not helpful. Then 3 markers were combined, and you can see it seems that it increases the promising character of these combinations. And mainly it was that CA12.5 was combined with other factors. And next was to combine 4 and 6 markers, but nevertheless, it has not reached the stage beyond being promising. So what can we conclude from these studies? What we know is that anti-endometrial autoantibodies, and again, I would like to quote Philip Connings, who did quite a lot of work in that area, but it is nothing more than a beneficial or additional tool, and it's not going beyond CA12.5, so that is what we have to today. And you can see the references are marked in between. Interleukin 6, it's relevant in monitoring pre-sepsis, rheumatoid arthritis, and pancreatitis, and it is associated with inflammation and infections, but not at all specific for endometriosis. The third one, and I concluded 4 of them, it's CA19.9. We know this as a very important marker for pancreatic cancer. But then again, we know it's pancreatic cancer, but even for pancreatic cancer, it's only a surrogate marker for relapse, but nothing more than that, and definitely not for endometriosis. Now, last not least, it is CA12.5, and we know it is a tumor marker. It is found in membranes of mesothelial cells, and we know that we have increased levels which are unspecific for peritoneal inflammation. And we also know that it was found in malignant tumors of ovaries and many other things. And we know that it's associated with the endometrium, but also with the tubes, the lung, gastrointestinal tract tumors. And that is why the overview could not show more than just promising. In conclusion, this means that even these 4 very promising biomarkers have not been evaluated by enough studies that were showing a real relevance of this test to have a meaningful test accuracy. None of these tests was accurate enough, at least to replace diagnostic surgery, and that mainly applies to mild and moderate endometriosis, particularly of the peritoneum. And we could see that of course, there were several studies, but there were too few reports to be sure of the diagnostic benefits. So overall, what we can say is there's not enough evidence to recommend testing for any blood biomarker out of all these different groups that you've seen, to have a meaningful test that one can rely on if, for instance, an adolescent comes to you and wants to be diagnosed. So I think this is very, very important. And I know that a lot of work has been done in that respect, but this is nothing that we can bet on. Now, there is some new development, and I called it latest development, and this is based on the commercially available microRNA tests And perhaps you remember that the last aspect was microRNA, and there were quite a number of microRNAs that were regarded as being helpful, but they did not reach a positive level. Now, the Paris group around Sofiane Bondifala, they have done a lot of work, and very interestingly, and also seeing the latest presentation where we can see that artificial intelligence has been introduced into many aspects, whether it's robotic surgery or now it is about testing. Bondi Fala, they said, we wanted to investigate machine learning algorithms for patients with endometriosis, which means that you can feed a lot of data, and machine learning or artificial intelligence is capable of handling so many more data than we can do for ourselves. But this was only the beginning. They came to look at serum microRNA. Then they had a prospective study where they tested in blood samples microRNA analysis associated with endometriosis, and then they generated a signature for endometriosis based on blood microRNA. And so finally, and this is the conclusive study, which was the basis for developing a commercially available test. It is salivary microRNA signature for diagnosis of endometriosis. And I will briefly go with you through this publication. And this is, on the one hand, this is very good to have this study. And you can see it is 109 microRNA biomarkers. In the meta-analysis that I showed you by Niesenblatt, the maximum number of biomarkers was 6. Now it is 109 microRNA biomarkers. So they reached a sensitivity of 96, specificity of 100%, and diagnostic accuracy of roughly 98%, which is pretty good. But, and there is a big but, it is that these are only, I have to see how I can get rid of my, they had only 47 controls and 153 trial patients, and they only used the R-ASRM classification. So the majority was over 50% was 1 and 2, and the other 48% were stage 3 to 4, and they could find that a high proportion of these patients had endometriosis, but, and this is again something that Philip Connings highlighted, they also had other abnormalities, which may have been another confounder in that respect. Now let's look. What is the indication for use of a test that was evolved from that? And that is, if you have signs and symptoms and imaging doesn't take you any further, particularly when there is a normal imaging or a doubt, then you can either do an empirical medical treatment, which is suggested by the RCOG guidelines in Great Britain. But in this case, you could apply the endo test. And of course, if there is endometrioma, there is no need to perform an endo test. Then, of course, medical or surgical treatment that should be applied. If you look at the development, of course, the first was questionnaires, then is imaging, and the sensitivity and the specificity is not as high as being calculated for this test. Then laparoscopy, of course, laparoscopy has different stages. Just looking is by far not as good than taking a biopsy. And of course, and this is a slide that was given to me by the company, they say we are much better than you can imagine. This is the product. It's the Civic Endotest produced in France, and it's all fine. And I would not mind using it, but we have to take into consideration there is one backdrop, and that is the price is about 800 euros. So you can even do a good surgery for 800 euros, I guess. And still, this test is not sort of really reliable. You have also other factors, even though they say the specificity is 100%. And by saying so, dear Laila, I am concluding my presentation. And of course, everybody has to make their own conclusions and has to decide. But for me, myself, I am not a great fan of this latest development. Thank you very much.
Dear Professor Hans Tinneberg, yes, I used millions of tests in my life. We believe in one test, then in another test, but today I know that there are no tests to diagnose endometriosis. All tests, as we've already mentioned, show that there is no just one single disease. There is myoma, hyperplasia, ovarian tumors. Well, thank you very much for this objective and exact presentation. Thank you for showing all the options as far as these tests are concerned. Specificity is 100%, accuracy 98%. Well, but there was no differential diagnosis of different pathologies. And the test, which costs 800 euros, well, I agree with you. Well, you can have a surgery for that money. Thank you very much for being with us. Good luck and bye-bye. Well, dear colleagues, now I'd like to give the floor to Professor Michel Nissol. Michel Nissol has been dealing with endometriosis during the entire period of life, a professor, a specialist in reproductive surgery, a person who is in charge of the journal. And Michel Nissol is our friend. The theme of the presentation is There a Place for Deep Endometriosis Surgery in Infertility? We know that surgeons operate on all patients. Specialists in reproductive medicine, well, usually try not to refer to surgery but prefer ovarian stimulation. Often such things are useless. So let's listen to Michel Nissol from Citadel Hospital, chair of the Department of Obstetrics and Gynecology, Liège, Belgium. Dear Michel, the floor is yours, and please do not overrun your time. Thank you.
The kind introduction, and it's a real pleasure to see you again and to share with you this topic, because I think it's very important to know if we have to operate patients with deep endometriosis in cases of infertility. So you know the guidelines published by the ESHRE. When you have a patient with infertility and deep endometriosis, we have the choice between surgery and assisted reproductive medicine. And in fact, the arguments to send the patient to IVF is to reduce conception delays, to reduce the risk of postoperative ovarian reserve damage, and to avoid the possible effect of postoperative complications on patient fertility. I think that when you have a patient in front of you with infertility and deep endometriosis, there are two questions. The first one is the patient a pelvic pain patient or completely asymptomatic? And the second question is about the pregnancy. Should be the pregnancy obtained spontaneously or not at all? Is there an indication for IVF? When we have to speak about infertility and deep endometriosis in asymptomatic patients, this is the real debate. In fact, we have to know if there is evidence that operative laparoscopy for deep endometriosis improves fertility. But in fact, the answer is we have no randomized clinical trial on reproductive outcomes after surgery and after expectant management. So the guidelines published by the ESHRE propose that women should be informed about the possibility of becoming pregnant after surgery by adopting the endometriosis fertility index score to identify patients who may profit from IVF following surgery. So today we will speak about the endometriosis fertility index later in this presentation. But in fact, when you look at your patient, we know that the majority of patients with deep endometriosis are painful. And we can say that more or less 11% of patients did not report any gynecological pain symptoms. So what do we know about deep endometriosis and pelvic pain? So is there an improvement of pelvic pain after laparoscopic surgery? And in fact, we know for a long time that the answer is yes. Here you can see the paper published a long time ago by the team of Leuven here in Belgium. And the conclusion was that the radical surgery but fertility sparing for the treatment of endometriosis is followed by a significant improvement of pain, quality of life, and sexual satisfaction. So the ESHRE guidelines propose an operative laparoscopy that could be a treatment of choice for symptomatic patients who want to get pregnant. And deep endometriosis surgery is necessary and recommended if there is a bowel or urinary obstruction or in cases of pelvic pain. Now, if we look at the impact of surgery on fertility, here you have a summary of the different studies performed a long time ago, and you can see that the majority of the studies were retrospective or prospective. You can observe that the surgery was bowel resection and colorectal surgery. And in fact, you can see that the cumulative pregnancy rate was high, except in this group of patients. And look at this group, it was a group of patients treated by laparotomy. So it means that if you perform a bowel resection by laparotomy, the cumulative pregnancy rate is very low. So nowadays, there is no indication to perform laparotomy to remove deep endometriosis. We will discuss now about the paper of Horace Roman, published 5 years ago, because you can see here that the rate of cumulative pregnancy is very high, 75%. And in fact, the importance of this paper is also to see that the natural conception is more than 50%. In fact, it is 53% of patients operated for deep endometriosis, colorectal surgery, followed by a high rate of natural conception. And here in this paper, you can see that the patient receiving advice from experienced surgeon on conception mode, so it means either spontaneous, either by IVF, were more likely to conceive faster after surgery. So it means that the surgeon, when the surgery has been completed, has to fill the endometriosis fertility index in order to give an advice to the patient to be sent to the IVF department, on contrary, to be pregnant spontaneously. And here you can see again the ESHRE guidelines. After the surgery, due to the FE endometriosis fertility index, we can propose to the patient to go to IVF or to try to be pregnant spontaneously. And on the right side of the slide, you can see that when the FE score is high, the rate of pregnancy is higher when compared to the FE score very low. Now, what do we know about the impact of surgery on IVF results? In fact, we have here in the literature a paper published in the Gynecologic, and this paper seems to be very attractive. In fact, it's a prospective study, including a large number of patients. You can see the number 105 and 64 women. And here you can see the design of the study. the patient with the diagnosis of endometriosis, there is a patient allocation, and the problem of the study was this step, the patient allocation, because the patient has the choice to be sent directly to laparoscopy and after that to IVF, or not undergoing laparoscopy, but going directly to IVF. And you can see here the group A and the group B, and we will compare the results obtained by IVF. And in fact, if you look at the results, it seems that it's better to operate the patient before IVF because the implantation rate and the pregnancy rate were higher when compared to the patient sent directly to IVF. But in fact, the problem of this study is the patient allocation. So it means that it was not a randomized clinical trial. This paper published by Bretto and Arnaud Vattiès is also interesting because we can see the impact of deep endometrial surgery in patients who had two failures of IVF. They analyzed a group of 73 patients, and you can see that the rate of the post-operative pregnancy rate was high. But interestingly, we can see that 21% of patients were pregnant spontaneously after the surgery. Even at the beginning, the patients were previous to be pregnant due to IVF. So what is the fertility after surgery followed by IVF versus IVF directly? Here we have a study, a French study, Mounsam Botte and Émile Laraille, a retrospective study, and you can see the comparison of the cumulative pregnancy rate were similar in both groups. I will not go into the details of this study because I have no time, but I think that the message of this paper is finally to decide surgery or not is according to the pain of the patient, to the age, to the tubal permeability, the ovarian reserve, and the sperm characteristics. Another paper published by Bendifala, and we have already heard about Bendifala, about the salivary tests. It's the same gynecologist working in Paris. And in the retrospective study, you can see that there is a significant difference in patients undergoing surgery followed by IVF when compared to patients undergoing directly IVF. So for this team, there is an indication to perform surgery before IVF. And here you can see the paper, but you can see also that when you perform the first-line surgery followed by IVF, the results are better. It's exactly the same. And in fact, if we are going to see the systematic review and meta-analysis, we can say that there is no randomized clinical trial, but the surgical treatment of deep endometriosis improves IVF outcomes compared with those in patients who did not undergo surgical treatment. What about the complication of surgery? Because you know that this surgery is complex and usually all gynecologists will have complication. We know also that deep endometriosis is associated with other locations such as uterosacral ligaments, the ureter, and in fact, those anatomical considerations increase the risk of surgical complications. For example, if you have to perform an ureterolysis, be careful because it's not a good idea to have a complication with the ureter, but nevertheless, you can see that deep endometriosis still left in place, and we will use, in this case, the CO2 laser to remove these deep lesions, probably causing pain during sexual intercourse. On the right side, you can see here the hypogastric nerve. So during the dissection, be careful, don't cut those nerves because the patient will have a problem with the bladder function. The complication could be minor and major. We can have a fistula, anastomotic leakage, and here this example is in my department. We observed a leakage of the anastomosis 2 days after the surgery, and the patient underwent a ileostomy. But what about the risk of complication? We know for a long time that the rate of complication is related to the bowel resection. And this paper published also by Horace Roman demonstrated very well that the rate of clavien dado 3B postoperative complication was significantly higher in cases of segmental colorectal segmental resection. So it means that if you could perform a shaving, do a shaving because the risk of complication is less. What do we know about the fertility outcomes after severe complication? And in fact, again, the paper of Horace Roman and Ferrier, you can see here a high rate of patient, 900 women with deep endometriosis with colorectal involvement. A rate of complication, you can see that the number was 48 women. And you can see that 20 women were pregnant and also spontaneously. So it means that if you have a severe complication, it does not mean that you have to send to the patient to IVF directly, because some patients could be pregnant spontaneously after severe complications. And you can see also that the rate of cumulative pregnancy at 5 years was 46%. But nevertheless, if you compare the type of complication, we see that the cumulative pregnancy rate was lower in cases of anastomotic leakage or deep abscesses. And in my department, sometimes it's difficult to say to the patient after IVF, you have to be operated, but don't forget that those patients who received many stimulation could have ureterohydronephrosis, as in these cases, or in another cases, renal kidney atrophy due to the endometriosis located on the ureter. And in fact, there is in the literature also some paper concerning the endometriosis progression during IVF. If you look at the ESHRE guidelines, you could read that women with endometriosis can be reassured regarding the safety of IVF, since the recurrence rate are not increased compared to those not going ART. And you can see that the paper related to this sentence is Benaglia and Somigliana. But if you are going into the details of the studies, you can see that in the first one, the patient underwent only one IVF cycle and the size of the nodule was very small. So it's easy to say there is no risk because one cycle of IVF is nothing. And the second paper is more or less the same. You can see that the patient underwent one IVF cycle, but also that the visual analogic score was very low at the beginning because the dyspareunia at baseline was less than 3. So it means that the patients were not so pelvic pain patient. What about the complication of IVF? We can say that if the patient has bowel endometriosis and are undergoing IVF or pregnancy, in the literature, we can read that bowel occlusion and perforation were described in 21 cases, either during the pregnancy, after the pregnancy, or during the IVF stimulation. So probably the complications requiring major digestive surgery are probably underreported. So as a few slides concerning the conclusion, we can say that the IVF in patients with deep endometriosis, there are some disadvantages. We are not convinced that there is no progression of the disease during the stimulation. And personally, I think that it's very difficult to operate patients after 4 or 5 cycles of IVF. And we know also, but I have no time to explain everything, but there is also a risk of infection, ovarian infection, and ovariatis. On the contrary, we have advantages of surgery. We have an improvement of pelvic pain, that's for sure. There is an increase in infertility, either spontaneous or IVF, and the fertility is preserved even in cases of complications. I would like to propose you 2 algorithms. The first one is concerning the management of bowel endometriosis. We published that a few years ago. So the diagnosis is not a problem. When the bowel endometriosis is considered as superficial, we will propose a shaving because we have seen that the risk of complication is less. On the contrary, when deep endometriosis is infiltrating and very deep in the bowel, according to the symptoms and the patient consent, we will perform a bowel surgery or a shaving because sometimes patients refuse to go to the bowel resection. But in this case, we know that the shaving will let complete removal of endometriosis. Concerning deep endometriosis and infertility in patients with pelvic pain, in fact, you have to decide if the patient could be pregnant spontaneously or not. If according to the age, the tubal patency, the ovarian reserve, and the sperm characteristic, you estimate that the patient could be pregnant spontaneously, you can go directly to perform the surgery because the patient is a pelvic pain patient. On the contrary, if there is an indication of IVF due to the, for example, the male characteristics, according to the patient design, according to the previous surgery or the age, you can choose between performing a laparoscopic surgery followed by IVF or performing IVF 2 cycles followed by surgery if there is a failure. But please don't wait 4 or 5 cycles before performing the surgery. And I would like to finish my presentation to invite you to come to Brussels if you could come in Brussels in October to participate at the next ESGA Congress. And as president, I would like to welcome you during this Congress. Thank you so much.
Дорогая Мишель.
Well, dear Michelle, thank you very much. You've been dealing with endometriosis all your life. I have 2 questions for you. I know that you like laser, you like the flexible laser, and you use the laser in what cases when you treat endometriosis? That's my first question. And my second question is, if you say that first we should have a surgery, colorectal surgery, retrocervical endometriosis, after what time can we allow pregnancy for such a woman, please? Do you use a surgical razor? What type of razor? Flexible CO2 laser? My first question. And after surgery, that's my second surgery, after retrocervical or colorectal surgery, when a woman can become pregnant. Thanks.
Thank you, Leila, for the question. As you know, I am using the laser for each patient. The laser is always in the operating room, and it's not flexible. It's the articulate arm, and it's for all cases of endometriosis and all reproductive surgery, I would say. Concerning the pregnancy in patient undergoing colorectal surgery, I would propose to wait a few months because usually the patient has to have a recovery because it's a strong operation, and usually we will wait 3 months certainly before going to IVF or before trying to be pregnant spontaneously. We will wait a few months.
Could you tell me, please, well, your choice of hormonal therapy, if we administer hormonal therapy, histogens, agonists, or maybe something else? What's your choice of hormonal therapy?
So in the past, I was using analog therapy for a long time, but nowadays anymore at all. So we will propose to the patient dienogest before surgery for pelvic pain or after the surgery before the IVF or estroprogestin pill, but continues to avoid menstruation. But no agonist therapy. Dienogest is my preference.
Thank you very much, and see you in Brussels or somewhere else, in Leuven or somewhere else. Bye-bye. Thank you.
Уважаемые коллеги, нам
Distinguished colleagues, Now we are welcoming Professor Abrao. Professor Mauricio Abrao is a great name in endometriosis and metacervical endometriosis and classification specifically. He is a huge friend of ours, and he's very famous global expert. Professor Mauricio Abrao, who is the Associate Professor of Obstetrics and Gynecology Chair in São Paulo University. He is the lead of endometriosis department in Brazil, and he will speak about the modern algorithms of gut endometriosis treatment, intestinal endometriosis. Mike is yours, 20 minutes.
Thank you, Leila. Thank you for inviting me. It's my honor and pleasure to be here. I'm going to talk about what we are doing in terms of how to treat deep endometriosis. And for me to start speaking about this, I think that I would like to mention that there is a big effort, global effort, to unify the terminology for endometriosis. This is an important thing because in the past, for example, many surgeons was having different names for the same disease. And in this publication that I recommend all of you to read, we try to define some details, mainly, for example, the definition of recurrence and persistence of the disease. That is something that is very important for the specialist to evaluate the treatment of endometriosis. So here I'm going to discuss different aspects of the treatment, starting from the current concept.
Professor, slides are not changing. Slides are not changing. Please, please change the slides because we still see the first slide with the title and nothing else.
Let me try here. Now you can see, right?
Yes, now we can see it, but this is not full screen. Could you please make it full screen option? Так, сейчас я попытаюсь выйти в полноэкранный режим. Yes, and please click couple of times. Click couple of times to see that they are clickable. No change, no change, no change, no change. It's still pain and infertility. It's still the same slide.
Пожалуйста,
Slides are not changing, unfortunately.
Rapidly, please. Can you hear me?
Yes, I can hear you. Just two slides are changing. Just two slides are changing.
Okay, right?
Ну, хорошо.
All right, let's proceed.
So the next thing to be discussed here is that when we talk about endometriosis, we need to consider that we may have different phenotypes, meaning that we may talk about the superficial disease, the ovarian disease, and the deep endometriosis, right, in different sites. And this is very relevant for us to start a strong discussion about the treatment of the disease. In our experience, some years ago, we published a study showing that with more than 1,000 cases, 40% of the cases that we do surgeries here may have deep endometriosis in different sites. But what is very interesting is that 20% of all cases may have the bowel compromised by the disease. That is very important for this purpose. The other important aspects for us to discuss is that we need to decide about the best treatment for endometriosis, also considering which is the main symptom of the patient. If the main symptom is pain, and we know that pain may be related to many aspects of inflammation of the related to the disease, and also the presence of activated mast cells near the endometriosis lesion, and also the intense immunoreactivity for nerve growth factor. But we need to consider the infertility as well. And we know that when we talk about deep endometriosis, we have more cases of infertility when compared with non-deep endometriosis, as you can see here. So when we discuss this, we need to define the therapeutic algorithms considering the presence of the symptoms, or if the patient, and which symptoms we are talking about. In our experience, 90% of the patients have symptoms, and in 10% they have low symptoms, and of course the algorithms that I'm going to present will be related to this aspect. Another important aspect, thinking of the future, is when we consider that nowadays we know that the classic criteria for the definition of endometriosis is the presence of glands and or stroma outside of the uterus. But also, we are on the line, thinking of the future, to redefine endometriosis, including the profibrotic nature. This is a very important opinion paper proposed by Paola Vigano and Edgardo Somigliana and the group from Milano, mentioning that fibrosis must receive more attention as potential targets of medical treatments for endometriosis. And the definition, including fibrosis, may have clinical and diagnostic implications. Saying that, for us to define the treatment of the disease, the starting point is the diagnosis of endometriosis. As you must know, right? Sometimes we just see in a laparoscopy the tip of the iceberg, and according to many publications of our team, it's possible to use imaging to diagnose the disease, but more than this, right? The imaging can be used, right, to define the best treatment and for us to be prepared to what we may found during the laparoscopy. In this study that we published in Human Reproduction 15 years ago, you can see that at that time, the transvaginal ultrasound done by trained specialists with a very simple bowel preparation have a sensitivity of 98%, and it was better than MRI. That at that time, the sensitivity of MRI for endometriosis compromising the rectum was 83%. For retrocervical endometriosis, the sensitivity is slightly lower, but it's good, right? And also better than MRI. So for deep endometriosis, we think that ultrasound is the first line exam, but of course, the sonographist must be trained for this purpose. And this is something that is being used in many different countries, right? Like Italy, like Spain, France, looking for the best way for us to diagnose the disease. In other papers from our team, we showed also that for bowel disease, we can have other informations related to the imaging. We know that when the disease compromises the bowel, the imaging can provide us information like the distance between the lesion and the anal verge, the morphological characteristics of the lesion compromising the bowel, like the size of the disease, the depth of the disease, right? And the circumference of the rectum that is compromised by the disease. So with this protocol that allowed us to train people from all over the world, we have strong informations that can allow us to define exactly what can be done during the surgical procedure, right? And this is an example, right, of a normal rectum, the different layers of the rectum, right? And when we have a hypoechoic lesion related to the disease, as you can see here in this slide, this is a hypoechoic lesion compromising the bowel of the rectum, right? Invading the muscularis of the rectum, and with 2 to 3 centimeters, that is an information that is relevant for us to define the treatment. So the sensitivity for the imaging is good, not only for us to define the presence of the lesion compromising the bowel, but also the number of the lesions, the deepest layer, in different ways, as you can see here. And in a very recent study, that I think that is very, from the practical standpoint, is a study that is changing the way for us to see, to diagnose the disease. Here, we published it 2 years ago, a study showing that when we compare ultrasound with diagnostic laparoscopy, ultrasound may be even better than the diagnostic laparoscopy. So what we did here was to evaluate 120 consecutive patients, and we compared the beginning of the laparoscopy, that so-called diagnostic laparoscopy, that we recorded and we sent to external evaluators. And these external evaluators staged the disease, right, and comparing with the ultrasound that the patient did previously. And the conclusion of the study was that ultrasound, transvaginal ultrasound, it was even better than diagnostic laparoscopy to predict sites of endometriosis and bowel disease. The ultrasound has good accuracy for staging the disease. At that time, we used ASRM and Angel score, and also it can replace the diagnostic laparoscopy for the surgical planning of endometriosis. Saying that, this is our pre-surgical workup. We start with a good clinical exam and a good ultrasound. We don't do markers anymore. If it's normal, the patient may have early stages endometriosis, peritoneal disease, or even no endometriosis. And we can be more conservative. If it's conclusive, we can define the treatment. And if we have questions about the ovary, the MRI is recommended. Questions about the bowel, the transrectal ultrasound is recommended. And questions about the urinary tract, we may do urography or MRI. So after this, it's important for us to mention that there is a new classification of the disease, right? That is a very user-friendly classification from AGL. And in this study, we evaluated the possibility for us to stage the disease, looking for different sites, right? And there is, depending on the presence of the disease in these different sites, we can stage the disease in a 4-stage system, right? And after this, we also pushed the society to submit this publication about the use of imaging for stage the disease before the surgery. So I invite all of you to download from the App Store, from your mobile, the Android or the Apple Store, if you want to take a picture of this QR code. It's possible to download this app, and then you can see there the publications that originated this classification. And with this app, we can click in different sites of the disease, saying if there is known disease, the size of the disease, and the different aspects of the disease, ending with 4 stages classification depending on the presence of the disease in different sites before and or after the surgery, right? And then we can submit this PDF to the report of the patient. That is very important and would help us to define which treatment needs to be done. And here we can, when we talk about the bowel endometriosis, we can discuss the possibility for us to do shaving segmental resection or disc resection. And these different types of procedure, right, they will be done depending on the morphologic aspect of the disease. And of course, if we have information before the surgery, it will be very helpful for us to define which kind of treatment will be performed for this patient. So we are being more and more conservative in the treatment of the disease, and we know that the different algorithms for the treatment of the endometriosis depends on these aspects that I will discuss here. The first one, and this is something that we published a few years ago, shows that for deep endometriosis, if the patient has pain more than 7 in the visual analogic scale and the presence of the disease in different sites, we can recommend surgery for this purpose. And depending on the characteristic of the disease, we can do a segmental resection or a more conservative procedure that should be shaving or a disc resection. When are we indicating the segmental resection? With lesions bigger than 3 centimeters or multiple nodules compromising the bowel, or when the submucosa is affected, or into IVF failures with a bowel surgery, right? This is another recommendation. If the lesion is smaller than 3 centimeters, unique nodule, we can be more conservative. But if the patient doesn't have a strong pain, right, we can be conservative in terms of the treatment, using the imaging to follow the patient, right, and only recommending surgery if there is increase of the pain or of the lesion. When there is infertility as one of the main symptoms of the disease, we are recommending the treatment depending the ovarian reserve of the patient. If the ovarian reserve is normal, and one of the things that can be done is the evaluation of the anti-Müllerian hormone, we can, and the patient is younger than 30 years old, we can recommend surgery if surgery is indicated. Otherwise, if the ovarian reserve is low, or if the patient is older than 30 years old, or the ovarian is compromised, the cryopreservation of gametes must be considered before the surgery, at least for us to recommend to the patient before the treatment. And this is the same that we discussed in this publication, right? In the Human Reproduction Update, when we just went in details in this systematic review about these possibilities to recommend surgery for patients with pain, and the type of surgery depending on the morphologic aspect of the disease. Or if the patient doesn't have enough pain and doesn't have bowel or urinary obstruction, we can be more conservative and recommending surgery just if there is an increase of the symptoms or the disease as well. And another important thing that watching the Michel Nisoli presentation, that it was a great presentation, is our algorithm to treat patients with infertility. That again, starting with the evaluation of the symptoms, followed by the imaging and the evaluation of the ovarian reserve. If the patient doesn't have enough pain or no bowel obstruction or ureteral obstruction, we can be conservative, recommending induction of the ovulation or even IVF, right? If there is a tubal obstruction or failure of the induction of the ovulation. If she has 2 IVF failures or pain, or of course bowel obstruction or ureteral obstruction, we will recommend surgery. And the decision about doing cryopreservation or not depends, of course, on this criteria that I mentioned before, that is the ovarian reserve and the the age of the patient. So this is important. And my last thing that I'm going to discuss here is to show you in the practical aspect of the treatment in this study.
Уважаемые переводчики, переводите громче. Я слушаю ваш текст.
Okay, this is the last slides that where we evaluated 170 patients, and the question was how many times we do what we plan. And in this study of 170 consecutive patients, we planned to do, according to the pre-op exams, shaving in 30 cases, discoid resection in 70 cases, and segmental resection in 70 cases. The conclusion here was that in 85% of the cases, we do what we plan. In other 15%, we may change during the surgery. And we change for less, in other words, we downstage the treatment in 13 out of 15%. And in the other 2 or 3%, we upstage the treatment during the surgery. So again, thank you so much. And I am available to answer questions, right? Thank you.
Thank you very much, dear Professor Abrao. Dear Mauricio, I know that you, like nobody else, know the difference in approaches. You know all the details. And some specialists who do not master these approaches and they don't have extended options of colorectal surgery in their clinics, they treat and treat and treat colorectal, retrocervical, our beloved type of endometriosis, using conservative methods medically without going into the details. And that's even for reproductive age patients. My first question to you, why still it's preferable to do the surgery? What does surgery give us? And my second question, if this is combined option, that means surgery and hormonal treatment, then how do you change this approach? So, because what you told us about the surgery is absolutely brilliant. So please, tactics of management, young females, retrocervical endometriosis 3-4, or colorectal, if the whole gut is not involved, in young females. Please speak about your tactics. Why surgery is first? Why surgery is first? And what if we do combination of surgery plus hormonal? What hormones and how do you prefer prescribing them? I want to get it from your hands. Thank you.
Звук.
No sound.
Звук.
Okay, so thank you for your question, Leila. As I showed in my presentation, I don't recommend surgery to everybody, right? The recommendation of surgery depends on the symptoms of the patient, or, for example, if she doesn't have pain and wants to get pregnant, I may start with the treatment of the infertility or even IVF, and I will recommend surgery if she has 2 IVF failures. That's the point. When I do surgery, the difference between the surgery and clinical treatment is that surgery still now is the way of choice to treat the disease. And the clinical treatment treats the symptoms of the patient, in our opinion, and in the opinion of many experts all over the world. So it doesn't mean that we need to do surgery for all the patients. Sometimes we can do the clinical treatment and follow the patient. And this is something that we do a lot. But when we do a surgery, when we recommend a surgery, the goal is to do a one-shot surgery. That is something that is important. And about the type of clinical treatment, there is no difference between any clinical treatment. I participated in many studies, even the most recent studies with elagolix and relugolix, and I affirm that even with these new drugs, right, the strategy is which drug to recommend to all of these patients, depending on many aspects, the cost, the side effects, the tolerability, and things like this. But again, the future is going to change. And we have new perspectives to treat fibrosis. This is why I approach the fibrosis here, right, as part of the disease. But if in the future there is some immunologic treatments to reduce the lesion, it may be a way for us to be more and more conservative for the treatment of endometriosis.
Yes, thank you very much. Brilliant response. What do you want to say? Do you want to say that it would be immunological treatment? So it's like drugs for malignant diseases. What class of treatments, immunological treatments, where do we look at in the future? What type of immunological treatments? Because you know that the team of our center is very professional. We have great preparation. You visited our center and we are collecting most severe cases from former USSR, from many neighboring countries and even European countries. Mainly these are severe endometriosis, cases of severe endometriosis. What shall we look at in the future? Well, today we understand surgery, yes, it's indicated if there are symptoms, bleeds, obstructions, pains, etc. It's clear, it's very clear. Then we can provide hormonal treatment and agonist gestogens are among this leaves IVF, that's clear. But your view of the person who is visionist, who is dealing with endometriosis all professional life. So what should we look at? What immune treatment? Please be more precise, maybe monoclonal, whatever. Please tell us the secret.
Mauricio.
The secret, yes, the secret, Leila, there are new studies, right, about NQ cells. There are new studies about dendritic cells. But what we have in place, there is a very recent study from a drug that is an antifibrotic drug that I think that one very strong possibility. This is a phase 1 study, right? Anti-interleukin 8. The name of the molecule, I think that's AMY109, something like this. That's for sure. It's part of the perspectives of the treatment of the disease. So for endometriosis, Leila, for me, is like cancer, right? In the past, 40 years ago, we were much more radical for some types of cancer that we are now. And this is how I foresee the future, right? For us to be less and less radical.
That was great pleasure to talk to you, at least online. Thank you very much, dear Mauricio, and hoping seeing you in Europe somewhere in the near future. Thank you very much, and we wish you a very good day. Dear colleagues, and now it's a pleasure to give the floor Alexander Giovanni. This is ultrasound mapping of parametrium and endometriosis of the gut, gynecologists and specialists of ultrasound in the pelvis floor to identify malignant and benign diseases, consultant of Malsoni Center on the pelvis surgery. Brilliant doctor, brilliant assistant, fantastic speaker and great friend, and the wife of Professor Mario Malzoni. Alexandra, mic is yours. But please try to stick to the timing. 20 minutes are yours. You're welcome.
Thank you, Leila. Thank you for your kind invitation. Can you hear me?
Yes, please proceed. Please proceed. We can hear you and we can see you. Please start. Please start. Please start. Please start. Yes, please start. Please start.
Перевод.
Please start. Please start the presentation. Please start the presentation. It's all good. It's all good. Please start. please start the presentation. Alexandra, please start the presentation. Please start.
Yes, I'm connected. Can you hear me?
Please start. Please start. Yes, yes, yes. Oh my God.
So, can you hear me now?
Please start. Please start. Please start. Please start the presentation.
Чего? Техническая поддержка. Пожалуйста, разберитесь в этом вопросе.
Please start the presentation.
Вопрос.
Together the ultrasound mapping of parameter and bowel endometriosis. So we all know that we made giant steps in the diagnostic workup of patients affected by endometriosis. Nowadays, imaging is highly recommended, both in terms of ultrasound and magnetic resonance in order to evaluate patients with a diagnosis of or suspicion of endometriosis. And of course, clinical examination is fundamental, but sometimes not enough in order to assess the extent of the disease. Biomarkers are no longer recommended in order to diagnose endometriosis. And in terms of which is the best option in order to evaluate the patients by imaging, we can choose ultrasound or MRI because the diagnostic accuracy is almost the same according to recent literature data. But the main theme, the main issue is the experience of the operator. So it's a crucial key point in evaluating patients with this kind of disease. There is still some space for diagnostic laparoscopy. It happens when we have a strong clinical suspicion of the disease, but with negative imaging made by expert. And also when we decide to go for surgery in order to be sure about our diagnosis, we should be aware of the need of an expert surgeon performing laparoscopy in order to obtain the best results. So we moved from the so-called diagnostic laparoscopy, see and treat approach to a time in which we can make our diagnosis by imaging, and we also can stage the disease before surgery. In 2016, we had the first multicentric study defining terms and definition for deep infiltrating endometriotic lesion, but still today we will see together we have some troubles with specific anatomic area. Probably the key is to explore systematically those patients and trying any time to provide information that can be relevant for clinical and surgical management. So we have to make any effort to stay in our surgeon mind in order to provide useful information. And another advantage of imaging before surgery is to provide information that can be useful in order to set the surgical strategy, to put together the correct surgical team for specific type of surgery, and also to counsel the patient before surgery about the surgical strategy and program. So when we approach a patient affected by endometriosis, we should be able to explore all those compartments in which endometriosis lesion can be located. So the key is anatomic knowledge of disease, knowledge of pelvic anatomy in order to go for deep infiltrating a lesion. So it can be useful to follow a stepwise systematic approach to different pelvic compartments. Now we will focus on bowel and parametrial area, but we cannot do this without mentioning adhesions. We know that endometriosis in majority of cases can be associated with severe pelvic adhesions, and we can assess them by ultrasound just by performing the so-called sliding sign. When we push with our probe on the posterior vaginal fornix, so behind the cervix, and we observe this kind of movement of the bowel together with the uterus, so we are facing a situation in which we can predict the presence of severe adhesion, because bowel and uterus are completely attached, and in those cases we have high predictive value for the presence of deep infiltrating endo in more than 80% of cases. On the opposite, when we observe a free movement of the uterus, so with the bowel that stays behind the cerebellum, we can assess the so-called positive sliding sign, and in those cases we don't have severe adhesions. But the matter is that we must avoid to identify adhesions with deep infiltrating endo. Adhesions doesn't mean we have infiltrating endo. It simply means that we have a higher probability to face with also with deep infiltrating endometriosis, but we should take always in mind that we can have deep infiltrating retroperitoneal lesion without or with really mild adhesions. Moving to the typical deep infiltrating lesion, we know that we can have lesion in the vaginal fornix, in the rectovaginal septum, and probably those lesions are the most are really easy to detect and identified by pelvic clinical examination. It can be a little bit harder with the bowel lesion, especially when they are located in the upper bowel segment that cannot be reached by hands. How we can, which is the typical ultrasonographic feature of a deep infiltrating bowel nodule. It's an hypoechoic solid lesion with poor vascularization that increases the thickness of the normal muscularis, whose normal thickness is 1.5 to 2 millimeters. So this is the typical appearance of a deep infiltrating bowel nodule. In this case, we also have an infiltration of the submucosa, but we have to take in mind that when we observe an infiltration of inner layers of the bowel wall, it means that it is just the tip of the iceberg, because the most of the disease is in the layer of the muscularis, and sometimes, of course, also at the serosal level. But in that case, we speak about superficial endometriosis. This is also the reason why colonoscopy is not useful in order to detect deep infiltration infiltrating bowel nodules because it's really rare, the infiltration of the inner mucosal layer. So it can be useful in case of patients complaining with bowel bleeding, with the rectal bleeding, but just in order to make a differential diagnosis with the primitive bowel diseases. Of course, by ultrasound, we can measure the nodules in the 3 orthogonal planes. It's our habit to use a curved line in order to provide a measurement that can be absolutely comparable with the fresh specimen diameters. So we can measure length, transversal diameter, percentage of the involved circumference, and last but not least, the anteroposterior diameter, I mean the depth of infiltration, that together with the length is one of the parameters that mostly influence the decision about the type of surgery to perform. And I underline the type of surgery because the decision to perform surgery or not is clinical and is based on the patient's symptoms. So once we decide to go to the OR, we can use information retrieved by imaging in order to evaluate what kind of surgery we want to perform on the bowel between shaving, discoid resection, or segmental resection. And this is also the reason why we should be able to distinguish the component of deep infiltrating endometriosis that is in the bowel from the outer component that is located at the retrocervical level, vaginal level, or rectovaginal septum level. With those criteria, we are able to provide very precise measurement of deep infiltrating nodules. We can also give information about the distance between the tail of the nodule compared to the anal verge. And we should always combine our transvaginal or transrectal where needed, of course, when transvaginal route is not feasible, with a transabdominal approach, because in the majority of cases, a nodule of upper sigmoid or descending colon or the right iliac fossa are better seen by transabdominal approach, like in these cases of involvement of the appendix. Sometimes some nodule of the small bowel can be located down in the pelvis and can be appreciated also by transvaginal ultrasound. Following those criteria, we can reach, as you can see, really high diagnostic accuracy, and we confirmed it also in retrospective and perspective multicentric study concerning the ultrasonographic pre-surgical evaluation of the ANSI score, and more recently by assessing the feasibility of staging preoperatively endometriosis extension according the surgical staging, the AGL surgical staging system. But however, we still have some troubles, especially with retrocervical uterosacral ligament lesion and parameter lesion. This was a study from Professor Guerriero of 2015, but you can see that the situation with parameter lesion more recently is not so different. And probably this low sensitivity, it can be explained by the absence till now of specific terminology. So probably it's a bias derived from inhomogeneous definition. Many authors recently began to write about retrocervical and parametrial lesion, and we also focused in the latest years on this specific pelvic compartment. First of all, because we think that we can see really clearly uterosacral ligament by ultrasound, whose normal feature is that hyperechoic band that runs from the posterior cervical border through the parectal space up to the pelvic sidewall. This is the appearance of the normal healthy uterosacral ligament. When it's affected by deep infiltrating lesion, we can observe the typical solid hypoechoic lesion with poor vascularization and irregular margins. But we also should be aware about the fact that the majority of people, when speak about uterosacral ligament lesion, refer to lesions that are located at the retrocervical border of the cervix. However, we have to consider that uterosacral ligament is this entire band of tissue, and it's far different, especially from surgical and clinical point of view, when we have a small lesion at the level of the retrocervical border or a bigger lesion at the level of the dorsal part of the uterosacral ligament, or when we have lesion that extends beyond the limit of the uterosacral ligament itself. Because according to anatomic criteria of radical hysterectomy, we know that uterosacral ligament is the medial border of the lateral parameter. So we should be, and the uterosacral ligament itself, it's the in its dorsal part is the dorsal parameter. So we should be aware of those anatomic concepts when we evaluate extension of disease in those areas. But why? Because first of all, we can obtain really high diagnostic accuracy in identify those lesions. This is our latest paper of last year, in which we showed a really high sensitivity and specificity on both uterosacral ligament, retrocervical area lesion, and parametral lesion. And then we confirmed it in the above mentioned studies on the ANSIA score. But why it's so important? Because in the parametral area, we have ureters and we have nerves. Concerning ureters, we can explore how close the deep infiltrating lesion is to the ureter. We can observe nodules that are completely in touch with the ureters, and we can observe nodules that embrace completely the envelope, completely the ureter. And of course, in those cases, it's more likely that we have a ureteral impairment. But those are information that we have to give our surgeon, especially in cases we don't have a pelvic surgeon and we need a neurologist in the OR. And concerning dorsal parametral lesion, we have to be aware of the fact that this area is the area in which the majority of neural pelvic fibers run. So you can see here, here we have the pelvic hypogastric plexus. It runs below the level of the uterosacral ligament, below the deep uterine vein, and from ultrasonographic point of view, it corresponds to this area. So we have, of course, a situation in which retrocervical and parametral area are bilaterally involved in case of a really severe endometriosis. This kind of endometriosis can cause lumbar, gluteal, perineal, vulvar, sciatic-like pain, and also altered urinary function. But Professor Konings told us a couple of years ago that endometriosis can cause pain at distance. So we can have a parametral lesion that can cause also sciatic-like pelvic pain, because the effect of the lesion can be observed up to 3 centimeters distance from the nodule itself. We should be aware to distinguish parametral nodules that are located in this area from sciatic-like, from the true sciatic nerve endometriosis that is located more laterally and cranially in the pelvic structure, and it's a completely different disease. But what we can do by ultrasound. Can we see nerves by ultrasound? I'm really pleased to tell you yes. Recently, we had this wonderful paper by Boker and colleagues who showed us how to visualize the sacral nerve roots and sacral plexus by transvaginal ultrasound. We try to do the same, and I can tell you that is completely feasible. We can observe sciatic roots. We can observe all the sacral plexus and sacral roots, one in between the two branches of intericlic vessels, 2 and 3 that are just between the piriformis and obturator muscle. And please see how our dorsal deep infiltrating endometriotic nodule of the uterosacral ligament, how close are to the sciatic root one. But we tried to do more, and we more recently tried to identify, and we managed to do it during surgery. We went in order to identify the hypogastric nerve. I go fast. And I can show you here with the surgical forceps pushing on the axis of the nerve, that is this hypoechoic thin. The thickness is 1 millimeters, 2 millimeters. So we pushed with the forceps very gentle in order to avoid trauma on the nerve, and we identify the nerve just below the peritoneal reflection of the Douglas patch in the dorsal area. So in this way, we are able to identify the hypogastric nerve, the lower hypogastric plexus, and we can provide our surgeon information about those kind of pelvic infiltration from deep infiltrating endos. So probably for sure we have to better assess those techniques. We need a larger and further studies in order to set a systematic approach to the ultrasound evaluation of pelvic nerve, but we are ready to do it because learning never exhausts the mind. So thank you so much, and thank you for your attention.
Dear Alexandra, thank you very much. I am very impressed. Well, that's an alliance between a surgeon and an ultrasound specialist. As you can see, nerve endings, gangliomas in pelvis, well, it's very difficult to detect. Well, I would like to ask you to publish your studies, the results of your studies in our journal. Well, it's the first quartile journal. It would be very interesting for Russian doctors. Thank you very much. And I'm waiting for Mario. Mario is not ready yet, but he's supposed to make a presentation today, and tomorrow he will demonstrate a surgery. Dear colleagues, thank you very much. We have a wonderful conference, and right now, according to the agenda, Professor Wolfgang Kupker and then Anastasia. Anastasia, first Professor Kupker, he is already here, and then you, Anastasia, will speak after Professor Kupker. Thank you both very much. So, dear colleagues, let me say a few words about our audience. Several thousand people are participating in this conference. Adenomyosis and infertility. Does immunologic mapping help? As far as this issue is concerned, Professor Kupker is a professor at the Lübeck Medical University. Professor Wolfgang Kupker, please do not overrun your time. 20 minutes for your presentation. Professor Kupker, please.
You can hear me? You can see me, you can hear me?
Yes, we can see you.
Мы видим.
Yes, we can see you and we can hear you. please. Everything is fine.
Okay, so I start my lecture right now. Good afternoon, ladies and gentlemen. First of all, I'd like to thank the organizing committee, and in particular, Laila Adamian, for inviting me once again to join this wonderful conference online again. That's a pity. So my lecture today just a second. Yes, this is the title. So I want to address and draw your attention to the question if adenomyosis impair the fertility, especially in patients having endometriosis as well. The second question is, does immunology plays a role in adenomyosis? So adenomyosis has come into focus during the last years after being forgotten for long years, but it was very precisely described and characterized by the Vienna pathologist von Rokitansky in the mid-19th century, as well as Thomas Kahn from Baltimore, who did that wonderful papers in the beginning of the 20th century, many years before our John Sampson, published the theory of the pathogenesis of endometriosis. So where we are today, so it's not so difficult to diagnose adenomyosis. You can do it laparoscopically. So adenomyosis is displayed with the smooth and enlarged uterus. You can perform an MRI, and you can see on the right side the enlargement of the junctional zone of the posterior wall of the uterus. You can see some particular patterns and changes during hysteroscopy, but I think it's very easy to perform a vaginal sonography, and you can see the structure of the uterine walls, the enlargement, how big the wall is, the anterior, the posterior. There are a lot of signs directing us to the diagnosis of adenomyosis, in particular the very bizarre vascularization in the Doppler. So let's come to the latest news about the pathogenesis of adenomyosis. So I refer to the latest papers of the Chicago group, Bulun, from this year. So they say that endometriosis and adenomyosis have the same or the similar pathology. So what did they find? That epithelial cells from the inner lining of the uterus invade under activated mutations of the KRAS, the gene, into the myometrium, and in concert with epigenetic abnormalities of the stroma cells, adenomyosis is in development. Maybe this is the pathogenesis of endometriosis at all. So this is the inside-outside theory. But let's stay to the adenomyosis. These epigenetic abnormalities, the KRAS, that means the gene mutations, are guided by abnormal estrogen action via the estrogen receptor beta and the consequence of a deficient progesterone receptor expression. That's something what we know from endometriosis. So there are the similarities. The French group, Bourden and co-worker, they find an elevation of pro-inflammatory and anti-inflammatory cytokines like IL-6, IL-1 beta, IFN alpha, tumor necrosis factor alpha. We all know these substances, as well as IL-10 and TGF-beta. So what we know from endometriosis, and this affects adenomyosis as well, are these facts we have to take into account. And this is the decreased activity of the estrogen receptor alpha and an increased activity of the estrogen receptor beta, with a subsequent loss of the progesterone receptor beta, which leads to a progesterone receptor resistance. The inhibition of the 70-beta hydroxysteroid dehydrogenase 1 and the increased aromatase activity leads to the situation of the permanent estrogen dominance and the imbalance of estrogen and progesterone. And this seems to be the same for the adenomyosis. So what's about immunology? The title of my lecture. So already Peter Medava, the Nobel laureate, he is one of the pioneers of transplant medicine, asked the question that makes sense. How does the pregnant mother contrive to nourish with itself and many weeks or months is fetus that is antigenically a foreign body? So what's going on in the endometrium? And this is the important compartment of implantation, the endometrium. The predominant cells are the NK cells and the T cells. And I draw my attention to these subgroups and how we can detect them in the endometrium and what they exhibit any action towards or against the implantation. So we have different types. For example, on the one hand, the natural killer cells, they differ in their cytotoxicity. 80% of the uterine natural killer cells have a low toxicity and a high cytokine production. And this is of utmost importance. On the other hand, the peripheral NK cells have a high cytotoxicity and a low cytokine production. This is a different system. So on the one hand, we have the blood circulation and the immune system. And then on the other hand, we have the compartment of the uterus, which means the endometrium itself. If both cell types are elevated, that leads obviously to miscarriage, hypertension, preeclampsia, and fetal growth restriction. Let's go a little bit more into detail of the immune physiology in implantation. So the uterine NK cells, they participate in some important events of implantation. This is the tissue and vascular remodeling. It supports the trophoblast invasion. It attracts the trophoblasts. And in addition, the spiral arteries are remodeled. Furthermore, they guarantee immune tolerance with their low cytotoxicity. Then we have the T cells. Most important are the T1 and the T2 T cells and the T regulator cells. The T cells are responsible for the immune tolerance, in particular the T2 cells. And so we have on the one hand the pro-inflammatory and on the other hand the balance of anti-inflammatory events, the T1, T2 cells. This guarantees, if this is balanced, then immune tolerance, which means at last implantation can occur. In addition, myeloid cells participate as well in the tissue and vascular remodeling. Especially they are responsible for the vascular maturation, and they are also responsible for the tolerance and the inflammatory balance. So how do we measure these events? We take biopsy from the endometrium in the mid-luteal phase, the day when embryo transfer should be done. So first, the endometrial receptivity mapping. So we analyze 48 genes, and we can confirm the receptivity for a special day. And 70% of all women do have the receptivity on day 5, 30% on another day. They are then pre or post receptive. This is one thing. But I will focus on the homology and how do we test the concert of these subgroups of T cells when we perform this using a flow cytometry. These are the results, for example, in one of our patients, but it's quite interesting. So what is interesting? 3 events, the number of the total NK cells, the number of the cytotoxic endometrial NK cells, then, as told before, the balance of T1, T2 cells. And here we have a pathology. So this is unbalanced. We have more T1 cells and less T2 cells. And this ended up in a T17 track ratio, which is also out of range. That can be treated with special medication I'm going to show you. Moreover, what we are doing is looking for the compatibility of the partners of the embryo and the mother's part, testing the KIR genes and the HLA system. Most of the groups perform immunostaining of endometrial tissue to look for the distribution of the uterine NK cells. You can measure them, how many NK cells are there. We don't do this, but this is another possibility to look for the uterine NK cells, but you don't know if these are what you see, cytotoxic NK cell or the good guys, if you may say so. Of utmost importance, progesterone. So what is happening? The trophoblast is recognized by the serial T cells, and the T cells are activated and express progesterone receptors. Progesterone binds and the genes are activated. And what comes now is very important and crucial event is the secretion of progesterone-induced blocking factor. And this factor not only detected in the endometrium, but also in the circulation, but this substance contributes to the dominance of T2 cells, which is important for the cytokine balance. Moreover, the substance PIBF reduces the activity of the bad guys, the cytotoxic natural killer cells. What is this? Just have a quick look at our ancestors, the Neanderthal. Why do I mention these people? Because the group of Seeberg from the Max Planck Institute in Leipzig, and they got a Nobel Prize for that. They investigated the progesterone receptors in Neanderthal specimens, and they could show us that they have a high expression of progesterone receptors, and obviously Neanderthal people do not encounter miscarriages, implantation failure, if you may say so, or preeclampsia. Moreover, they took a look into the gene bank of Great Britain. Among 250,000 women, they looked for the Neanderthal-derived variant carriers. And a third of these women, they do carry this variant, and these women actually show an increased fertility. So that may say us that the progesterone and the progesterone receptor is of utmost importance in the immune process of implantation. So what can we do? How we have a lot of immuno agents that could be used for treatment of a special immune situation in the endometrium, but you don't have to read that. So what are we doing? So first of all, avoid too much uterine NK cells with a high toxicity. And on the other hand, to balance the T1, T2 system as mentioned before. So immunotherapy, what are we clinically doing? So what we know, corticoids bind to NK cells and decrease the T1 cytokines. They modulate the T1, T2 balance. All know intralipid reduces the uterine NK cells and their activity. And some other substances we use is, for example, tacrolimus. This inhibits the IL-3, TNF-alpha, interferon gamma expression in T cells, especially to modulate the T1, T2 balance as well, and that functions very good. Hydrochloroquine and TNF-alpha blocker inhibit toxic cytokine secretion. So we have some agents we could use for treatment of such findings in the endometrium. So, but makes that sense? Is the endometrial immune profile analysis in patients with adenomyosis really useful or not? And so we did about 500 biopsy, and I'm just beginning with my PhD student to characterize all these patients having undergone these biopsies. These are the first preliminary data. So 50 patients with clear adenomyosis, and we found in 74% an immune dysregulation. And then we did an embryo transfer in the IVF system. We did an embryo transfer using some of these agents, these immunoactive agents, and I was amazed. I couldn't believe, but there was a pregnancy rate of 51%, and you have to take into account that these women have a long history of IVF, of sometimes surgical interventions, sometimes not, but a long journey, 5, 6, 7, 8 years, and then I think a wonderful data. So I hope we can rely on these data if we analyze more of our specimens and of the biopsies. So to put it in a nutshell, I come to my summary. So what, in my view, as a clinician, is important in treating endometriosis and adenomyosis is first things first. This precision surgery is, in my opinion, of utmost importance. Second, hormonal balancing with special regard to the action of progesterone. So if we are in the IVF system, we need good quality embryos. So that's a precondition. This is necessary. We can perform immunotherapy with good results. So what may come in future? I hope for a causal therapy using stem cells, endometrial stem cells, but as far as I know, and I talked to these colleagues who are working on this, we are not far enough to implement this into a clinical routine, but that will come in my view. Thank you for your attention. Thank you for your patience. Best regards from my hometown Baden-Baden, where I'm now. Hope to see you all face to face sometime, maybe next year. Stay well. Thank you.
Dear Wolfgang, dear Professor Kupker, once again, we've known each other for a long time. We've been dealing with issues of endometriosis for a long time, and your today's presentation is bringing us back to the past, to Neanderthal man, but on the other hand, it gives us promising opportunities in the future. Could you tell me, please, judging by what we're having today, in all these methods of treatment, methods of therapy, surgery, histogens, progestins, agonists, immunotherapy, well, it's quite obvious that we must look towards immunity, because in any case, this may be violation of autoimmune aspects, maybe embryonic aspects, but what does the future hold us, near future? Well, endometrial stem cells can be used, maybe cortisol, etc. What is your view as a practical clinician? What is going to happen in the next 10 years to treat adenomyosis? Well, of course, if surgery is indicated, if there are symptoms, it's one thing. If we know adenomyosis exists, but how can we help the patient to restore their reproductive function in the near future? What can we do for this? Wolfgang, please answer this question, because you know everything, please.
Thank you for this wonderful question. So it's not so easy to answer what may come in future. So I think on the one hand, so we are all, as far as I know, relatively good surgeons. And I think you change the immune system doing best precision surgery. Many women do get pregnant spontaneously after a adequate surgical intervention. This is first step. The second, is IVF. IVF is an opportunity since many years. Immunotherapy is helpful, is interesting, but it's not causal and not radical. So I think with a particular regard to adenomyosis, I think this is my hope, and I'm trying to go on with these things to use endometrial stem cells, to inject them into the niches of the junctional zone, if you may say. So that's a hope. It's a hope for the future. So I think that would be a very elegant kind of therapy to stop the further development of adenomyosis. I think adenomyosis is nothing to operate on, despite the fact that you can do very artistic things like our friend Osada, for example. But I think adenomyosis, and maybe endometriosis itself, can be cured using stem cells. That's a hope.
Well, Wolfgang, I know that you are a wonderful endocrinologist, and as of today, there are some endocrine drugs. I'm not going to mention brand names. These are agonists, progestins, histogens, and among them Dynagest, DDG. And today, if you're operating on a patient and you need to prepare the patient for the pregnancy, what would you prefer? What drug would you prefer to prepare the patient for pregnancy? We're also using such medicines. Well, and I don't need to disclose the conflict of interest as far as different drugs are concerned, but how do we prepare the patients for pregnancy after our surgeries?
So that's an interesting question. So far, that now it comes to the GnRH antagonists, which I'm working on since 20 years. Now we have oral antagonists available, and I think we could prepare the patients before another transfer with a GnRH antagonist therapy for maybe 4 or 6 weeks after surgery. So I would wait. I wouldn't give my patients nothing. So just try to conceive spontaneously within maybe half a year. Depends on the age of the patients, of course. So after surgery, I wouldn't do anything, but preparing the patients for a better transfer, maybe, I would use a GnRH antagonist, not an agonist. This is old stuff. I would I would use an antagonist.
Thank you very much again. It's always a pleasure to talk to you. And I would like to see you in person anywhere, somewhere. Thank you very much. Well, dear colleagues, Anastasia Usier is our next presenter. My dear Anastasia, she is my Italian sister, as I call her. She has been with us all my life. We've operated together in Italy, in Avellino, in Crotone, in 1991 for the first time with Harry Rich, as far as I remember. She is our friend. She likes us, our country, our center, our director, all my staff. Dear Anastasia, how should endometriosis be treated in adolescence? She is the president of the Association of Gynecology in the Villa del Rosario Hospital, Rome, Italy. Anastasia, the floor is yours.
Thank you, Leila, for these beautiful words. I know you are really my sister. I am always with you, and I have to say that I learned a lot from you. You are my mito. Okay, I'm going to talk about what we should do in endometriosis in the adolescents. Let me see if the video is going to be. Can you see the video?
Yes, but they are small. Can you go full screen?
Is full screen now? Is okay?
Yes, now they're full screen.
Is okay now?
Yes, you are full screen. Go ahead. You are full screen. You are full screen.
Great.
Thank you. Everything is all right. You are full screen. Go ahead.
Perfect. What we know, endometriosis in the adolescents, it's really today a challenge for gynecologists and for experts, and also dilemma. In the still as controversy remain regarding incidence in the younger, how is the pathogenesis, the real pathogenesis, the natural history, and the optimal treatment. In my lecture, I'm going to describe this pathology to just to give an idea of the mechanism of the dysmenorrhea and the pain in the adolescents, the hypothesis of pathogenesis, about the importance of early diagnosis and the optimal treatment today, and also the preliminary result of Strasbourg consensus we did in September concerning adolescents. We know that in adult endometriosis, in the adult, affect 15% of people, women in reproductive age, and 70% of women with chronic pelvic pain has endometriosis. And then 20% cystic, 10% deep if there is severe pain. But what is important is the 66% of adult women with endometriosis report onset of symptom before the age of 20. It means that start very, very young. And adolescents that go undergoing laparoscopy for chronic pelvic pain have an endometriosis rate reported in the literature that go since 19% up to 75%. Okay, why don't go? No. If you see these slides, you can see that the age that starts the endometriosis symptom are very early in the age. Between the 46% is between 2029, 18% 10-20. It means that 64% of women with endometriosis start to have endometriosis before the age of 30. Endometriosis affects women during the prime years. When we go to the literature, we find this publication from many experts. We find that the stage third and the stage fourth from American Fertility Society, the stage second and third are prevalent in women in adolescent. It means that the severe endometriosis is less in the young, but most of them as a second stage and third stage, like you see in these slides. The recurrence also, when we go to have a good look in the literature, we say that more younger are the girl, more higher is the recurrence rate. And we have Adalbert says that there is a 50% recurrence and new localization, 34% of recurrence of pain after surgery, and only 23% of resolution. It means that more younger start, more high incidence of recurrence. The difference between the aspect of the endometriosis in the adolescent and in the adult is that in the symptom, first, the adolescent has more severe dysmenorrhea, and the adult have moderate dysmenorrhea. At laparoscopy, we find 77% of the early stage, first, second, and only 32% of more severe stage. In the adult, we find more severe stage third and fourth. And also in the peritoneal, we have minimal fibrosis in the young with the vascular implants, more vascularization, and black intraperitoneal implants and more fibrosis in the adult. For the ovary, we have more endometrioma with adhesions and also little deep. In adult, more deep endometriosis. Also in the cystoscopy, when there is a localization in the bladder, we have more neoandrogenous inflammation and in the young. And for concomitant pathology in the young, was often associated with the other Mullerian anomalies and the bladder involvement and adenomyosis. Which is a publication from Brose and Gortz a few years ago that says that endometriosis in adolescents is a hidden, progressive, and severe disease that deserves attention, not just compassion. What they want to say is that this lesion that starts in the young should be detected very early and treated very early, since they can develop, and we don't know how lesion can develop in more severe lesion and involve and become a really severe disease, and we don't know what have a spontaneous regression and stay there without any progression. For this reason, it's very important the early diagnosis. For the pathogenesis, I like to see these slides from Philip Koenig's. That is the hypothesis is what we know, that the original cell can be endometrium, neonatal cell, embryological stem cell, and the subdeletion is not a pathology. All women has the subdeletion, but only in few women, in some women, that for many genetic, epigenetic change, because of predisposition, because some insult like inflammation and other disease, immunology problem, and oxidative stress can develop the disease and have a progression to typical lesion, cystic ovarian lesion, deep lesion, and other lesion. It means that endometriosis, subtle lesions are not a disease, but in some women that we should understand which girls can develop this kind of disease, because subtle lesions are present in all the women. When we see about neonatal uterine bleeding, say that there is more incidence risk of endometriosis in the girl that had the neonatal uterine bleeding. In the literature, they find that 4-7% from Levy and 5%, but also if you do the occult HB test, you can find in 61% of women, of girls, as neonatal uterine bleeding. And we know that neonatal uterine bleeding increase incidence in preeclampsia, in post-maturity, with blood incompatibility, with low birth weight. How is this mechanism? We don't know. Maybe the intrauterine hypoxia can accelerate the maturation of a fetal endometrium, and there's this a predisposition to develop in the future endometriosis. We should take care of the girl that the mother has a preeclampsia, the girl that with low birth weight, that the girl that had neonatal uterine bleeding. First conclusion for pathophysiology: the endometriotic disease theory can explain all observations on endometriosis. In addition, the hereditary predisposition in the mother can explain the association of endometriosis with less physiologic change and preeclampsia and low weight of gestational age, and also the early onset before the menarche signals that hereditary trait or predispositions play an important role in the history of the disease. When we see growth endometriosis in the adolescents, we don't have solid data, but between the onset of the disease and the adult endometriosis must occur a growth. And this is very heterogenic, suggests, because in most women, the growth is self-limiting. They have just a disease that stay there for all the rest of the life, is typical and maybe never go deep or go worse. And some typical and deep are no longer progressive when we make a diagnosis, and this mechanism, we don't know why. In some women, progression seems continuous and going worse and gross. And in some women, progression also, even during pregnancy, even during oral contraception. In other women, we don't see any progression during hormonal therapy. Even with the pain, is a variability. The many women with deep endo report pain since after few years the menarche, and the pain increase progressively over the time. In some women, there is no pain in the beginning, but just before can and be worse since the beginning and get worse. For infertility, we don't have data in adolescents, and we don't know real if there is some relationship. How can we prevent in a young girl, adolescent girl with pain that we suspect endometriosis? How can we prevent that develop a severe disease? We have to pay attention to the girl that had early menarche, pay attention to the girl with dysfunctional bleeding, with a recurrent infection, vaginitis, with the bowel inflammatory disease, because the bowel inflammatory disease changed the intestinal microbiome that play an important role in the development of the disease. And what is the problem? With young girl with pain, with severe pain, dysmenorrhea is what we should do. We should avoid laparoscopic or surgery in order to avoid repeat surgery, since in addition, endovarian damage, because we see that the recurrence is very high, and therefore give medical treatment as long as clinical possible, but with the risk. Take into account the risk that the disease can grow and become worse, or we can do an early diagnosis with laparoscopy and surgery to avoid the progression and to prevent infertility, but with the risk of repeat surgery and the risk of damage of the ovary and to make an adhesion, this is the dilemma. Who has an answer about this? We have clinical options. We have to consider that, first, only laparoscopy can diagnose superficial endometriosis, and the diagnostic absence of data about diagnostic accuracy of clinical exam, of ultrasound, especially for pubertal time, is very difficult to do, except for ovarian cyst. For all the rest is very difficult. And also the absence of data that medical treatment can prevent the progression in all women. Maybe in some women, but not in all women. The first rule is we should do a diagnostic laparoscopy, maybe less invasive with the transvaginal laparoscopy, coldoscopy, before starting the treatment and before to put the patient in oral contraception. Or second rule, after the diagnosis, we can consider the treatment options and or completed surgery or postpone the surgery or follow the patient with medical therapy. But which evidence we have for each options? No one. Only experience of surgery. Pro-surgery is medical therapy is that to avoid the surgery, you can avoid complication, you can avoid ovarian damage, you can avoid repetitive surgery. Contra, no data that medical therapy prevents progression in all women, and maybe at the age of 30, we find a woman that need a ball resection or that need a very, very difficult, extensive surgery. And no data that medical therapy prevents ovarian damage. We don't know if the ovarian cyst maybe stay there and damage the ovary, as even if you remove, maybe the damage is less if you remove in the right way with the expert surgeon. Considering little evidence available, medical therapy is most based on the assumption theory, because if you consider endometriosis progressive and recurrent by definition, and you consider subdeletion important, give medical therapy for the rest of the life, even if the patient in 30 can develop a severe bile disease. But we believe in the endometriotic disease therapy. Endometriosis is heterogeneous. Subtleties are not pathology. We should make a decision human by human. Personalize the therapy. Is not, we cannot say we have to do this in the adolescent. We have to take difference, depend on the history of the patient, the family history, the symptom, the age, and also the desire of the patient. For the surgery, pro-surgery, there is that the recurrence rate of deep endometriosis after excision is rare, 1%, of cystic ovarian reported in the literature is by 5 to 20%. Contra is the ovarian damage, the adhesion formation, and also the risk of infertility because adhesion. Practical conclusion in this first, diagnostic laparoscopy, when we should do. A surgery during laparoscopy, if it is available, yes, for this reason, this patient has to be treated from expert in endometriosis, expert in pelvic surgery. After surgery, could be wise to give medical therapy to prevent recurrence of cystic ovaries, but even not mandatory. If too much side effects, we can follow the patient without any therapy. What we see in the young, this is early endometriosis, is characterized by neoendogenesis, is more red lesion, more ovarian endometriomy, more adhesion formation. In this publication, in this paper, they say that the fluid from endometrioma from older patients also contain significantly higher concentration of total bilirubin, ferritin, free iron, that when compared to young women. It means to support the data that the changing nature of endometriomy with age reflects the impact of repeated and continuous injury and repair in the ovary that results in the adult in larger fibrotic, not progressive lesion, but become resistant to hormonal treatment. It means that also the endometrioma, after many years of treatment, can be resistant. Concerning the ovarian reserve and possibility of the misuse of ovarian reserve, this publication for Kitania is endometriosis, this formation and associated alteration, fibrosis, in apparently normal ovarian cortex can reduce ovarian reserve. Even an early diagnosis intervention could be beneficial in women with endometriotic to protect the ovarian function, especially with cyst less than 4 centimeters. With transvaginal, we can do and we can detect a small endometrioma and also treat it. And maybe we can make a distinction between the small endometrioma with a good prognosis and one endometrioma that continues to develop and to destroy the ovary. What we do with surgery when you have an endometrioma, especially in young, is the maximal preservation of a healthy ovarian tissue. For this reason, has to be the judgment what to do: to remove completely the endometrioma, to do only drained endometrioma and laser vaporization, hybrid technique, to do two-step surgery, has to be decided case by case. Surgery of ovary in the adolescent is a double-edged sword in adolescent. Increased risk of premature failure should be minimally invasive and is being performed by skilled surgeon. This is also a technique, a diagnostic, not invasive diagnostic technique, the TVL, offering the way of diagnosis and start an early treatment. What says Einstein, learning is experience. Everything also is just information. And experience is more important to drive you into the right way to treat the young girl. We don't have animal model, no experimentation, no invasive diagnosis. Knowledge is limited to symptomatic women, and no blinding therapy, since if you do a blind therapy, the patient has no menstruation, immediately understand is doing a therapy. The effect of medical therapy, also, you have to consider the placebo effect. And randomized control time in surgery is not realistic. For this reason, when we did the consensus on management in Strasbourg, we all have a personal consensus how to manage. Each patient is an experiment controlled by outcome. We learn from experience of the others and update our management daily, weekly, which is not a personal opinion, this is what Philip says, let's teach it last, a Bayesian approach. Not need to agree on everything. Important is that it works for you in your place. Our collective experience is the best evidence we have. This was the conclusion of the Strasbourg consensus in the adolescent, when with hereditary should be informed about potential prevention. Everybody, most they say yes. All vaginitis should be treated adequately, yes, of course. The majority say yes. Adolescents with dysmenorrhea deserve ultrasound investigation, and if negative, and trial therapy with continuous estrogen, 85% yes. During medical treatment, some 10-30% endometriosis lesion progression is important, a yearly follow-up by imaging. That's 80% is agree with this. It means that you give the oral contraception, but the patient, the girl, is to be followed year by year. Adolescents, after 3 months of medical therapy for pain, only 22% is agreed to do a laparoscopy. I think at least minimal is to stay 6 months, 9 months, and no effective therapy maybe is take consideration to do a laparoscopy. And that you think can grow significantly during medical therapy, 29% say no. And a delayed diagnosis of more than 5 years results in more severe endometriosis lesion. 64% say yes, they believe this. Also, the ESHRE guidelines for endometriosis and treatment don't respond to clinical medical therapy, should be after medical therapy 6 months, you should indication to look for endometriosis with laparoscopy. To summarize, we do in a young girl with severe pain and dysmenorrhea, especially transvaginal ultrasound and clinical examination. If it's normal, we do hormonal medication and is effective. We follow up the patient every year. Is not effective, we should, after 6-9 months, we should think to do a transvaginal laparoscopy or a laparoscopy. If it's abnormal and we have an ovarian endometrioma, we start hormonal medical therapy and to check if it's effective or not effective. If there is deep endometriosis, severe endometriosis, even are young, and is positive for deep, it's better to do laparoscopy and do a surgery. Endometriosis, we know, conclusion, at some point can be a progressive disease, and we don't have markers to predict progressivity. And the prevalence and severity of stage increase with the age. The goals of the early diagnosis is important. Our goals is to decrease the morbidity, to limit disease progression, to reduce the risk of infertility. And the clinical management of endometriosis in the adolescent should be based upon our observations, our understanding of pathophysiology and the natural history. Some theories are obsolete. Maybe endometriosis is a polygenetic disease, and the progression, we should focus on prevention of incident. Avoid infection, avoid pollution, and oxidative stress. Early diagnosis and early treatment can prevent the progression of the disease, can improve the quality of life of this young girl. And early treatment can prevent future infertility. And the major problem of surgery, because we don't know, is the absence of quality control. We should focalize to do a surgery with the quality control to know is it effective or not effective. Thank you for listening.
Dear Lucia, Professor Lucia, that's great, sounds great. We are saying that the most important we have to do all together with us, distinguished colleagues, we should not ignore dysmenorrhea. We should not ignore pain, because unfortunately in children and in adolescents, it could be very early endometriosis. But then the selection of treatment or laparoscopy, well, depends definitely from the clinical situation, whether it's cyst or not, type of pain, etc., etc. The most important is not to ignore. The most important is to pay attention to that. Thank you very much, my dearest Anastasia, for very, very deep analysis. Distinguished colleagues, and now we are happy to give the floor to our fantastic Daniela Luciana. Then we will deserve a short break, and then Professor Mario Malzoni, and then Sinan Jrat, and other colleagues, Andrea Sebert and Dr. Zefirova. Daniela, microphone is yours. You are welcome. Sima, good afternoon. Good afternoon. Daniela, please, you are welcome. Daniela Lucia, the role of modern ultrasound. Yes, we can hear you very clear. We can hear you very clear. Please start.
Okay. So thank you, Dr. Damian, for this opportunity to speak about modern ultrasound for preoperative planning. I am an associate professor of obstetrics and gynecology at the University of Connecticut. I have no financial disclosures. However, I am part of the endometriosis working group, which is a political group run by one of our representatives working to pass legislature to increase research and awareness for endometriosis in Connecticut. The goals of this lecture today are to compile and synthesize the literature and some of the talks that we had this morning on preoperative diagnosis for endometriosis. So put it all together into one kind of summary. And through that, look at our classification and staging systems to decide which systems work best to help us diagnose endometriosis prior to surgery and how they match surgical findings. And then finally, to make a surgical plan, or how I make my surgical plan here in Connecticut. So we'll start with the who, the why, and the how of ultrasound for endometriosis. So as we've talked about today, who should get an ultrasound or an MRI for endometriosis? It's every patient who has pelvic pain, who has abnormal bleeding, who has infertility, who has dysmenorrhea, and who should do the ultrasound, either a specialized GYN ultrasonographer or the surgeon or both. And I think this is an argument in and of itself, but I do think that it is important for the surgeon to be involved in the ultrasound, if not doing the ultrasound themselves, to really pay attention to the pictures and to be involved in the radiologic diagnosis. Why should we do an ultrasound? So this is actually one of my favorite quotes whenever I talk about ultrasound. I quote Dr. Lockwood, who is a high-risk or maternal fetal medicine doctor here in the US, and he says, "How long did it take a physician to stop listening to a patient's heart with their ear on their chest wall after René Laennec invented the stethoscope? Yet here we are still performing this relatively crude bimanual exam when we can carefully assess the anatomy with ultrasound with astonishing clarity, regardless of the patient's body habitus." So in other words, we should be doing an ultrasound because our bimanual exams are not perfect, and we have it, and it is clear, and it is very good at diagnosing endometriosis, as we have heard all morning. Why also should we do ultrasounds? Well, I say this to my patients and to my fellows and residents all the time. I love surprises when it comes to parties and presents, but I'm not a big fan of surprises in the operating room. I want to have the right tools available. I want to have the appropriate consults or assistance, and I want to be able to give my patients reasonable postoperative expectations. And the way to give a patient reasonable postoperative expectations is to have an idea of what you're getting yourself into before you get into the operating room. That way you can talk to them about fertility potential after surgery. You can talk to them about whether or not you can or want to do a complete resection. And you can talk to them about recurrence risk if you choose not to do a complete resection, or if they want to be on medical management afterwards, or they want to get pregnant afterwards. So I really think the why is pretty clear. So the how, we have talked a lot about that today. So we're going to talk about kind of how I do it, trying to combine everything that I have learned at all my ultrasound courses and listening to these outstanding surgeons and ultrasonographers today. So I do follow the 4-step ultrasound that the IDEA group described in 2016. And the first step is that I evaluate the uterus for adenomyosis and the ovaries for endometriomas. And I also use the ultrasound to note specific tender spots on exam for evaluation. So, sometimes, especially in patients who are heavier and have a larger body habitus, it's difficult to really get a good exam and to feel the uterosacral ligaments. Sometimes it's also difficult because there's a lot of guarding in patients who have a lot of pain and discomfort with pelvic exams. They make their muscles really tight, and it's very difficult to evaluate. So using the ultrasound probe to note these specific tender spots sometimes can make it a little bit easier. Also makes it easier to help diagnose or look for what might be causing some of their discomfort. So as we talked about, you can definitely see adenomyosis by ultrasound. There are both indirect and direct signs of adenomyosis, indirect being myometrial asymmetry and hyperechoic striations and heterogeneous myometrium. And then there's also direct signs like myometrial cystic lesions or thickening and infiltration of the junctional zone. And we know that these signs are all consistent with adenomyosis because we've done targeted biopsies and we've compared them to histologies with sensitivities as high as 80 to 90%. We also look at the posterior cul-de-sac by evaluating the sliding sign by putting pressure on the cervix and moving the anterior rectum. We also look at the anterior cul-de-sac and bladder and uterosacral ligaments, looking for nodules as well. The posterior and the anterior slide tests are able to predict anterior and posterior cul-de-sac adhesions with a sensitivity of 86 to 96%. And why do we care about this? Because posterior cul-de-sac obliteration was detected 94% of the time and was associated with a threefold increased risk of bowel endometriosis or need for bowel surgery. So you can see the ovary stuck to the back of the uterus, or when things move a little bit more smoothly. Another test that I do that looks at adhesions, and sometimes I'll do this in patients who have multiple previous surgeries, especially midline surgeries, is I will look to see about adhesions in the abdominal wall. And this is kind of a fun and easy test to do to look for adhesions under the umbilicus. And you can see the arrow here is pointing to the umbilicus with gel in it. And then what you do is have the patient take a deep breath, and you can watch how the bowel moves underneath the umbilicus there. And the office visceral slide test had a sensitivity of about 83.3% and specificity of about 100% with a diagnostic accuracy of 98.6%. So this is a nice, easy test if you're concerned about umbilical adhesions. So deeply infiltrating endometriosis, as we've talked about, you can see direct observations like endometriomas, deep nodules on the bladder or bowel or rectal vaginal space. Or you can also have indirect findings of deeply infiltrating endometriosis like a fixed uterus or kissing ovaries or posterior ovarian location, ovarian immobility. Adenomyosis can be an indirect sign or suggestion of deeply infiltrating endometriosis, and as well as large hydrosalpinx. We know that the most common place to find deeply infiltrating endometriosis is in the uterosacral ligament and rectum. And when you add the sliding sign, you can increase your sensitivity for finding that about 68%. When you see signs of adenomyosis, you want to consider the possibility of concomitant endometriosis, as we talked about, especially DIE. And especially posterior, looking for posterior adenomyosis with posterior cul-de-sac obliteration, and bladder endometriosis being associated with anterior adenomyosis. So we look at all these different ways of seeing endometriosis by ultrasound, and then we have all of these staging classification indexes, complexity scores, and what are all of these for, and how can we use them to have a good conversation with our patients? Because I think for me, the most important part about preoperative planning with ultrasound is having as much information as I can to speak to my patient prior to surgery, prior to before she goes to sleep, and as part of her consent process, what our plans are for the operating room. And so I'm going to briefly go through some of these staging and classification systems and talk about how they can be used and whether or not they are relevant, not only for determining what we're going to see in the operating room, but also for our discussions with our patients. So can ultrasound detect ASRM surgical staging? So we know that the ASRM surgical staging, or the staging system, is actually a surgical staging system. And although we know it's not associated with pain, there has been some suggestion, and it was designed to be associated with fertility. So Dr. Leonardi did a study trying to see if he could stage patients by ultrasound and have the same ASRM stage by ultrasound as he did when he got to the operating room. So he took a total of 204 consecutive patients and did a transvaginal ultrasound on them, followed by a laparoscopy. And when he split them by stage, ultrasound had a better diagnosis at stage 3 and 4 disease with an 89 to 93% accuracy than with stage 0, 1, and 2, which was only about 53 to 93%. But when he dichotomized it, he to advanced stage disease, stage 3 or 4 versus early stage disease, 0, 1, and 2, he was able to increase his accuracy by 9 to 94.1%. And then when he added plus DIE, to 94.6%. And so what was the purpose or conclusion of his study? That ultrasound can be a useful tool to appropriately triage patients preoperatively to centers of expertise for advanced stage disease. And I think we've talked a lot about that today, the importance of these patients getting the right surgery the first time. And I think that's one of the keys to using these staging systems or classification systems. So The NCN system is actually not a staging system, it's a classification system, and it can be used with ultrasound, MRI, and laparoscopy, and it's used to describe the amount of disease and location of the disease by looking at each organ and compartment, and then its severity and its extent. So NCN with transvaginal ultrasound followed by laparoscopy has shown to be the most effective in compartment A, which is the rectovaginal space, vagina and rectocervical space, as well as the rectum, especially when using categorized matches. So in other words, yes or no that the disease is present, and especially in lesions greater than 3 centimeters. It has not been found to be as accurate for compartment B, which is the uterosacral ligaments, cardinal ligaments, and pelvic sidewall. And this was touched upon by Alessandra earlier in her lecture. And some of that is related to nomenclature, and some of that is also related to the expertise needed to really get a good look at those ligaments and pelvic sidewall. And that goes to, like other systems, using the NCN system for transvaginal ultrasound requires highly skilled ultrasonographers. But it can be used as a triage for severe disease. And so I think using this system can, again, prepare patients or recommend for patients to go to centers of excellence. Another staging system is the AAGL 2021 endometriosis classification system. This is as well, it has stages. However, it is not considered the same as the stages for ASRM because the idea is that it's anatomy-based and it's more of a surgical complexity score. So this is not to try to describe pain or to describe fertility function. It's actually to describe how difficult the surgery might be. So again, a study was done looking at comparing the AAGL classification by laparoscopy and then by transvaginal ultrasound, and you can see that it was the most effective when there was no endometriosis by laparoscopy and by ultrasound, and then in the higher stage disease and stage 4 disease by both ultrasound and by laparoscopy. And the conclusion of this study, like the others, have been that ultrasound scoring can distinguish advanced stages of disease and complex surgical cases. So again, the classification system was to determine how complex these surgical cases may be, and again, to help patients be recommended for centers of excellence in treatment of endometriosis. So the classification systems we've talked about so far, or staging systems that we've talked about so far, have talked really about the complexity of the surgery and really about where the patients need to have their surgery done so that the right surgery can be done. So this is a great thing to use when trying to determine who should be doing the surgeries and how difficult the surgeries may be. And going back to what we talked about before, trying to minimize the number of surprises that you see in the operating room, and also to make sure that you have the right tools and consultants available for you for your cases. The next couple staging systems we're going to talk about are more about what other things to expect when you are in the operating room. So there's also a adenomyosis staging system, and this is looking at extent of adenomyosis. And this is important because, as we've heard today, and as we know, adenomyosis is not only associated with symptoms, dysmenorrhea and pelvic pain and menorrhagia and menomenorrhagia, but it's also associated with infertility. And it is important to be able to diagnose adenomyosis, and especially focal lesions of adenomyosis, so that they can be removed or considered to be removed to hopefully improve both heavy menses, but also possibly infertility and perhaps medical management in preparation for fertility treatments, as we've talked about in patients with low AMH levels who maybe may not be the right patient to take to the operating room right away. Should we consider doing cryopreservation of embryos or eggs prior to surgery, and then doing surgery, and then perhaps Lupron and then IVF? These are all things that are easier conversations when you know what you see in terms of adenomyosis. And then the endometriosis fertility index which is a surgical scoring system. So this isn't to be used with ultrasound, but this is important because this scoring system is designed to determine fertility potential based on surgical findings, and it's to identify patients that might benefit from ART after surgery, and it has been validated and reproducible. So this is something that we can use in the operating room to help us to appreciate what to expect and whether or not to consider having these patients do fertility treatments either before or after surgery or both, depending on what makes the most sense. So for example, cryopreservation, like we talked about. So I hopefully summarized some of the stuff that we talked about today. Everybody did such beautiful talks with lots of details about how to actually see all these things by ultrasound. I'm going to talk a little bit now about how I make a surgical plan and how I talk to my patients. One of the other things that I hear about every time I go to an endometriosis conference is about how we do not have a cure for endometriosis and how our research and our data is not perfect. And so I tell this to my patients all the time when I sit down with them to talk about surgical planning or medical planning, is that we don't have a cure for endometriosis. And so what we do is we talk about all of our options and we talk about what makes sense and what side effects are worse or better. And the only way to have a conversation like that is to have all the information you need before you sit down and have that conversation. So the first thing I do when I see a patient is I get her history and I do her ultrasound and exam. And then sometimes I consider an MRI. So unlike Alessandra, I am by far not an advanced ultrasonographer. And unfortunately, I also don't have within my hospital advanced ultrasonographers. So when I think a patient may have DIE or I see something by ultrasound that is concerning for possible rectal involvement or ureteral involvement, I will get an MRI, and I have an MRI specialist at my hospital who looks at endometriosis. And also, if I'm concerned about thoracic endometriosis, another reason to consider doing an MRI. And then once I have the MRI and the ultrasound and the exam, then once a month, we have what's called benign tumor board. And at benign tumor board, we have colorectal surgery, we have urology, sometimes we have thoracic surgery, and then we have our MRI specialists and our radiology specialists, and sometimes also our fertility specialists. And we talk about all of these cases. And we look at the imaging and we talk about what types of surgery we could offer these patients, all the way from the most radical or the most complete surgeries and resections to the less complete surgeries, but perhaps more fertility sparing surgeries. And I find these meetings not only to be an incredible learning experience, but also an opportunity to look at each patient individually. Like Dr. Azia just said, it's, each patient is its own unique control in and of herself. And going over these cases individually with all of these physicians allows us to make a plan that is personalized to the patient. And so after this meeting, I will meet with the patient, and I might have the patient also meet with the other consultants to really discuss the plan that we came up with. The other thing that we do that I think we did a lot more when we first started this and aren't doing it as much now is that if there is a surprise in the operating room or if something is different, sometimes we'll go back and look at the pictures again and see what we might have missed. And that's a way to teach each other what you saw in the operating room and comparing it to radiology. And it just improves the overall experience, not only for the surgeon, but for the radiologist as well. And then, like I said, I'll get consults for these patients if needed with colorectal, thoracic, urology, fertility, et cetera, so that the patient and I are both really comfortable before going to the operating room about what to expect. And I think, if there's anything we learned from all of these talks today about diagnosis of endometriosis and the effects of endometriosis on fertility and surgery on fertility is that making a surgical plan with these patients before going in with as much data as possible is really the key. So in conclusion, the diagnostic accuracy for endometriosis is crucial in preparation for surgery. It allows for appropriate patient counseling, and it allows for triage to centers of expertise in treating endometriosis. Using transvaginal ultrasound can detect severe disease and deeply infiltrating disease, but surgeon and radiology communication is really important, and you need highly trained and skilled ultrasonographers to fully detect these lesions by transvaginal ultrasound. And if you can't do that, then getting an MRI is totally reasonable, and also can be used for things like thoracic endo, which I don't think we can yet see with a transvaginal ultrasound, but can be very relevant. And then finally, classification systems like NCN and AGL can be used preoperatively, and they are mostly used to determine surgical complexity and where the lesions are going to be. They allow for a single language to be used between the surgeon, the fertility specialist, and the radiologist. And I think the most important place for these systems or these classifications or staging indexes is for research. I think the best way for us to be able to evaluate and compare the effectiveness of therapeutic interventions, whether they're medical management or surgical management, is by being able to speak the same language and having a staging system that makes sense, or a classification system that makes sense that we can all use. Because if we have something that we can all use, then when we compare data, we're all speaking the same language. And I think that's really important. So that is my lecture. And I'd like to thank you all from Connecticut. We have gotten lots of rain this year, so we have beautiful green. And someday, hopefully, we can all be together again, because I would love to go to Moscow and visit Dr. Adamian someday.
Огромное спасибо, дорогая.
Thank you very much, dear Daniela. Thank you very much. You are always brilliant, and you're a fantastic daughter of your fantastic father. And I have to say that almost every presentation of yours, it's a female view on endometriosis challenge, but very deep view. And three things you mentioned, I'm really thrilled by that. What do? You do benign oncological continuum, benign, and your position is endometriosis is multidisciplinary disease, and also plus to that, you said, as our great friend Anastasia said before, actually every new patient with endometriosis, it's a new universe. And thank you very much for that. And thank you very much for being with us. Thank you for connecting. And thank you for making your fantastic presentation. And I do hope, and I'm absolutely sure that we'll see you again very soon in the near future. Thank you very much. And we wish you all the best. Dear colleagues, and Professor Nijrat is waiting for us. Medical Director of Nijrat Medical Center in Atlanta, and the title of the presentation, Etiopathogenesis of Endometrioma and Surgical Treatment of Female to Increase Fertility. Dear Professor Sina, your 20 minutes, and hopefully you will stick to the timing, because we have two more gentlemen here after you, because we expect Mario Melzoni after you, and then Andrea Sebert. So you're welcome. Please start, and then Hugh Taylor. And I couldn't say no. I couldn't say no in order to make the presentation. Our Congress, it's a huge site. It's a huge site for the enlightenment, for the education, for science, and for the treatment, which is implementing and demonstrating all the best. So, dear Sina, you see that I wanted to give the floor specifically to you in this very saturated session of great surgeons. Mike is yours.
Very much, dear Laila and Asia, for the invitation, and thank you, everybody. I do work with these companies mainly on teaching and product development. Some of the data are from this book, which is available online for free, and I'd like to thank my fellows and assistants to help me to prepare this presentation. My talk, it would be a lot easier after listening to the previous speakers and looking at the agenda. But what we have here, British Journal of OBGYN made the suggestion comparison of expectant management versus surgical management. And in my opinion, surgical management, if it's done properly, it is in the benefit of the patient, and I will elaborate on it. Specifically when it comes to the patients with endometriosis, endometrioma, and infertility. This is available online for your reference. We do know for the fact that endometrioma affects the ovarian function in multiple levels. It has a toxic effect, it has a physical effect by compression, it affects the growth factor decline, and it could cause tissue compression, necrosis, damage, and decrease the follicular density and quality. Also, when it comes to comparing on the size of endometrioma, it all depends on the type, not just the size by itself. I know most like ESHRE guidelines says endometrioma more than 30 centimeter or less than 30 centimeter affects the management, but if we go by the classification that I will elaborate on, even a smaller size could have toxic effect on the function of the ovary. We also know for the fact that bilaterality, it could affect the ovarian reserve, the function, and fertility. So putting all of these together, the type of endometrioma, the size of the endometrioma, bilaterality, and associated pelvic pathology are the important factors. When they looked at the anti-Mullerian hormone and the patients with endometrioma, and when you look here as a baseline versus 1 month or 6 months follow-up after the surgery, definitely there would be, if it's done properly, would be improvement in the AMH. So having said this background, I'd like to show you that and tell you we believe not all the endometriomas are the same. Philippe and I have had this discussion multiple times, and I'd like to get his attention. I'm sure he will have comments later on. How we look at the picture affects our judgment. You heard after the ultrasound evaluation, after anesthesia evaluation, how we look at these endometriomas, it would help us decide how to manage it. For example, this is a case that is being reported to be as a corpus luteum on ultrasound, hemorrhagic cyst, but the patient had symptom, infertility. And when we look at the surgery, this is along the right pelvic side wall. You could see those fibrotic lesions right on the top of the ureter, on the uterosacral ligament. If we look deeper in the cul-de-sac, we could see the endometriotic lesions in the pararectal and rectovaginal septum. So simply ultrasound defining it as a hemorrhagic cyst or corpus luteum does not help us make a decision. We have to judge it by clinical symptoms as well. Looking further down on this cyst, lifting the ovary, you could see the endometriosis and fibrosis affecting the ovarian supply of the blood supply, and these are more fibrotic. So endometriosis itself could affect the function of the ovary. Looking down deeper on the cyst, if we aspirate it, yes, at one part it would show the luteinized corpus luteum, but look at that chocolate cyst fibrotic on the top, which we classify it as a type 1 endometrioma. And what do I mean by type 1 endometrioma? In 1992, my brothers did a report of classification, and then in 2000, we modified it, published it in ESHRE group, and there are two types of endometrioma. Type 1 are true endometriomas, which is endometriosis invading the wall of the ovary and growing on it. Type 2 endometrioma are the result of the endometriosis entrapment in ovulatory cyst and the functional cyst. And we further classified these. And here, type 1, you could see the endometriosis from outside, fibrotic, invading deep into the cortex of the ovary. These are the hardest to remove because they are fibrotic, could damage the ovarian cortex unless we remove part of the ovary. It's better to remove them with piecemeal biopsy, make sure it's benign, and then we can do ablation. Type 2, however, and this is a drawing from Michel Canis, is that based on our classification, when the endometriosis gets entrapped into the post-ovulatory cyst and then it forms adhesion on the top, this endometriosis is active inside the ovary and creates hemorrhage and forms fibrosis and chocolate cyst. We believe that type 2 endometrioma are early functional cysts, and you can see they are more on the surface. Majority of the other cyst wall is thin and easy to remove. Type 2B, the lesions are larger. They are still small compared to the complete invasion to the wall. Cyst wall is easily separated at the base of implant, but there is an area of fibrosis. Type 2C is the worst kind. It's been around for the longest, is more fibrotic. It affects the sidewall, creates adhesion, and these are the ones that excision could be more difficult. Daniela mentioned the ultrasound and also Anastasia, excellent presentation. Today, color Doppler ultrasound evaluation of the endometrioma is very helpful. As you can see here, there are minimal blood supply to the cyst wall, only very small area. And why is this important? For two factors. One, it would help us strategize where to make the incision. And number two, it would tell us that those capillary oozing of the cortex or the base of the ovary doesn't require energy, doesn't require bipolar and causing vascular damage. There was the data that when they did a systemic review of the 11 studies that they did endometrioma, except for one of them that did not mention the technique, majority of them used bipolar on the ovary. And these are the ones that could cause ovarian damage and decrease the AMH and fertility. Of course, the technique of the removal of the ovary cyst is important. These are on the top, on the bottom, you could see both patients, they have had prior ovarian cystectomy, and you see the majority of the cyst majority of the ovary has been removed on one side. So the surgeon, as Anastasia said, is very important. This is an example of a person having pain, and this is a corpus luteum that being traumatized. So these are the techniques who could damage the ovary and ovarian function, and definitely this cyst did not require any intervention. Although you can see here, the surgeon is trying to do hemostasis, is burning the residual ovarian tissue. So we have further damage to the ovary, and of course those piecemeals around the pelvis could cause adhesion. So the technique of ovarian cystectomy relies on microsurgical principle that has been advocated for so many years. Mobilization without tension, gentle manipulation, avoid devascularization. And I will show you hydrodissection, which has worked for us. We do not use any energy, and reapproximation without strangulation. I have seen people suture the entire ovary together, which is not necessarily the good technique. This is a technique that I showed you the ultrasound picture of the same patient. And as you can see here, first evaluation of the entire pelvis is important. You could see the right tube is patent. The left tube has distal adhesion to the left uterosacral ligament. We have endometriotic lesion in the posterior cul-de-sac, rectovaginal septum. So only removal of the endometrioma and not treating the residual endometriosis is not good. We lift the right ovary and you could see these are type 1 cortical endometriosis, very superficial. This is the hydrodissection technique. This is a diluted pitressin with saline. And as you notice here, we injected on an avascular area. This minimal cortical incision, it could be made with any device. And the rest, it relies on traction and counter traction. And as you see here, majority of the cyst is inoculated easily. This is a type 2C endometrioma. As I mentioned, the base of it has more of a fibrotic area. And those are the ones that requires minimal incision. These are the cortical endometriosis, which is vaporized. So we do complete treatment by vaporization and excision technique. We don't have necessarily to go and remove all these small lesions from the cortex of the ovary. As far as the suturing, as I mentioned, this is a non-inflammatory monofilament absorbable PDS. Intracortically, this is a number 4, and we stay inside the base of the ovary, try to avoid bringing the cortex and suturing on the cortex area, and this cyst is inoculated and easily removed. When we talk about endometrioma and function, it is very important that, as I mentioned, we have to address associated peritoneal implant adhesions. When we work on the hilum, we have to be very cautious about working on the uteroovarian ligament. And when we see a brown area on the surface, simply by vaporization, we can take care of it. For those of you who are interested in the robot, this is a similar case. And you can see here, we assess, this is a type 2C endometrioma as well. We look at both pelvic sidewall, minimal traction, and the least amount of compression on the ovary. If you notice, I avoid grabbing the ovary. We try to lift it without compression or tissue, which could cause tissue necrosis. Now the cyst is ruptured, we copiously irrigate it, and I will show you again hydrodissection here. And if you noted, simply by injecting saline or diluted pitressin, majority of the cyst wall is separated. It's only the edges that they are fibrotic, and those are the area which were adhered to the pelvic side wall. So simply by inoculating this cyst, we have done separation of the fibrotic cyst from the ovary, and then the rest of it removal is very easy. Post-surgical ovarian failure, as we mentioned, it has to do with the patient's associated pathology, surgical experience, but surgical experience doesn't guarantee preservation of ovarian function. This is a great study from Busaka, which is a great surgeon, and even in his group, when he did, when in his group they had 3 cases of ovarian failure in 126 patients. So choosing to do surgery still has to do with indication. Now, cystectomy versus cyst wall ablation, for the fact we know that cystectomy decreases the recurrence rate compared to ablation only. And this is for Umberto, Alboruzi, and these are available. Now, to summarize what I mentioned to you, this is Kamran Nejad, my brother, in 1986, advocated using CO2 laser for ablation of the base of the endometrioma with good fertility outcome. Myself, I came up with using argon plasma, which is actually originated from Russia by engineers, by Russian engineers. And we are lucky now that Nicola is in Atlanta. And this plasma jet, I have had good results for ablation of the base of the cyst. And now there are literature coming up about sclerotherapy. So these are alternatives that they are available, but I still would like to focus on proper cyst excision. When it comes to the IVF patient, I think it's better to remove the endometrioma before going with the IVF, because I have seen a lot of post-IVF abscesses and infection. But the IVF people think otherwise. Our group, we looked at the retrospective study of a group of patients who had failed IVF. This is available fertility sterility online. And we found out that when we treat endometriosis on patients with infertility, who even those who have had failed IVF, they have good chances of spontaneous pregnancy and also IVF pregnancy. So to summarize it, endometrioma is not just endometrioma. Endometrioma is like a bird. Not all the birds are the same. We have to classify them, and classification and type of them would help us to have proper approach. Video endoscopic excision of endometrioma with or without robot, it would have less chance of recurrent best outcome, and if it's done properly, improves fertility. And patients who have had prior treatment of endometriosis would benefit from complete treatment. I'd like to thank all of you again for being here and participation. I'd like to thank Professor Adamia and Asia for this opportunity, and wish you the great rest of the meeting.
Dear Professor Nijat, dear Sina, that was a wonderful presentation as I expected. Thank God you proved that endometrioid cyst is not just a cyst, but that's a disease that should be eliminated. And of course, that would mean the restoration of the reproductive function, reduction of pain, and so on and so forth. But that should not be a training procedure. Otherwise, the ovarian reserve will be diminished. Thank you very much. Well, and also say hello to all your family. Thank you very much again.
Thank you, all of you, for the opportunity, and my family and I send their best regards to you, and we're missing you in person.
Thank you, my dear. Well, dear colleagues, in 2 minutes, we're going to give the floor to our big friend who will be operating on patients tomorrow. That's Mario Malzoni. Dear Mario, we're waiting for you. We can wait for you for ages. We love you very much. We love your surgical technique and the way you organize congresses. We were in Rome. Rome is a wonderful city, wonderful impressions, and the attention you paid to all our delegation. That was wonderful, being in Rome. And please say hello to your dad, to your mom, to all your relatives. I love you very much. And today you will have a presentation. Tomorrow you will have a surgery. Mario Monzoni. The theme of his presentation, that was in the morning, in fact. He was supposed to speak in the morning. All right. So let me see. All right, here is the presentation. Tailoring surgery in deep endometriosis with bowel involvement. Professor Mario Monzoni, who is the scientific director of Modern Gynecological Endoscopy, the National Endometriosis Center, the Center of Cancer Diseases, Avellino, Rome. It's always a pleasure to be in the operating room with Mario. He operated a long time in Russia. It was a gift of Harry Rich, and now I should say that we had a real celebration in Rome. I was happy that we met in Rome. Mario, now the floor is yours. Do not overrun your time because we're monitoring the time. Thank you very much.
Hi, Leila. Thanks again. Thanks so much for this opportunity. And thanks again for being part of the meeting in Roma in the last May with your daughter Asia, with all your team. So thanks for this opportunity. And thanks for the opportunity of tomorrow to perform live surgery from Italy too. So I share my computer and I start with my presentation. And so let me know if everything works.
Yes, we can see the slides. Go ahead. But if they're not full screen. Yeah, everything is okay. Everything is okay now. Go ahead.
Perfect. So the tailoring of surgery in deep endometriosis with the bowel involvement. So we start from this consideration that to give a correct management in reference center for patients with deep endometriosis and suspicious of bowel infiltration, we have to start from a correct anamnesis and clinical evaluation. And then we talk all the morning about skilled imaging using in deep endometriosis in order to understand the correct indication for clinical management of these patients, and to put a complex counseling with the patients and informed consent. And then, if needed, we go in operative room with skilled surgical experience, knowledge of anatomy, and an adequate intraoperative and postoperative management of all the complications. The consensus on endometriosis in Salzburg 2022 arrived to some consideration, like asymptomatic patients shall not be operated, of course. In case of pain symptoms, we can consider surgery, and we can consider surgery in order to improve and reduce the pain and improve the quality of life of the patients. And pelvic MRI and transvaginal ultrasound with experienced radiologists and sonographers are very accurate, and the surgical team should be able to upstage or downstage the surgical procedure according to all the intraoperative findings. And consensus number 4 is that the surgeon should be as complete as possible in order to remove all the fibrotic tissue in order to leave at least a visual disease-free margin of the disease. It's better to avoid to dissect the nerves, and if you have a bilateral infiltration of the nerves in the dorsal parameter, probably it's better to consider to leave some disease on one side. Avoid unnecessary dissection of the nerves, of course, and always try to be as conservative as possible. But when the nodule is very big, with the big infiltration, with stenosis of the bowel, the procedure of segmental bowel resection is to be considered. And the fibrosis seems to be the part of the disease, so should be removed. And so about the preoperative workup, we have an ultrasound or MRI, urodynamic test in case of suspicious of infiltration of the posterior and dorsal parameter. We avoid, so we never ask for colonoscopy and double contrast cinema because we don't need these instruments and this workup. The sonographer, radiologist, must speak the same language of the surgeon with the same classification system of the disease, and so consider a ultrasound evaluation of the descending colon, the rectosigmoid, and the right colon with the ileocecal valve and appendix. This is the picture of ultrasound and the indication for surgery, considering the sites, the cranocaudal sites of the nodule, the depth of infiltration, the number of the lesions, and the circumferential bowel involvement of the lesions. We published in 2020 our landmarks for evaluation, the preoperative evaluation by ultrasound, the cranocaudal sites less than more than 3 centimeters, and the infiltration of the muscularis more or less than 7 millimeters. And so the clear indication for shaving all the superficial nodule, the clear indication for discoid resection, and the clear indication for segmental resection for the nodule bigger than 3 and deeper than 7 millimeters. So this could be the technique that we use for shaving technique. So if you have a big plaque, more than 3 centimeters, but with the infiltration very superficial, less than 7 millimeters, we can work at the level of the serosa or inside the muscularis, and you can scale the mucosa and remove all the muscularis infiltration using bipolar, ultrasound instruments, or I prefer to use monopolar current with coagulation mode, so-called precise coagulation mode in monopolar is a wonderful technique to remove and to achieve the clear and the correct cleavage plane at the level of the muscularis of the serosa in order to avoid to opening the mucosa. We can avoid to open the mucosa if the infiltration is superficial, less than 7 millimeters. It's very difficult to avoid to open the mucosa if the infiltration is more than 7 millimeters because arrives completely inside. So in that case, we need to do a discoid resection in case of deep nodule smaller than 3 centimeters, and we published it on 2021 on Journal of Minimally Invasive Gynecological Surgery, our technique of discoid resection. So just to show you the final part of the technique after the removing with the shaving technique in the superficial part, we put a stitch inside the nodule, and then with the circular stepper we go through the rectal view and do the resection of the anterior wall of the rectum, closing the circular stepper, the transnasal circular stepper. With the check of indocyanine green evaluation of the vascularization, we go with to check the vascularization at the end of the discoid resection. We published our classical technique in 2020 about the surgical steps for segmental resection using the classical mini laparotomy access, and this is, in our opinion, the technique to prepare lateral at the level of the pelvic side wall, checking the left ureter, the internal of the left IP ligament, of course, evaluation of the common iliac vessel, the external internal iliac artery, and then evaluation of the hypogastric nerves, opening of the medial parectal space, and then we have to avoid to push or to pull on the nerves and opening only the plane that we need medially to the presacral fascia, medially to the nerve, and laterally to the mesorectum. So opening of medial parectal space, and then we operate and resect. For the last part of resection, the classical technique is the small laparotomy suprapubic laparotomy, and then we can remove completely the nodule, put the anvil, and come back in laparoscopy in order to complete the end-to-end reanastomosis with night briefing. And this is the final picture of the nodule. And if we compare the ultrasound picture with the specimen picture, you see the good level of the accuracy of the preoperative evaluation. So our complication on the first area in our center, in 17 years, we performed more than 1,400 segment of our section for infiltration of the bowel, deep endometriosis, rectal bleeding at 3.2%, anastomotic leakage 1.6%, and rectovaginal fistula at 0.7%. Then we are thinking 2 years ago, we have the idea to reduce the mini laparotomy access for extracorporeal anastomosis and specimen retrieval, and do a total laparoscopic resection with intracorporeal anastomosis, the so-called nose, natural orifice specimen extraction. If you see at the literature, we have many randomized trials, systematic review, and meta-analysis about the use of nose technique for colorectal cancer. If we compare with the traditional conventional laparoscopy with mini laparotomy, nose should be preferred to transabdominal specimen extraction in order to reduce the rate of postoperative pain, shorter time of gas passage after surgery, decreased of hospital stay, of course, better cosmetic results, and reduce the rate of wound infection and incisional hernia. One of the problems at the beginning was in the colorectal cancer for using the nose, the risk of implantation of the tumor at the specimen extraction site, but the results was totally different in terms of total recurrence, local recurrence, disease-free survival, and overall survival. If we compare it on the pooled analysis of 19 studies in literature involving a total of 3,432 patients, we have no difference comparing the nose technique versus the conventional laparoscopy plus laparotomy for colorectal cancer disease. And about the risk of bacterial contamination of the peritoneal cavity, at the same on 21 randomized clinical trials involving 2,112 patients, we have no difference between the two groups. So the experience with the intracorporeal anastomosis and nose technique for treatment of bowel endometriosis is very limited in gynecology, and literature review comparing for the transvaginal natural orifice specimen extraction for deep endometriosis bowel resection is only 124 cases with postoperative complication grade 3. You can see on this picture. And very similar results for the transanal natural orifice, only 124 cases, and this was the complication rate of grade 3 complication. We published our technique on 2021 about the total laparoscopic resection with the transanal natural orifice specimen extraction for infiltration of the rectum, and this is the final part of the technique, resecting completely the rectum, opening completely the rectum. So we resect under the nodule and then cranially to the nodule. This is the second resection line, and we remove only the part of the sigmoid and rectosigmoid junction bowel with involvement of the muscularis. The nodule is more than 3 centimeters, and through the anus, the extraction in the back, so avoiding the mini laparotomy. Then we go inside with the spike and the anvil, and then the spike go up in the cranial part of the rectum. Small hole, then we remove the spike and we close the opening of the sigmoid with the linear separate through a 12mm port on the right side. Then we close the rectum with another linear separate, so all the procedure without laparotomy, only with one 12mm port, two 5mm port, and one umbilicus for the optics. So the results are very good. This is the final part of the reanastomosis that usually is could be a terminal or lateral to terminal anastomosis. The check of leakage with air bubble test or Brody-Methylene test, and then we cover the dog air with a single stitch in order to reduce the tension at the level of the reanastomosis. This is the final results, and this is the evaluation with the overlay mode, androgen in green fluorescence, and monochromatic mode that, in my opinion, is better to identify the vascularization at the level of the shoot. So the results on the first 40 patients treated in the last year, very good results in terms of radicality of the surgery, in terms of use of drainage. We never used the drainage. No patients had protective ileostomy or colonostomy. And this was the median of the surgical time, blood loss, intraoperative complication, no intraoperative complication, only one anastomotic bleeding treated with endoscopic management. And we have 1 day of average for passing gas after surgery and 4 days of median for passing fishes after surgery. Hospital stay was 5, now we are between 3 and 4 days. So the pro for this technique is the lower overall and wound complication rate, better cosmetic results, and potential for decreasing of hospital stay and increasing the quality of surgery and the quality of life of the patients. We need a specific training. We have to standardize the technique, and we need the randomized clinical trials in order to compare at the end the final results with the classical technique. So in conclusion, and we are in time, we have to agree the same endometriosis classification system between radiologist, sonographer, and surgeon, speak the same language, the same anatomical nomenclature, and appropriate indication for medical treatment, pregnancy, of course, surgery or follow-up, correct surgical indication for shaving, discoid or segmental resection, and correct surgical strategy, and in order to have an appropriate preoperative counseling with patients, and please centralize the patients in the reference high-volume center. So thank you again. Thanks for your attention. And thanks, Leila, again, for involving me in this wonderful meeting.
Dear Mario, thank you very much. The quality of your surgeries is fantastic. Thank you. Tomorrow morning, we'll be waiting for you in the OR. Thank you very much. See you tomorrow.
Thank you so much.
Спасибо.
We've got 2 minutes for a break. After this, we're going to give the floor to Andres Pellicer. Thank you very much.
Яйцеклетка вышла в маточную трубу. Граафов фолликул трансформировался в желтое тело. Наступает лютеиновая фаза менструального цикла. Желтое тело активно синтезирует прогестерон. Под действием этого гормона слизистая оболочка матки, эндометрий, утолщается, обильнее снабжается кровью, в слизистой становится больше желез. Так прогестерон готовит эндометрий к имплантации в него оплодотворенной яйцеклетки. Именно поэтому прогестерон называют гормоном беременности. Однако тот же прогестерон один из факторов развития миомы матки. Эта доброкачественная опухоль возникает в виде узлов в мышечном слое матки – миометрии. Активный рост узлов происходит в лютеиновую фазу менструального цикла, а также во время беременности, то есть на фоне высокого уровня прогестерона. В клетках миомы содержится большое количество рецепторов прогестерона. Стероид соединяется с ними и в таком комплексе поступает в ядро. В нем прогестерон вступает в связь с определенными участками генов и активирует синтез белков, тканевых факторов роста и цитокинов. Эти специфические белки вызывают синтез ДНК и заставляют клетки миомы делиться, а также стимулируют в опухоли ангиогенез – образование сосудов. В то же время прогестерон подавляет синтез белков апоптоза – белков, контролирующих смерть старых клеток. Старые клетки не гибнут, новые образуются, узлы миомы растут. Женщины испытывают обильные и длительные менструации, чувство боли, давление внизу живота, боли в спине, часто анемию. Назначение гинестрила – один из современных способов остановить рост миомы матки. Препарат содержит синтетический антигистоген мифепристон. В клетках миомы антигистоген связывается с рецепторами прогестерона и блокирует их. Таким образом, не дает половому гормону соединяться с собственными рецепторами. Как следствие, тормозятся эффекты, которые зависят от прогестерона. Так подавляется синтез тканевых факторов роста. Миомные узлы не растут. Кроме того, через факторы роста гинестрил тормозит в узлах миомы ангиогенез. В итоге клетки миомы недостаточно снабжаются кровью, испытывают гипоксию, нехватку кислорода. Стимулируется работа белков апоптоза. На этом фоне клетки миомы не только не делятся, но и гибнут. Миомные узлы уменьшаются в размерах. Своевременная терапия миомы матки гинестрилом позволяет избежать радикального хирургического лечения, тем самым сохранить орган и репродуктивную функцию. Препарат отличается хорошей переносимостью, не вызывает симптомов эстрогенного дефицита, депрессию, не влияет на массу тела и свертываемость крови, не снижает плотность костной ткани.
Связь, извините, с министерством, я не могла по поводу важной и тяжелой больной оторваться от этого момента. Уважаемый Андреас Эберт, директор научно-исследовательского центра.
Director of the Research Center and the Clinic of Female Health, Gynecology and Obstetrics, our great friend. And his topic today is the galat epigalat catechin and endometriosis, new opportunities for the very well-known options, Berlin, Germany. And we have to say that Professor Ebert is a great surgeon. He's a fantastic doctor, and he's our great friend. And Andrea, please apologize for a little bit of delay. And after you, we would be happy to give the floor to Dr. Taylor. And this is fantastic journey. And we are welcoming Professor Ebert. Mike is yours. And he will be speaking about the new opportunities for the old treatment. Mike is yours. Distinguished colleagues, dear Leila, thank you very much for a fantastic invitation to speak up today in Moscow. And I'm extremely grateful for the organization of this fantastic Congress. So although Russian, Chinese, and the British are the big lovers of the tea, I am, being a German, will tell you a little bit about the green tea and the role of green tea, that role that it can play in the treatment of endometriosis. We heard wonderful presentations how endometriosis could be treated. We know what role belongs to the surgical part in this orchestration of treatment. Laparoscopy, how important it is for the diagnosis and to find endometriosis and to remove as much endometriosis as possible in order to get histology. So that means maybe some markers like estrogen receptors, progesterone receptors, Ki67, or other markers. And definitely we need to know what sort of stage our endometriosis has. But then there is a question, what is next? All right, but what is next? So what can we administer? Maybe non-steroid anti-inflammatory treatments, or maybe gestogens, or maybe Mirena would be enough, LNG, IUD, maybe a COX, oral contraceptions could be okay, because in some females we still need to give analogs or antagonists. And we know that these hormonal treatments, they have their own side effects, and very many patients are suffering from depressions, they are losing libido, and they have problems with skin and problems with vein thrombosis, thromboembolias, etc. And for that, it would be great to have some more options of treatment, but unfortunately, these options are yet quite experimental, and definitely the natural products, biological products, and you know, this is the classical question. So women come after the surgery, says, "Doc, surely it's all great, but do you have something without hormones?" And you are looking at her and thinking, "Oh my God, endometriosis, that's a chronic disease. This is hormone-dependent disease, so that would be great if we take gestogen now," but the patient is against. She doesn't want. So what to do? So when we look at the opportunities, so what is developing beyond hormonal treatment, and we see that more and more frequently we have some data about green tea, about epigallocatechin, resveratrol, red wine extract, curcuma, etc. So all that is extremely interesting for the patients as well, because they have a feeling that they're doing something good for themselves, something natural. But definitely it would be great if this natural would also be helpful. And if we look again at green tea, so it is treated properly, it is started properly, so we know the formulas, we know the functions, and actually we have taken a lot into oncology from the green tea. What specifically? So for example, we know that normal cells could be changed, and finally they could turn into malignant cells, and there are several steps, and this is initiation, promotion, and progression. And this is very interesting that molecular data from oncology clearly tells us that epigallocatechin-galat, so that means green tea extract, could positively influence and inhibit oxidative stress, inflammatory processes, growth factors, reduce apoptosis, and also could influence the proliferation and also the production of new microvessels. So all that could be influenced by epigallocatechin-galat. If we look in the detail, then we have a lot of interesting developments here. And nobody knows why actually this data from oncology cannot be transferred for the endometriosis treatment, especially if we have huge number of patients who are happy to have the surgery, but they say no to hormones after the surgery, even if the hormones are indicated. If we again look on how EGCG, epigallocatechin-galat, is working, we know which pathways it could potentially influence. For example, NF-kappa B. And you know that NF-kappa B plays a huge role in endometriosis because it could influence IL-8, and also it could influence on estrogens. So IL-8 could be effectively suppressed. And this is how inflammation, proliferation, especially in the stromal cells, could be minimized and diminished. And epigallocatechin-galat could inhibit NF-kappa B. If we look at this very complicated but very beautiful picture, you can easily appreciate that epigallocatechin-galat also could inhibit the expression of COX-2 as well as NF-kappa B. And this is how it could potentially influence P53 as well as AKT. So that means cell proliferation, cell apoptosis also could be effectively influenced by epigallocatechin-galat. So that's extremely interesting, novel data, because these data shows that this is the way how we can influence the inflammation, we can minimize the inflammation rate. If we look at this pretty old picture of pathogenesis of endometriosis, we see that COX-2, cyclooxygenase 2, and definitely PG2 and star aromatase are in the center of endometriosis development, P450 aromatase. So it's in between stroma and muscularis and the cells of mucosa. So this is the struggle takes place, and that would be great if we have something that could potentially influence at this level. If we again look at other components, other medical options here, then we see that epigallocatechin-galat could even influence like antisclerotic and antihypertrophic. This is also very interesting to us, beside antioxidant and beside inflammatory processes, because we know that endometriosis and adenomyosis, this is hyperplasia. And here we could see some potential preventive approaches that yet are not quite clear to us, including even antisclerosis. We all know if we perform ultrasound, and this is very frequently, especially in adenomyosis, we see the vessels that demonstrate sclerotic features. So that means sclerosis in the uterus body. And here we can appreciate it, and possibly we could have some new approaches here. So there is some more new data showing that myomas are easily respond to green tea, but definitely all that should be done with cautious, and we see the reduction of the volumes, we see the reduction of the symptoms, and also we could see the improvement of the quality of life of the patients. But truly, there is no solid literature data here. But all that sounds very promising. But on the other hand, we see some positive effects even on polycystic ovarian syndrome, polycystic disease, because females, they lose weight and they lose fat. And this is how they improve insulin sensitivity and testosterone is reduced. So all that sounds great, but we just saw multiple fibrotic changes in the ovaries, and in the literature, we could easily find some more interesting data showing that epigallocatechin galat could potentially inhibit fibrotic changes, and this is how maybe, and I'm very cautious about it. I'm saying maybe epigallocatechin galat could also be taken as a prevention of fibrotic processes and maybe even adhesions. So this is our current understanding of green tea and epigallocatechin galat's influence to the angiogenesis, fibrosis, and apoptosis. And all these processes, they play a huge role in the endometriosis and adenomyosis. And also free radicals are important here. And also, if we manage to turn off some key proteins like COX-2 or PF450 aromatase, then we would have a great approach for the treatment of adenomyosis and endometriosis. And we all know that cyclooxygenase is differentiated by prostaglandin expression, and they could give pain. So it could be not only non-steroid anti-inflammatory treatment, but also epigallocatechin galat during the whole cycle without interruptions. So there was some more interesting data, but only experimental data. These are mice models, and the investigators transplanted endometrium, and they could show that epigallocatechin galat and resveratrol, so that means concentrate of the red wine, could potentially minimize the rate of endometrioid lesions, and that sounds extremely interesting. And also they could show that epigallocatechin galat and resveratrol in combination, that's the best, could minimize cell proliferation and also could improve apoptosis. They could minimize the number of vessels in the lesions, and also they could support VEGF expression. And this is very interesting data, because if we treat endometriosis with hormones and if we reduce estrogens, then endometrioid lesions also start to be expressed by epidermal growth factor receptors family. So this is so-called survival pathways, and it could be overcome. And this is very important because we know if there is a relapse, then this relapse is very difficult to treat later on with hormones. And actually, what we know from oncology, what we know from experiments, epigallocatechin galat, as well as red wine, as well as extracts of the red wine, and by the way, that's red wine extract, increases the apoptosis rate, reduces proliferation in endometriosis, reduces VEGF, and also endometriosis lesions, not only in oncology, but also reduces the vessel size and the number and the volume of endometrioid lesions. And I believe that this is extremely important, and all these data would be shown for the first time, specifically in oncology. So I believe that what we need to do is to deal with this topic, and there are such approaches that look at epigallocatechin galat pre-op, and if yes, then how long, what should be the concentration, where and how we can use epigallocatechin galat after the surgery. Again, that's a question about the concentration, about the doses, and how long. Then maybe even we can take epigallocatechin galat instead of the surgery. And finally, what would be the role of epigallocatechin galat? in the relapse issue. And the classical question that your patient is asking, doctor, probably you have something without hormones after the surgery, and then you can easily in the future, you can possibly say, maybe we do have something for you, but dear colleagues, yet, I prefer in vino veritas. With that, thank you very much for your attention. And I wish you all the best. I wish you a very successful Congress. Hope seeing you very soon. And I do hope that we will see each other very soon, face to face. Thank you very much, Professor Adamian, for the organization and for the invitation. Many thanks to your team, because I think this Congress is one of the central congresses in the world, which is carried out annually. Dear Andre, I want to say thank you very much. Thank you for your loyalty, for your friendship, for your professionalism, for the depth of your knowledge, because it is really great that we are all together and we are moving forward. We are creating this progress with our own hands. And also, I want to thank you for the following, because if I understood you correctly, from everything what you said, that this is work for the endometriosis, inflammation, minimizes pain, reduces relapse rate, our epigalots and all these products. And what is useful also, red tea, red wine and green tea. Is it correct? Yes, that's the most positive thing. That's the most positive thing, because green tea is loved by everyone. I myself truly love green tea, and if possible, a little bit of red wine. Yes, a little bit of red wine if you have a good mood, and definitely it would influence positively our health and our mood. Well, I'm joking, of course. Thank you very much for very nice words, and thank you very much for high assessment of the agenda of our Congress. Dear colleagues, and now I'm happy to give the floor to Professor Hugh Taylor. I know Professor Taylor for many years. Well, I was directly in United States, and I remember this fantastic university, New Haven, Yale University. To me, it's a university that graduated the Czerny, Neftalina, Taylor, Warsaw, and now Hugh Taylor. So, dear Hugh, I promise you that you would be in the prime time, and this is exactly the prime time, endometriosis as a systemic disease. And we are welcoming the lead of the obstetrics and gynecology chair and the science of reproduction, Yale School of Medicine. Well, what could be better than that? The lead of obstetrics and gynecology ward of Yale Hospital, New Haven. And I would be extremely grateful if you stick to the timing. You have 20 minutes. Thank you very much. Microphone is yours.
I will. Thank you, Lila. Thank you for your friendship, and thank you for your leadership in gynecology. I must say these conferences that Dr. Adamian creates every year are always one of the highlights of my year, and really capture better than any other meeting the exciting updates, the latest and newest novel findings in the field. So thank you not only for your friendship, but for organizing these conferences. Let me share my screen. Okay. Can I just make sure, can everyone see that?
Yes, positive. Please proceed.
So thank you. Today I'm going to talk to you about endometriosis, not just as those blue lesions we see in the pelvis, but really as a systemic whole body disease. I hope I leave you at the end of this 20 minutes with the thought that endometriosis has some profound effects outside of the pelvis. I think you know endometriosis is an extremely common disease affecting almost 10% of women, second leading cause of hysterectomy, at least in the US, first leading cause in young women, and $22 billion we spend in the US alone. Common disease that we don't fully understand. And some of that I'd like to suggest the reasons we don't understand it is because of the systemic nature of the disease. We define it as the ectopic glands and stroma that we think mostly arise through retrograde menstruation. But even this simple definition, I think, belies the complexity of this disease. Sometimes we see the blue or powder burn type lesions in the peritoneal surface. Sometimes we see the big endometriomas. Sometimes we see white lesions, clear lesions, red lesions. It's not a single disease and is much more complex than the simple histologic definition would lend us to believe. Not only that, but we all know the clinical presentation is quite varied too. This really is a very heterogeneous disease. Sometimes patients present with pain, probably most commonly, but sometimes they have considerable disease, and we don't see them till they can't conceive and they come to us for fertility treatment. And sometimes they may have horrific endometriosis and may be completely asymptomatic. So again, the clinical presentation doesn't correlate with what we see in the pelvis, makes us think that, again, there may be other manifestations of endometriosis outside of the pelvis. When you look at pain by stage, whether we look at dysmenorrhea, non-menstrual pelvic pain, or dyspareunia, we see that the amount of pain someone has doesn't vary by stage of disease. So again, what we see in the pelvis is just part of the disease. It doesn't really explain all of the manifestations of the disease. And not only that, that there are multiple other symptoms outside of the pelvis that are associated with endometriosis. Not only do we have the pain and infertility that we've talked about, but fatigue is common. Lower BMI, less body fat is common. There can be bowel dysfunction, bladder dysfunction, generalized systemic inflammation. It can affect the brain as well. Depression, anxiety are common, much more common in women with endometriosis. And not only that, we're learning in the long run, these women have other long-term complications of the disease, such as increase in cardiovascular disease. So again, many features of endometriosis really extend well beyond the pelvis. So I'd like to suggest to you that endometriosis truly is a systemic, a whole body disease. And referenced here is one of the reviews we wrote a couple of years ago that summarized a lot of what I'll be showing you. Again, we used to think endometriosis all arose by Sampson's theory, and most of it probably does. But what about areas that aren't contiguous with the peritoneal cavity, the lungs, the brain, where we sometimes see endometriosis? Or what about endometriosis in women without a uterus, or even in the old days when men were given high doses of estrogen for the treatment of prostate cancer? Some of them developed endometriosis. That's not arising through retrograde menstruation or hematogenous or lymphatic spread. There must be some other etiologies of endometriosis. Well, what we looked at was the stem cell theory of endometriosis, and it's been some time now since we first published on this, and others have reported and confirmed this, that stem cells from the bone marrow at one place, but many other places, can travel to remote locations and differentiate into endometrium or endometriosis in ectopic locations. Bone marrow contains not only the hematopoietic stem cells that we're all familiar with and used for bone marrow transplant, but it contains these multipotent mesenchymal stem cells that have vast ability to differentiate into many cells of solid organs. And we reasoned that if they could turn into all cells of all these other organs, certainly they should be able to contribute to a tissue such as endometriosis and endometrium, where there's this dramatic turnover in each menstrual cycle, a real need for replacement of endometrium. So we asked, could they travel to different locations? Could they differentiate into endometrium? Could they contribute to endometriosis? And to do that, again, this is many years ago, we did some simple experiments. We took male bone marrow, put it in females, and then used Y chromosome FISH to see if we could see any endometrial cells that came from the bone marrow. And this is a summary of some of that work in the mouse. The upper left A is a male tissue, positive control. The red dots are the Y chromosome by FISH. B is a female-to-female transplant. That's the uterus with no Y chromosome, no red dots. But C and D show Y chromosome bearing cells that went to the uterus. And I won't show you all the detailed work that we did to prove these really are endometrial cells and not leukocytes, but they are endometrial cells that are male, so they came from the bone marrow donor. These are bone marrow-derived stem cells that differentiated into endometrial epithelium on the left in C, that's right adjacent to the lumen of that uterus, or a stromal cell in D. We also looked at women. We took women who'd had whole body irradiation, chemotherapy, and bone marrow transplant, And this was in the old days when they did bone marrow transplant by bone marrow aspirate, not peripherally mobilized cells, which contained fewer of those mesenchymal multipotent stem cells. And we looked at women who had had a bone marrow transplant with a mismatched HLA antigen. And the blue is the H&E staining. The brown is the staining for the mismatched HLA antigen. And you can see that the epithelium on the left and some stromal cells on the right that are pointed to by the arrows are the cells that came from the bone marrow of the donor. They have the HLA antigen of the bone marrow donor that have become endometrial cells. You can see the arrowheads point to the blue nuclei there of cells that do not stain for the mismatched HLA antigen. Those are the resident stromal cells that were there prior to the bone marrow transplant, whereas the new ones show that staining for the HLA antigen. Red shows leukocytes, again, to distinguish that from the endometrial cells. And here we show that that contributes in a mouse model to the ectopic lesions. Here we use bone marrow that was from a mouse that had a red fluorescent protein, and we transplanted that into mice and looked at endometriosis that we generated in those mice. And you can see the red cells end up in the lesion, again, cells coming from bone marrow, but probably more importantly, they contribute to the vasculature around the lesion. They probably contribute to that angiogenesis that continues to feed and make the lesions grow. So this is a novel origin of endometriosis. Stem cells contribute to endometriosis, and I think accounts for much of the endometriosis we see outside of the peritoneal cavity. And beyond endometriosis, this is really a novel mechanism of disease. I suspect that we'll find in the future that other diseases arise from the inappropriate transplant and differentiation of stem cells where they should not be located. It's a novel mechanism of disease in general. But I think this may explain some of the whole body symptoms that we see. Not only that, we can see stem cells that leave endometriosis and enter the circulation as well. So not only the cells coming from the bone marrow and becoming endometriosis, they can leave the endometriosis then and go on to spread to other parts of the body. And this is our ability to detect these cells in the circulation of, again, this is a mouse model where the endometriosis cells are tagged. The cells we found in the circulation were not mature endometrial cells. They were predominantly stem cells. So we call this micrometastasis. Many of these cells end up in distant organs. And again, not large clinically appreciable endometriomas, but may impact some of these organs. When we sort for the fluorescent cells of the endometriosis lesions in other organs, what we can show is that found in low numbers in the lung, the spleen, the liver, the brain, multiple distant organs. Again, not large enough you'd ever clinically recognize them, but because we use labeled cells to create this endometriosis, we can detect these small numbers in multiple different organs. Matter of fact, again, very small numbers, but we could find them in spleen, brain, liver, lung, almost every organ we looked at, and essentially in every animal that we looked at. So this is a very common phenomenon. And whether this is part of that impact and creates those systemic manifestations, we still don't know, but it may. The other thing we've looked at in recent years is microRNAs. These are small non-coding RNAs that are, in the genome. They're transcribed but not translated into proteins. Then they're heavily processed, and they can go to messenger RNAs, block the transcription of that RNA or destabilize it so it's degraded. So they generally downregulate the expression of other genes. We know from cancer biology that these microRNAs can actually be exported from cells. They can either naked DNA or encapsulated in exosomes, get into the circulation, go to distant cells far away, and influence their gene expression, a hormone-like effect. So could some of these microRNAs be coming from the endometriosis and affect distant organs? Well, we looked at circulating microRNAs in the women with and without endometriosis, and we found a whole bunch of microRNAs that were increased and several that were decreased in patients with endometriosis compared to controls with no endometriosis. So we could use this as a biomarker for endometriosis, and we've developed a test for this that we published about 3 years ago, when we picked the top microRNAs and we looked to see if they could predict endometriosis in our initial training set. We could really get a perfect receiver operator characteristic curve from this. When we went back and tested in a distinct new population of women with and without endometriosis, we see it's a little bit less, as you'd expect, but still a very good area under the curve. Very high potential for this to be used as a biomarker of endometriosis. But more importantly, those microRNAs aren't just there waiting for us to develop a test. They have a function. Here we use the microRNAs that are elevated or decreased in the serum of women with endometriosis, and we treat macrophages. And when the two black bars show what happens when we increase one of the endometrial or endometriosis-associated microRNAs, 125, or block one that's decreased in endometriosis, the LET7, we can see the macrophages make more TNF-alpha, they make more IL-1 beta, they make more IL-6, they make more IL-8, all of the inflammatory cytokines that are associated with endometriosis. So clearly these microRNAs in the circulation are triggering inflammatory response and contributing to the systemic inflammation we see in endometriosis. We also know endometriosis patients have a lower BMI, and it's been said in some textbooks that being thin is a risk factor for endometriosis. Well, the animal studies actually show just the opposite. When we create endometriosis in a mouse model, they lose weight or fail to gain the same amount of weight. They end up with lower body weight, lower body fat. We looked in their liver, and I won't go through all the details on this slide in the interest of time, but we looked in their liver, and we see when you create endometriosis, we see changes in gene expression that affect metabolism and that would be expected to lead to a lower body weight. We also looked in adipose tissue. And again, I won't go through them all, but when you mimic the microRNA composition we see in the circulation of women with endometriosis, we see changes in leptin, adiponectin, IL-6, hormone-sensitive lipase, all changes that would be expected to lead to decreased body fat, decreased body weight. There is a metabolic phenotype in endometriosis directly caused by the disease. How about brain and behavior? We know that endometriosis patients are more likely to be anxious and depressed. Well, what we've shown is when we create endometriosis in the mouse model, we can directly affect gene expression in the brain, electrophysiology, and that leads to differences in behaviors. When we look at the brains of mice with endometriosis in the upper left, and again, in the interest of time, I won't go through all the details and all the different areas of the brain, but we see certain areas of the brain where we see large differences in the expression of some genes that have been associated with pain sensitivity, pain response, depression, and anxiety. We look at electrophysiology, we can see some differences in signal transduction in the brain. And finally, most importantly, when we create endometriosis, it leads to the same type of behaviors we see increased in women with endometriosis. These women aren't just depressed, anxious people complaining about their pain. No, the endometriosis itself causes changes in the brain that lead to anxiety. To measure anxiety in a mouse, we put them in an enclosed chamber. Anxious mice huddle in the corners. Mice that aren't anxious travel through the center of the box. And you can see in those tracings of their movement throughout the box, the sham mice that don't have endometriosis spend more time in the center of the box than the controls. And when we measure that, you can see within about 6 weeks, we have a statistically significant decrease time in the center of the box. It takes a few weeks after we create the endometriosis, but they acquire this anxiety within 6 weeks. Again, it's statistically significant, the difference, and persists throughout the course of this experiment. So the endometriosis gives them anxiety directly. These mice not showing obvious pain manifestation. When we look at depression, shown in the bottom right-hand corner, to measure depression in a mouse, the standard way that's done is just simply hold the mouse by its tail. A depressed mouse will lie there listless, not try and struggle to get away for a little bit of time, whereas a mouse that is not depressed will almost immediately start to struggle. And you call that the immobility time, how long before they start to struggle to get away. You can see very quickly within 4 weeks, the mice that we gave endometriosis became depressed and that persisted. And finally, pain sensitization. Here to measure pain sensitivity in mice, we put their paw on a warm surface and we wait to see how long it takes for that mouse to sense that as an unpleasant sensation and withdraw the paw. The faster that happens, the more sensitive that mouse is to pain. You can see here it took a little bit longer, but that duration on the hot plate was much shorter in the mice with endometriosis, became robustly statistically significant after about 12 weeks. In each of these cases, it followed the creation of endometriosis, and the endometriosis itself was causing these, again, mood disorders, the anxiety, the depression, and central sensitization of pain. Finally, last I want to present to you atherosclerosis. As I've mentioned, there's some epidemiologic data that have now linked endometriosis to later development of heart disease, cardiovascular disease, epidemiologically. And it's been blamed on sometimes the hysterectomies, oophorectomies we do, or the medications we use. But here we use the mouse model to show it's directly cause and effect. It is not due to the intervention. Here we use a mouse strain called the ApoE mouse strain. Those mice develop atherosclerosis much like humans do. Your average wild-type mouse doesn't develop much atherosclerosis, but these are a good model for human atherosclerosis. And when we look at the blood vessels, here's the large blood vessels are showing aorta. In mice with endometriosis, we see an increased oil red O staining. That measures those cholesterol-laden atherosclerotic plaques. They are increased in the mice with endometriosis. And if we look on the right, you can see the smaller luminal diameter, that vessel is smaller, and the thicker wall of the blood vessel, again, creating that smaller lumen in mice with endometriosis. So again, a direct effect of the endometriosis, independent of treatment modality, endometriosis directly causing that increased atherosclerosis. How does it do that? Well, we think it's more inflammation. The lipids aren't changed in these mice by creating endometriosis. The lipid levels were indistinguishable, yet many inflammatory markers like IL-1 alpha, IL-6, interferon gamma, and even vascular markers such as VEGF were increased in the mice with the endometriosis. So we think it's the inflammatory effects of the endometriosis that lead to arterial damage and atherosclerosis and cardiovascular disease in the long run. So I hope I've convinced you that we're really, when we look at those blue dots in the pelvis, we're really only seeing the tip of the iceberg, that there is much more to endometriosis, that it is truly a whole body systemic disease. And I'll summarize by saying, again, it is a widespread systemic disease. And the systemic nature of the disease often explains these extensive symptoms we see with women with endometriosis that are often hard to explain, and sometimes have given these patients a negative reputation that I think is undeserved. This really is a biologic function of the disease itself that causes all these systemic manifestations. And I've shown you that stem cells, microRNAs, inflammation are a few of the mechanisms that mediate these long-range effects. What are the clinical implications? Well, these varied presentations and these diffuse symptoms have often made it hard for us to recognize endometriosis. We're often distracted by bowel disease, bladder, or sent to a psychiatrist for their depression before they come to us for recognition that it's endometriosis. And I think we recognize these systemic manifestations. It may lead us to earlier, better diagnosis. And while surgical therapy treats the local disease, I think we need to think about simultaneous medical therapy to treat some of these systemic manifestations. Matter of fact, future therapies will include agents such as microRNAs that specifically target some of these disseminated features of the disease, those manifestations outside of the pelvis. I'll end there. I think I went over by a few seconds, but pretty close to on time. Just want to acknowledge all of my colleagues who've done much of the work that I've shown you here in the presentation today. Again, thank you very much for inviting me to this amazing conference. Each year is always quite the pleasure and educational experience to be here. Thank you very much.
Dear Professor Taylor, what can I say? We're all knocked down. You killed us all. I visited your university back in 1986. Oh my God. I was invited by Neftalin Warsaw, the Cherny, and I know your university. It's brilliant, it's fantastic, and I have to say that Yale, it's a big name. Your presentation is not only fantastic and amazing, it's soul-oriented, because every time I look at the patient and I think, oh my God, this is a disease which is everywhere. It's in the brain, it's nevrinoma, it's ganglioma, it's meningioma, so it's everywhere. It's colorectal manifestation, it's mild, it's lung, it's diaphragm, and definitely it is interdisciplinary problem, and you are absolutely right. And thank you very much for sharing this fantastic information. And I do believe that we try to do our best. We try to make our common scientific project, and you are a fantastic speaker, and thank you very much for that. And to all my friends, say big hello to all of them. We wish you a very good day. Distinguished colleagues, and now we are happy to give the floor to Tatiana Zefirova, and she will speak about the modern aspects of the diagnosis and treatment of cervicitis. She is the Professor of Obstetrics and Gynecology Chair, Kazan State Medical Academy, the branch of RMAPO University, Russian Medical Academy. The title of the presentation, Modern Aspects of Diagnosis and Treatment of Cervicitis, and we have also Antonio Pellissieri as a reserve, and this is preservation of fertility in endometriosis, and that would be a jury. So, dear Tatiana, please, the floor is yours. The most important is stick to this timing. Time is most precious thing today. Leila, good afternoon. Thank you very much for the invitation. I'm very honored to speak up today among the big stars on this constellation. And I will try to do my best, not just to stick to the timing, but also to even shorten my presentation a little bit in order to save time. So I will be speaking about the cervix. Cervix is a small organ that creates lots of trouble, lots of problems in real practice due to the localization, due to the structural and functional specificities. Cervix is very prone to different involvements, and these involvements can happen due to very different reasons. It could be hormonal, genetic, mechanical, immune, etc., etc. But in our practice today, the most frequent is the inflammation, cervical inflammation. And any doctor, any clinician, which is a practitioner, could see and understand that cervicitis, it's a condition which is not easy to cure, and sometimes it relapses to the worse, and this sick cervix, inflammation in the cervix, and poor swabs, we see them almost daily in our practice. So, now a few words about cervicitis. It's important to have proper structured diagnostic and treatment approach to make this algorithm very clear. And then, in real clinical practice, we can easily implement it, and it will be crystal clear to the doctors what should be approach to work with cervicitis, not to complicate the situation, but to make it short, crystal clear, and effective. Cervicitis, most frequent disease of the cervix, which is inflammatory. This is multilayer and cylindrical epithelium, and it's important to remember that it could be of infection genesis, it could be non-infection by nature. It's not always that cervical inflammation is exclusively bacterial, viral, or some other type of effect. This is how cervix is organized, cylindrical epithelium, that it's very prone to the damage, to the inflammation, because the specificity of that is not reliable protective mechanism due to the cervical mucus. This mucus is not always there because cervix doesn't always look ideal, sometimes traumatized and injured. And multi-layer squamous epithelium, this is reflection of uterine epithelium, and the challenges are the same. The reasons of inflammation are the same. And excess cervicitis, it's actually the mirror of vaginitis. And repeat it once again, So that's the property and the structure of the epithelium, which is the same. Speaking about etiological factors, now it is very clear that in acute cervicitis, the most important, the first and the frequent reasons of inflammation are still the agents. These are sexually transmitted agents. It's very important to remember infections should be known because that causes us to very accurate and intensive identification of these agents. If you remember that females, especially sexually active females, young females, acute inflammation in cervical channel, these are sexually transmitted agents. Most frequently, you would check them and double check them, and you will look for them. That will be proper examination, high quality cervical swab, then sequencing, and if needed, they could be culturing. And after all, you will find what you are looking for, especially if you pay attention to the trigger.
For example, a recurrent bacterial vaginosis, which is the marker of all problems related to sexually transmitted infections. Taking this observation, when a woman was treating vaginosis many times and on multiple attempts, it turned out that she has plasma genitalia infection, and all problems with recurrent vaginosis were gone after this. As for etiological factors, in case of chronic recurrent process, we must remember that non-diagnosed STIs do take place, and this happens quite often. So the approach is the same. First, we should exclude STIs, and if a woman is in the risk group and you do not find anything, it is feasible to see what is happening with her sexual partner. There might be other reasons for recurrent cervicitis, and here non-infectious events should also be taken into consideration. That's a traumatized cervix with ruptures, with poor or interrupted deliveries, the effects of drugs, immune reactions, everything can happen. It's difficult to detect, but we must bear this in mind. And of course, recurrent chronic cervicitis is associated with vaginitis, with vaginal infection, or with dysbiotic conditions in the vagina, because they usually go hand in hand, especially when we're talking about clinical manifestations of cervicitis. There might be other situations as well, and recently we've been talking about the fact that cervicitis can be of allergic nature, and recurrent cervicitis can be associated with unpleasant events such as mite or ticks, and they are not easy to diagnose, but attempts to do the diagnosis should take place. The clinical manifestations allow us to make the right diagnosis. Often we forget about this. For us, tests are the most important things. No first clinical manifestations. If there are no clinical manifestations of cervicitis, that means there is no cervicitis. There are not so many manifestations such as discharges from the cervical canal. Women sometimes may not notice them and have no complaints, but they do exist. Or light bleeding when you touch the cervix and the bleeding starts. So these are dominant signs. They occur in all cases. If there are no such signs, we should not talk about cervicitis. As for lab tests, which are recommended in our practice, and they must confirm our suspicions. I have already mentioned them. Well, STI tests, well, this can be molecular diagnosis or can be culture studies, specific methods, but we must be sure that there are no STIs, sexually transmitted infections. Also, the control of biotops in the vagina, vaginal problems have an impact on the cervix, and of course, they go hand in hand, and this will determine the treatment. In order to treat cervicitis, the vaginal problem should be solved, especially the inflammatory process of dysbiosis. Well, cytological tests should be done not to diagnose cervicitis, but to not miss cervical intraepithelial neoplasia in this situation. Our protocol states that this is a must, but it doesn't say that this is done after debriding. And of course, usually there are additional problems. Cellular changes may cause anxiety, and this is due to inflammation and not due to proliferative processes. As for bacterial cultures, well, and I should say that here we have a lot of doubts. Well, the culture taken from the cervical canal, what can we get out of it? There might be opportunistic pathogens that may not have a relation to the inflammatory process. Well, they may mislead us. They may induce the wrong therapy, especially systemic therapy, and often they are not useful at all. That is why hopefully we have a new draft of the protocol. We have also recommendations of our foreign colleagues. Well, culture studies are very expensive and not quite effective, like molecular tests, not to detect STIs, but to determine what particular opportunistic pathogens are there. Well, but this will not add up to the therapy. It will only cause problems. We should also say that no matter how hard we try to identify etiological factors in a particular woman, if she has no STIs, often we cannot do it. I have already mentioned this, and I will repeat again. Well, due to the fact that all our PCR methods and the culture studies can detect something, but not the major reason for existing of a specific pathogen. There are some other things which may not be quite good to our ear. What I mean here is that we have some specific results of scientific studies, the results of global knowledge, and here we can have the number of leukocytes. In our protocol, it says that the number of leukocytes cannot be the criteria for making a diagnosis. And I'm far from not paying attention to the number of leukocytes. I also pay attention to an increased number of leukocytes, but I do not know what is the normal range and what is the abnormal range. Well, 20 or 30, well, right now we don't have such figures because right now there is no proven boundaries regarding what is normal and what is abnormal in terms of the number of leukocytes in the cervical canal when there is an inflammatory process. First, we must pay attention to manifestations, then to STIs, and only then to the number of leukocytes. Often there might be another problem when there is the cytogram of inflammation. We have the cytological results, and the cytogram shows that there is cervicitis. It should be treated, but there are no clinical manifestations. In this case, when we just have a swab, we do not treat cervicitis unless there are clinical manifestations or some other criteria involved. Well, at least leukocytosis. In this case, we should not treat a woman when you only have the cytogram results. As a result, we structure the treatment. And what is meant by treating cervicitis? That means treating STIs. If you detect STIs, also treatment of STIs. If you suspect a woman is in the risk group, but you did not detect the infection, but you feel that there might be an infection, empiric therapy is administered. If not this, local therapy of vaginal infections using specific drugs, such as local therapy of vaginal infections associated with cervicitis. We treat either STI or the vaginal infection using wide-range drugs. So this empiric therapy using wide-range drugs is written into the protocol. It is very important because right now it is known that vaginitis in 90% of cases can be mixed in nature, and cervicitis can be the mirror of vaginitis, a spitting image of vaginitis. The story is the same. We do not know who is the main culprit. An aerobic flora maintaining the dysbiosis, and as a result of it, there is inflammation of the dominant flora, which is quite rare, or maybe candidiasis, or maybe a combination of mixed infections that lead to the development of inflammation. That is why we use wide range drugs. If we do not do this, if we treat using if we treat a woman using target therapy, if we do not see that the problem is multifaceted, we run into problems. And here you can see that starting from December to September, we could not treat a woman from cervicitis because due to the dysbiotic condition and inflammation, we administered drugs that did not cover all the existing pathogens, and so there should be a wide range drugs. Our protocol says this can be antibiotics, these can be combined drugs like antifungal drugs, or can be antiseptics. And I am focusing on this word antiseptics because antiseptics today are quite attractive. They attract a lot of attention of pharmacologists and clinicists because antiseptics is a real alternative to antibacterial drugs that can have a resistance developed. Why antiseptics are our priority in the future? Because they are polypotent and they have a wide range of action. So that's a big plus. That's very important. And also because antiseptics work that way that microorganisms cannot develop resistance to them. So resistance exists, but it's not significant. The probability of resistance is small. Microorganisms cannot find the ways that allow them to develop resistance to antiseptics. And antiseptics usually affect proteins, lead to the oxidation of the components of the cellular wall. And of course, this has already been proven as far as different antiseptics are concerned. Chlorhexidine is one of our major drugs used in obstetrics and gynecology. Why? Because until today, there have been no signs that chlorhexidine can lead to resistance. Not a single study showed this, and the situation is quite the opposite. There is a lot of evidence, modern evidence, that chlorhexidine has an impact in 100% of cases on anaerobic bacteria, gram-negative microorganism, gram-positive microorganism, on fungi. You can see chlorhexidine is very effective as far as different players of the infection process are concerned. That is why chlorhexidine has the ability to change the electric charge of the cellular wall, and as a result of this, the bacterial cell becomes kind of naked. Its somatic balance changes. It is full of water and it will be destroyed. But at the same time, chlorhexidine is absolutely safe for lactobacteria because they have enzymes that prevent the negative effects of chlorhexidine. This is a very important property. There is another aspect. Chlorhexidine can break biofilms. Just look here. It has been proven many times, together with other antiseptics. Chlorhexidine breaks different biofilms, and it works as an antibacterial drug, and also it triggers immune mechanisms. This has been proven in many studies. I can just give you a long list of different studies, evidence-based medicine randomized trials showing the efficacy of chlorhexidine in case of inflammatory dysbiotic processes of the lower urinary tract in pregnant women, in non-pregnant women. And today, this topic is under development. There are a lot of studies on this subject, the results of clinical trials showing the efficacy of chlorhexidine as compared to metronidazole or combined therapy has been proven. Good compliance is also marked among women. We must also remember that the inflammatory process and dysbiotic process mean the epithelial damage. In case of dysbiosis, we have the same key cells involved, and that means the epithelial lining is traumatized together with antibacterial effects. There is also a need of a reparative effect, restoration effect. I'm sorry, how much time do you need to wrap this up? Because you exceeded your time. I have 30 minutes. No, not 30 minutes, 20 minutes only. Sorry. Please continue. Yeah, I'm going to wrap this up. I'm going to wrap this up. So, a combination of antiseptics and regenerative drugs is a very important issue to restore the epithelium, and the pentanol chlorhexidine will provide not only for a bacterial but also reparative effect. Dipentanol has been used in our practice for several decades, but right now dipentanol has a new property which is quite interesting. That is the gene expression aimed at the healing of wounds. This combination of chlorhexidine and dipentanol is a very effective way of treatment and prevention of lower urinary tract infections, including cervical infections. And what is important is that we can use this on pregnant women at any gestational period. It is safe and effective. And on this note, I would like to finish my presentation. Unfortunately, I must say that the best antibacterial approaches do not solve all the problems, and in 30% of cases, there are still lab and clinical signs of cervicitis. That means a second or a third course of therapy is needed, or sometimes a surgery. So the problem of cervicitis has not been solved yet. He who climbs the mountain will master the road. Hopefully, through concerted efforts, we'll be able to solve this problem. Thank you. Thank you, Tatiana. Anything important you wanted to say? It looks like you said everything. Absolutely, I said everything. Sorry if I overran my time. That's okay. Well, I'll give you one more minute if you want to say anything else. No, no, I'm finished. Thank you. All right. Thank you very much. And I always keep my promise. Professor Felice Pellicer is going to join in. Due to technical reasons, Professor Pellicer could not do it. When there was a time slot for Professor Pellicer, the theme of the presentation is fertility preservation and endometriosis. Professor Antonia Pellicer.
Damian, for inviting me to this international meeting. The title of my presentation is Fertility Preservation in Women with Endometriosis, and I will try to convince you to perform this practice because, to my understanding, it's very important and we have data to show that. However, anything that I will present today has not conflict of interest, and therefore I don't have anything to disclose. Now, when it comes to infertility and endometriosis, we know that they have been related for many years. The possible reasons are not fully understood, some of them, others are evident, like mechanical infertility because of additions or because of hydrosalpinges. However, when we started to do assisted reproduction back more than 40 years ago, we started to realize that there might be other reasons why women with endometriosis are infertile. Inflammation and especially reduced number of oocytes, some endometrial dysfunction association with adenomyosis that is altogether an issue, and the quality of the oocytes might be affected in these women. Now, when we analyze what happens in women with endometriosis undergoing assisted reproduction, this is a meta-analysis from 2019 in which the authors analyze many different outcomes. But I'm showing you just one slide showing clinical pregnancy rates. And as you see, in women with endometriosis, it seems to be a significant reduction in clinical pregnancy rate, again, when they undergo ART. A previous meta-analysis from the registry of the American Society for Reproductive Medicine analyzed almost 350,000 cycles from the SART registry. And basically they found that in 11% of the cases there was endometriosis, but there were also other factors associated, especially tubal factor, male factor, and low ovarian reserve. And the bottom line and the conclusion from this study is that something that is quite evident in these women is that one of the reasons why the outcomes must be reduced is because the oocyte yield is reduced in these women, and they only found differences in outcomes as compared to women without endometriosis undergoing assisted reproduction only when some of the associated factors were present. Unless these factors were present, the outcomes were very similar. So oocyte yield becomes an issue, and therefore ovarian reserve in women with endometriosis becomes an important issue. Let me show you the next slide, because this is a beautiful slide published actually 12, 13 years ago. But this slide shows you that in cases with adenomyomas in both ovaries, ovarian reserve is affected just by endometriosis. There is nothing to do because the endometrioma itself will reduce ovarian reserve, and this will directly affect the quality of the eggs, but especially the number of eggs retrieved and the outcomes of assisted reproduction. But the point I'm trying to make is not this, because in this case we can do absolutely nothing. It's already done when we find the patient with such big endometriomas in both sides. The problem is highlighted here in this slide, in which it was asked in different hospitals also 10 years ago, what do they do when they find an endometrioma? That were general hospitals. And if you can see here, if there was a district hospital, a university hospital with IVF setting or without IVF setting. But the bottom line is that in most of the cases, the cases were solved basically in 80% of the cases performing surgery. And what happens if you perform surgery in a woman that has an endometrioma, that you reduce the ovarian reserve, even if you are the best surgeon? You can use different techniques. We know that electricity, bipolar or monopolar cautery is the worst, but even though it's easy to removing the endometrial cyst, to remove some normal tissue, and in the end several meta-analyses have published that you can reduce the ovarian reserve up to 40%, and I personally have seen women who became totally menopausal after being operated because of ovarian endometriomas. So this is a serious concern. And the most important thing is that you don't need to remove the endometrioma before doing assisted reproduction. So there is no reason. The only reason is that we don't know and this is the message I'm trying to send to you today, we don't know how much we can harm the woman removing that cyst before assisted reproduction. Because if we compare women undergoing IVF in whom the endometrioma was removed versus non-removed, you see that the pregnancy rates are the same. So there is no need. And the only thing that we can do is to harm the ovarian reserve, and this has serious and consequences. Now, the other point is about egg quality in women with endometriosis. This is interesting. Obviously, the variable that is going to affect most egg quality is going to be age, also in women with endometriosis. But there are many publications that have shown different features that are characteristics of eggs with or follicles with endometriosis, like folliculogenesis alterations, increased reactive oxygen species in the follicle, spindle abnormalities, alteration in the number and function of the mitochondria. A recent study that was published in 2019 pointed out to 4 particular cell functions that are affected. This study is particularly relevant for me because it's the first time that single cell messenger RNA analysis technology was employed. And in this study, it became clear that the steroid metabolism in the oocytes of women with endometriosis is affected. It is also affected the regulation of cellular proliferation, the affected also the cell cycle, and in the end, and I recommend you this review, you can find many reasons why in women with endometriosis the quality of the oocytes might be affected. So the message I'm trying to bring here is not that women with endometriosis will not get pregnant. This is not true, and you have seen the meta-analysis before, and you will see other data. The message I'm trying to convey here is that if we reduce the number of eggs and the quality of the eggs is affected, in reality, we are decreasing the chances of this woman to become pregnant. Therefore, 2019 pointed out to 4 particular cell functions that are affected. This study is particularly relevant for me because it's the first time that single cell messenger RNA analysis technology was employed. And in this study, it became clear that the steroid metabolism in the oocytes of women with endometriosis is affected. It is also affected the regulation of cellular proliferation, the affected also the cell cycle relevance. This first study was published in 2020 in Fertility and Sterility, and includes almost 500 women aged 36, more or less, who underwent fertility preservation having endometriosis. Now, of these women, as you can see, basically 98% of them had severe endometriosis, stage 3 and 4. And when they came to us to preserve fertility, half of them have gone already surgery and the other half not yet. So we could compare operated versus non-operated women. And analyzing the data and just analyzing for you, because the paper, the reference is here and you can check all the data in detail, but if we want to compare the effects of surgery, previous surgery on outcomes, we go to women under 35 because in this sense we eliminate an important variable as age. And as you can see here, no surgery as compared to surgery, obviously the number of eggs retrieved was higher. Pregnancy rates were also higher, 55 versus 44, but no significant. But the cumulative pregnancy rate, which is important because in reality these women want to build a family, you can clearly see that were higher in women who had no surgery before, which is obvious because we had more eggs. Now, when it comes to survival of these eggs after freezing and thawing, I want to concentrate also in women under 35 and compare the survival rate in endometriosis as compared to elective fertility preservation. Elective fertility preservation is the control. It could be also egg donors, but we use elective fertility preservation, young women who come to us to freeze the eggs, period, without any pathology. And if you compare, there is a significant decrease, almost 6 points in endometriosis as compared to early fertility, to elective fertility preservation. And to my understanding, that means that the quality of these eggs is affected. Now, however, if you freeze the eggs and when the eggs are thought survive well, and the percentage of those which have survived are fertilized, then this is the cumulative pregnancy rates, actually live birth rates, according to the number of oocytes that we were able to freeze. And as you can see here, fertility basically is not affected. You need many eggs. So again, do the retrieval before surgery, and also is comparable to elective fertility preservation. But again, what we are comparing here is oocytes that were inseminated, fertilized. We lost 6% of them because they didn't survive freezing and thawing. So to conclude, I would like to let you with the following messages to take home. One general consideration is that endometriosis is associated with infertility. We know that. We also know that there are mechanical reasons, additions, hydrosalpinx, no question, but from ART we have learned different lessons. Today I wanted to focus on oocyte numbers, oocyte yield. Another day we can focus on adenomyosis or oocyte quality. But oocyte numbers are relevant because this is the most prominent factor observed in these patients, quite constant, and also is like this because many of them have been operated. And today what I have shown you is that you should not operate these patients. If they have an endometrioma, you should freeze eggs before surgery because you are going to, we have a strong evidence and it's published, and I have shown you that you not operating the patient, you increase the outcomes or the fertility rates of these patients. And I think this is of paramount importance. Obviously, it should be at a younger age because age affects outcomes in endometriosis or in no endometriosis. And also, I have shown you that these Kaplan-Meier curves, which are very important because are very interesting to counsel our patients. Because the patient will come to you and you propose fertility preservation, they ask you, but doctor, how many eggs do you need for me to guarantee in the future a pregnancy? And here in this paper published in RBM Online, you have the answer. So you have here the reference, you have the answer. So keep this data in your files and advise properly your patients. No surgery of endometrioma before preserving eggs. This is going to be of great help to your patients. Thank you very much for your attention.
Well, dear colleagues, I'd like to say that Mr. Pellicer is a great specialist. Unfortunately, it's not possible to do it in all cases because when there are endometriomas, there are indications for surgery, and in some cases, you cannot postpone surgery. As for this particular subject, in 1976, I remember when we started our program of in vitro fertilization, IVF, together with Professor Leonov and Dr. Lukin, we studied oocytes during laparoscopy when there were different benign diseases, and in 1976 we published some data showing that there was a reduction in ovarian reserve and the quality of oocytes was low. Many degenerative forms in patients with endometrioid cysts. To our great sorrow, we did not find an answer how to get rid of endometriosis. Dear colleagues, I am absolutely sure that you liked the first day of the Congress. We have exhausted our program. We had live surgeries. We had presentations, which are worth of the high grades. It was a long day, but by the way, we did not overrun our time. We finish our Congress on time. Tomorrow we start at 8 o'clock sharp, and we will have Armando Romeo, who starts his suturing course. Well, the course by Professor Romeo, then Mario Malzoni will have live surgery from Rome. After this, we start our plenary sessions. There will be more surgeries, live surgeries by Dr. Bitocchi, Dr. Bigatti, Dr. Jean Amou, and there will be presentations on hysteroscopy. Tomorrow is another great and fantastic day of the Congress. It was a pleasure for me to be with you as well, and our team from the Kulakov Center, that was of great help. Also, the team of RIA Novosti and the team of Media Expo, and also my students and my family. See you tomorrow at 8 sharp. Goodbye.